Good morning and a very warm welcome. Distinguished guests, delegates, participants, and partakers. It is a glorious moment to extend my warm wishes and welcome each one of you to the Haemophilia Conclave 2024. This meeting has been organized by the Haemophilia and Health Collective of North under the aegis of Maulana Azad Medical College and Lok Nayak Hospital, New Delhi, in association with Haemophilia Advocacy Society. This gathering is not just a convergence of individuals, but a celebration of ideas and collaborations. Now I would request Dr. Naresh Gupta sir to please come on the stage for the welcome remarks.
Good morning, everyone. I would like to invite our guest of honor, Mr. Bhupender Singh Bhalla, who is a member of Indian Administrative Society and also a secretary of Minister of News and Renewable Energies, Government of India. I request you to please come on the dais, sir. Dr. Poonam Narang ma'am, who is Dean, Maulana Azad Medical College, whose leadership has been truly transformative and is a pillar of strength. Ma'am is not here, sir. Okay, ma'am is on the way. Let's welcome our next guest, Dr. Naresh sir, who is the chairperson of Haemophilia and Health Collective North, who is also a medical consultant and advisor, Haemophilia, Maulana Azad Medical College and Lok Nayak Hospital. I would also like to invite Dr. Prem Roop Alwa sir, who is President of Haemophilia Federation of India. We welcome you to the dais, sir. Dr. Sunita ma'am, who is Director Professor, Maulana Azad Medical College and also Secretary at Haemophilia and Health Collective North, in charge of Haemophilia Daycare Center and also in charge Hematology Clinic, Maulana Azad Medical College. Welcome to the dais, ma'am. Dr. Kanjaksha Ghosh, who is an eminent hematologist and also a well-known personality in the field of internal medicine and hematology with numerous publications and awards. Welcome to the dais, sir. We will also like to invite Dr. K.K. Kaul sir, who is President of Haemophilia and Health Collective North. Welcome to the dais, sir. I would now like to request Dr. Naresh Gupta sir to please come for the welcome remark.
A very warm, no, not very warm, very cool good morning. I hope you traveled well and you have taken rest during your journey, or if you came yesterday during the evening here in Delhi. I hope the stay was comfortable. We will have a full session today from morning till evening. So I welcome you and I want to speak a couple of words about our society. Before that, I would like to make an apology and a correction. Mr. B.S. Bhalla, Bhupender Singh Bhalla, is a senior Indian Administrative Service cadre. Presently, he is the Secretary to the Government of India, Renewable Energy and others. He is a very upright person. Upright, I mean, he is connected with health in some ways he was our principal secretary health for some time, and anybody and everybody who has seen him find him very, very thorough and clear and clean. We were speaking yesterday, Vandana I don't see today, we were speaking yesterday about the challenges that we face when we have to get something from the administration. He is the source where you won't face any challenge. So the reason is not only because he was with health that I invited him, health department. We also invited him because he is an embodiment of health. Couple of weeks back he sent me a message. His renewable energy ministry is doing a marathon run. Run for fun on the sun day. So the Sunday falls on 3rd of May, and he organized it himself. And it was from Jawaharlal Nehru Auditorium. When I went there, he came in his humble manner, in his own humble car, in his own humble way, and then I came to know that I've been running marathons for some time, but it was the first time I saw a person who is flagging it off, running the marathon through and through. Now he is taking it further, and on 9th of June you can join. He has escalated this marathon. He also has been health conscious because during his tenure in some areas, Damandiu, he created these jogging tracks. This is really remarkable because times have changed. When I joined the institute, AIIMS New Delhi, it used to be All India Institute of Medical Sciences. And Tulika will tell me it still is All India Institute of Medical Sciences. Only once I think our health minister made a mistake of calling it All India Institute of Political Sciences. Shri Rajnarayan. The times have changed. For half a century, medical has changed to health. In fact, we have changed our primary centers to health and wellness centers, PHCs to. The ministry's name also has changed to health. But I find all these institutions don't work towards health. They work towards curing medicine, not treating, not even curing kind of, giving treatment for medical diseases. And that is one of the dilemmas I think, sir, this forum is facing, because whenever it comes to giving a treatment on a regular basis, they are at a loss. For diabetes, we give insulin as a replacement and nobody says don't give it. But for hemophilia, where the missing protein is not insulin but clotting factor, everybody says who will pay for it. And we are also conversant that there is not a primary stress on preventing it. Like vaccines are kind of kept secretly guarded. You know, you pay for it only then you take it. If you get influenza, we'll admit you in ICU and give you free care, in Delhi at least. So the health concept has not actually pervaded the medical science. And I think that is something that hemophilia teaches us, that if you want to speak of health, treatment alone is not enough. You give treatment, you will make them free of bleed, you will make them free of complications, but that in the mind of WHO is not freedom from disease, is no good health. So we need health, and sir, we are happy to welcome you here. We started hemophilia in 2007-8 under the direction of the Honorable High Court of Delhi. When the matter went up there, it was against the governments. And then it came up that it's a very specialized kind of a care if you really want to do justice. And the mandate came upon us in New Delhi in Maulana Azad Medical College. That time when we started the treatment, the problems were patients. It's an expensive treatment. Patients, not only the faculty, but the delegates also. And there are 51 faculty from Delhi and outside, more from outside than from Delhi. We want to hear them. And they would be covering 98 faculty sessions during this 1.5 days. So I think that is the origin, and I think we are doing well. There is a difference between delegates and participants. We are all delegates here. And we have a message for, we have actually freebies for delegates. Where is that? Oh no. Yeah. These are the freebies for the delegates. Please communicate areas of your interest, your neighbor's interest, your colleagues' interest for active participation and collaboration and contribution to the initiatives of Haemophilia Collective and Health Collective of North. Communicate any topic you would like to be included. Submit your feedback. Please do submit your feedback and suggestions and constructive criticism, and share the coordinates of others who might be wanting to contribute. And I am happy to share.
Good morning, everyone. Now I welcome forward Dr. Kunjangsha Ghosh sir to give us a few words of wisdom on changing landscape of hemophilia care in India. Thank you.
Good morning, Sri Bhallaji, the dignitaries on the dais, and my colleagues, delegates who have come from all the way from different parts of India to attend this meeting. I have been given the onerous duty of just communicating you in few words that how the landscape of hemophilia care has changed over last 3 or 4 decades. Partly you have already heard Dr. Naresh Gupta that how things were in 2007, but before that even the hemophilia care itself has evolved across the world, and India was falling back mainly because of the treatment product and also because of the lack of proper infrastructure and adequate manpower in this area. First and foremost of all is, over the years what has happened, there has been effort to develop the diagnostic abilities of the hemophilia in the country. Here we have made reasonable progress. We can say only about 10-15% of the progress what is needed. But for diagnosis itself, because you will know it for knowing that we have only diagnosed only about 30,000 PWH in our country, that is people with hemophilia, whereas we expect that there will be at least about 2 lakh, 1.5 to 2 lakh hemophilia patients or people with hemophilia across. But where are these hidden hemophilia patients? They are actually hidden because many of them are bleeding in the villages, in the talukas, in the other places. They are being treated in different ways in different part. Somebody may be initially treated as we were having some joint problem, gout, arthritis and all this. Then when bleeding comes in, then they say there is some other problem. So what has happened in all these times, the coagulation laboratory is one of the crux of diagnosing the hemophilia patients. And unfortunately, it is not like any other laboratories, because the blood on which the coagulation proteins are there, some of them are very labile. That means they will not stay for a long time stable in the blood unless you investigate them quickly or quickly freeze the plasma so that it can be diagnosed in a convenient time. Now, once we consider that we already have more than 600 medical colleges and about 750 odd districts. So if we restrict these 2 areas, that is about 1300 units across the country, where at least we should have expected a coagulation laboratory to be present. But over the time, what we have been able to do, or what India has been able to do, Bharat has been able to do, that only 15% of these 1300 establishments do have something like a coagulation laboratories, which are not, many of them are not of good qualities. So future, so that's where we stand in terms of diagnosis. Now, as Dr. Naresh has already alluded to, that our idea is of health, not only of absence of disease. Now, the concentrates which we are talking of, the main product through which we treat the PWH, there is a, though across the India, different states and centers are slowly, after 2008 or 9, Delhi High Court order, and then subsequently another 10 or 11 High Court orders, the various states have started providing the product. But this distribution is not uniform, because health is basically a state subject, but it is there. What was not reaching at all to all hemophilia patients in 1980s, now identified hemophilia patients are basically getting the product. One of the ways this has happened, and this has been made possible, is through the agency of the patients organization, that is Haemophilia Federation of India. This patients organization actually also have done a lot of advocacy, and at present they have almost 100 plus chapters across the country, where because this is not a very common disease, so the hemophilia patients have aggregated in these chapters, and they basically are integrated through the main office in Haemophilia Federation of India, and they are in a way as the support, as the patients group, and also the group which informs doctor as well as the administrators that what is required for them. We have always heard about product and product and product, because product is very important, and actually without that you cannot treat the patient. And we do have at present product which various government purchases, also products which we get as a donation or gift from World Federation of Hemophilia, because the patients organization is a sister organization of that. Plus this patients group also purchases some factor for emergency purposes. So these are the various ways the factor reaches the PWH, and occasional patient also do buy the product from themselves. But this is what is happening, as it happens to many other medicines in our country. Often the supply of this product is not continuous. Like you may have product for 4 months continuously, then probably 2-3 months there will be no product. So that is the landscape at present where we are standing. In various states there are only 1 center or 2 center where these government centers where these patients can be treated or can be looked after, not spread widely across, so that patient can easily access many of these places. Yesterday we heard Dr. Kaul, who comes from Jammu and Kashmir, and this is not different from many other places of our country, where many of his patients come far up mountainous regions, and they cannot come very often to the centers where treatments are possible. So there the product, it is not such that you can give lot of products to them to their own homes so that they can get their own treatment, or we can give a product which has which can be given less frequently but are more costly. So this is where we stand, and there has been a plethora of products. So there is a need for the government also to get the advice from these bodies, means patient bodies, as well as who are experts in these, and make a sort of an optimization by which this product can be purchased. One of the things which has been many times voiced by these patients, the doctors who are looking after them and the patients group, is that because the purchase of this product is basically done through the money which is disbursed by National Health Mission from one site. One of the major requests has been that why not National Health Mission itself organizes a nationwide kind of tendering or discussing or purchasing the product, that we have 30 states, union territories, some more other areas. So total requirement can be pulled into one way and a committee can be made, and basically then if so many states requirement are put in one tender, then government is also will be in a much more leveraging capacity, where it can get a product in a much cheaper price, and it can be done. So this has been one of the unmet kind of in our landscape requirement, and this will also assure that the product is continuously available to the patient, because it can be distributed. Another thing is in the distribution bottlenecks. Distribution bottlenecks are there, which even though the product is there, maybe many places, because it is not easy for the product to go from one hospital to another or one district to another. Suppose one district has the product in the same state, but another district has already consumed it, and now the district where the material is not there now requires it. But the surplus district is not very easily transferable from one place to another, these products. So these are some of the bottlenecks which are regional areas or regional problem which needs to be concerned. Now, who runs these laboratories? As I said, that at present, because when we were trained, there were 6 centers or 5 or 6 centers in India where coagulation laboratories were there. Of that, there was School of Tropical Medicine in Calcutta, there are All India Institute of Medical Sciences in Delhi, PGI Chandigarh, which was there. In Mumbai, there was the Nair Hospital and KM Hospital, and Dr. private labs were there few. CMC Vellore, of course, was there, who were doing the factor assays. This is all, and maybe 1 or 2 we have missed. Dr. Dubey's lab in Benares Hindu University used to have a lab where they used to assay the factors. So there were couple of labs which you can actually count in your hand. That was in 1980s. And at present we can say that at least we have about 150 labs where we can do these assays. But we require at least about 1400 if we have to go to each of the district, and each of the medical colleges have these coagulation labs. So when we are asking that this is the condition at present, and we are asking these laboratories because more hemophilia patient needs to be diagnosed, and they are remaining undiagnosed in the periphery. So there had been voiced whether we can have a patient side kind of test grossly to say that this patient can have coagulation problems. So to that, Indian Council of Medical Research has produced a kit, but again by the time the kit comes to the market and this is widely available, it may take some time. Now we are talking that we need so many labs. So these labs actually eventually will need good technicians to run this lab. I am not talking about the money required to furnish these labs, because instruments, reagents, they probably can be done much easily by the government by given one-time grant. But the other part which is more difficult is to provide a good technician, or so each press will take at least 2 technicians and a doctor who can supervise this, and a doctor who will be on both sides, right? Like suppose a hematologist or a trained doctor like that. We are producing around, at present the landscape is such that we are producing around 150 odd hematologists in our country every year, and if we consider that all of them will be absorbed into the job, then to get into this 1400 jobs, we will need probably another 8 or 9 years, so that, and probably very efficient placement in different places to get that, but many doctors will also not go there, so we have to understand how things could be done. So this is about the manpower and diagnosis of hemophilia. When we said coagulation lab can be of various complexities. At present, I am talking of medical colleges. Medical college should have a lab which will do most of the investigation, and district should have a lab which will do at least simple investigation to know that this patient has the coagulation defect. When we have discussed all this, the main problem is that people will say, oh, hemophilia is not such a common disorder. Why are we going to spend so much money for the lab, manpower and all this? This we have already repeatedly said that a coagulation lab is not only for PWH. Blood coagulation problem happens in many disorders. Surgeons often face it in operation theatres. Gynecologist is facing it every day and night. Medicine, there are many conditions like liver disease and other where bleeding problem is an important problem. So actually it should not be requested, it should be automatic thing for any reasonable hospital to have a reasonable coagulation laboratory. So that is one part. We have progressed, but not enough, we need to go there. About product, we have discussed. Now question is the product enough? Product and doctor is enough? No, because we said that many of these people actually have, just because he is hemophilic does not mean that he will not have other diseases. Plus, because of hemophilia, he will also have conditions related to this bleeding tendency. Now, anybody with, if we can say, like suppose a patient has a hemophilia and he bleeds in the brain. So he has a problem which is of bleeding plus neurological plus neurosurgical. He might bleed in the gastrointestinal tract. He might have chronic hepatitis because of various transfusion and other types of problems. So now we are coming for basically a concept of a hemophilia treatment center, comprehensive hemophilia care, and places where hemophilia can be holistically kind of treated. So these kind of centers like comprehensive and high level hemophilia care centers are actually needed in every state, and at least more than one center in every state. And hemophilia treatment center of course is needed down to probably a taluk hospital. So these are the areas where we have to go. At present, as I said, we have reached 10% of it. Then question comes that any country cannot do anything without statistics, because whenever you go to the administrators, health administrator, they will ask how big is the problem, how many of your patients are, can you name them? So that actually needed what we called a registry, that where every hemophilia patient's name, address is there, and you know where are they and how are they. So there are various different kinds of registry. We are not discussing about that. We are now discussing about a registry which is just recording that we are having so many hemophilia patients, this is their address and this is where they are. To that effect, the Haemophilia Federation of India and St. John's Medical College together, they come up, and one of the PWH himself has given the software, and a sort of registry has been made where I said that 30,000 hemophilia patients' names and addresses have been registered, but this is not a dynamic registry, and it has been requested, like I am a person from Indian Council of Medical Research, so we have requested many times the Indian Council of Medical Research to take over this registry. So at present things are there. The ICMR has agreed, things are there means it is already 2-year-old. ICMR agreed that my institute in Mumbai, AIMS and PGI, they will decide, there will be a registry between these 3 centers, which basically will cater for the bleeding disorder, sickle cell anemia and thalassemia. So these 3 important blood disorders have been there, will be discussed. transport was a problem, and in mid 90s it has been sorted out when Laluji was our railway minister, and the organization has been able to get concession for the PWH for transport, for railway transport from one place to another, with 2 of his attendants who get the hemophilia goes, the PWH goes free, and 2 of the attendants pay 25% of the charges. But this has not happened at present for all the transport, government transport across the city and other places, where that is also something which can be considered for these patients. The PWH, as we have been said, that they can live a totally normal life if they are managed, and it can be seen that many of them are now becoming lawyer, many of them are becoming business management graduates, quite a few of them are in medical field, some of them are working in other places, they are becoming doctors, engineers. So give them the chance, give them the ways they can live a really normal life, so that we should keep in mind and we should do the thing. Physiotherapy is a very important part of hemophilia care, and as I have observed in northern India, there is a general tendency of the person to become little bit obese in course of time, and this obesity is going to be a problem in future problem in hemophilia, so that also needs to be tackled. So product, laboratories, the comprehensive care, and spread in other places. We are now we are standing at actually a point where things can happen much better, and I think the administrators should come up and lend their hands, and we can make this place a much better place for PWH. Thank you.
Thank you, sir. That was a very informative speech. Now I request Mr. Prem Rupalwa, sir, President of Haemophilia Federation of India, to come forward and give a speech on the evolution of hemophilia care in India.
Thank you. Namaste and good morning. I'll keep I think Dr. Ghosh covered quite a bit of which I was trying to say. I'll keep it very brief. Haemophilia Federation India was established in 1983. Only vision those days was to unite people with hemophilia. There was only 3 organizations which became a part of HFI, which is Delhi, Kolkata and Trivandrum. Those days we were actually practically putting up advertisements in Bangalore. I met Dr. Cecil Ross through an advertisement saying that yes, there are hemophilics in the world. There are other hemophilics in India. Okay. And then we used to hear, okay, that there is some medicine which is called the factors. Okay, and the factors is a miracle drug. You give factors, pain goes away. Came the 90s, more chapters happened, and then the suitcases started coming in of factors. We practically were going abroad, bringing suitcases of near expiry medicines and expired medicines, and we were treating people. So this was when I see the slides of 1970s, the factors were there internationally, everything is very good. But in India, the scenario is very different. 90s is the first time we saw anything called factors. And then little later in the 90s, one pharmaceutical company came into India. Okay. 2005 was a transformation year with the government of Karnataka providing some kind of a treatment. Again, just one pharmaceutical company, it was a single tender, and it was plasma derived medicines. 2007, Delhi started giving treatment. Delhi treatment opened the doors to the whole of India. Delhi is the gateway to India, and then we were going state to state and saying, okay, Karnataka is giving it, Bihar is giving it, okay, Delhi started giving it, okay, see this, okay. Please, why is your citizens being denied? Within India, we are talking about within India, we are talking about going to each and every state and saying, look, those guys are getting it, why are we not getting it? Slowly, more and more, by the end of 2016, most of the states in India were giving treatment, and we started seeing recombinant medicines, third generation recombinant medicines. Now in 2022 onwards, we are getting a whole lot of products. So what we could not imagine, and any of the doctors, I'm sure most of the doctors here and myself as a PWH, we could not imagine the shift and the transformation from blood product to the products available right now. There is a shift in entire India. There is a shift in thinking that the products which are being manufactured right now internationally, the best product, long acting, non-factor therapy, everything, accessibility is there, which was not there earlier. There's a big shift. Government is giving medicines. Okay, government has started giving medicines, and we are striving for something called one country, one treatment. Presently, we are very thankful for NHM to have included hemophilia and hemoglobinopathies, and we are put into a blood disorders category. We are recognized by the social justice. We are considered as a disability in India. Fantastic. We are getting home treatment in one part of India. We are getting prophylaxis in one part of India, but most of the states, most of the districts do not have treatment. There is goods. Okay, it's like two Indias. There is a very good side, and then there is a side which can really develop. And we are, as Haemophilia Federation India and a person with hemophilia, I am very, very, very thankful to most of the leaders and most of the administrators in this room present here to come and join us and improve care year on year on year. The need is, even I met the ministry 3 days back, asking for a policy. What we need and what we need to work is, and I genuinely believe that this is a fantastic time. Election is around the corner. There may be a new ministry, the new establishment, new secretary. We have to hit at a proper policy. Only when we have a very strong policy will we have unified care across India, and that's what Haemophilia Federation India wants, and that's what we have all strived. We have gone state to state. We have seen different eras of hemophilia's life. And I'm very thankful to Haemophilia Conclave, Naresh Gupta sir and all, because he's already a step ahead. He has created a policy. Okay, we need the, I was telling the government that I'm not asking you for a policy. I'm asking you to bring a group of doctors from your own setup. Okay, your own system who have been treating hemophilia from 2016. From the states, every state has an expert in hemophilia today. Thanks to that. Okay, and bring them together. Let's at least start by bringing the doctors who have been treating from years to make a policy. And they have been positive, and I'm hoping that the new government and we will have a policy. Thank you for supporting us throughout the years. Thank you so much.
Now I request the members of the dais to come forward for the release of the Haemophilia Health Collection of Note Policy Statement on the Haemophilia Care in India.
Booklet. So HHCN has decided to come out with a policy statement on how they envision the problem and how they plan to see it getting sorted out, which country.
Now I request Mr. B.S. Balla sir to come forward to give a few words of wisdom.
Dr. Naresh Gupta, whom I've known for a very long time, all the esteemed delegates, dignitaries on the dais, off the dais, doctors, if there's any other not a doctor here, so I'll like to welcome them also, ladies and gentlemen. I'm neither a doctor nor an engineer, so I'm a very odd man out as far as this meeting is concerned, but you know, Dr. Naresh Gupta is one of the finest, not only gentlemen that I've ever met, but also one of the finest doctors that I've met. So once he requests, and I think everybody agrees to that, whoever knows him would agree to that, and therefore whenever he has requested me to join some gathering or a meeting, I've never declined, except when, of course, when I'm out of town or otherwise. So it's a pleasure to be here. My knowledge of medicine is limited to what I learned, of course, as a patient, mostly as a patient, but also during the time that I've handled health administration as Commissioner and Secretary and Principal Secretary, ACS, not only in Delhi for some time, but also in Andaman and Nicobar Islands as well. I also was fortunate to head the Union Territory of Daman and Diu and Dadra Nagar Haveli, 2 Union Territories, as the administrator, where of course I was handling everything since I was in charge of the territory. So I've had a experience of managing health, public health, in 3 Union Territories, including Delhi, and that's been quite a privilege. So my knowledge is largely based on my experience in that tenures, and that has ranged from, from 2011 to a couple of years ago when I was in Delhi. What I learned from hemophilia is, of course, in sessions like these, and what he has briefed me earlier when I was handling health. It's a unique disease. It's a congenital disease. I think the main thing is identification. As you're aware, of course, the number of people compared to the population, the number of people likely to be affected by this disease who are born with it, are very, very small in the sense of percentage terms. But whether we are a nation of 140 crores or there are other countries which have 10 million population or 5 million population, I think the process is the same. We need to start and identify whether a person has such a disease right whenever we are screening that person at any point in time. And I think, of course, now that when you launched this program, as you mentioned, about 15, 18 years ago, that time was more of a push effort in the sense of starting it either in Delhi or Bihar or Kolkata or Karnataka, as was mentioned, who led the way. But I think it's important to have a system as a country, whether it's a union territory. I was trying that in the union territory of Daman and Diu and Dadra Nagar Haveli. Whether you start in a district or a taluka, or whether you expand it across the country, the process is the same. And it's not only hemophilia. I think we need to have a system of screening the health of every citizen of India, every resident of India, through a regular process. And how it can be done is, it's actually very simple. The only thing is the time and effort involved in setting up the system and having a mechanism which does it as a matter of routine and not as one-off campaign. So now, you must have heard about Ayushman Bharat, and that is what I think the digital mission, involves. Essentially, Ayushman Bharat digital mission now is what it envisages, and what we were envisaging in Daman and Diu 10 years ago, and what we were thinking about in Andaman and Nicobar Island 10, 12 years ago, is screening every resident and every citizen in general, and making sure that every citizen is surveyed. There is a house-to-house survey, or whenever the person comes to a health center, there is an evaluation of whatever symptoms the person has, and thereby from there on then you build upon it and figure out what could be the possible disease that the person is suffering from, whether it is temporary, it is only a short term, it gets cured like cough and cold, or whether it is actually there's something different. I mean, maybe the lung needs something, if it is a long term thing. So that's the kind of thing which needs to be done. And now we have the technology to roll it out, in the sense that the intention of the government, and I would just mention that it doesn't matter which government is here. This government is government. It is the political leadership which could change depending on the election, and the election is a matter of fact and routine across the country. We are a democratic nation, and if you travel across the world to the nations which are not democratic, then you realize how lucky we are, how fortunate we are in India, that we have the system of deciding what the political leadership of a state or a country can be. And the political leadership may change, the overall messaging may change. Every political leader who comes has some ambition, some goals, and that then evolves into some policies which would support to make sure that the objectives are met. But it is larger bureaucracy, which is permanent bureaucracy, the permanent government. We are the ones who give suggestions of what is possible, and it doesn't matter whether elections are held or not. We try to work on it, on what we think is the best for the country, for the department we're dealing in, and also what we can do, what is the innovation we can do, what are the new things we can do, and how best, even if we are not innovating, we are already doing something, how can we do it better? How can we achieve the same results or better results with least expenditure or with optimum budget? So we are always trying to figure out something new. And I'm quite sure that the Ayushman Bharat Digital Mission, and I'm sure many states have actually done it earlier. It's not only that the national government of India is doing it now on a national level. Many states have already done it at their level. Many district collectors have done it in their own districts because of their efforts. The only difference is, if I am doing it in isolation in one district or in one taluka, because I am innovative and I want to do something new, there is a young officer who wants to really do something well. You've heard of examples. If you read the newspapers, you will see so many examples of young officers at district level and all kinds. It's not only the collectors. Every field you have brilliant people who are doing something out of the ordinary. They do something different. The question is, are we building upon an existing knowledge that we've created in that area? So, in my view, as far as the health is concerned, which is what Dr. Ghosh was mentioning, how do we start the process, how do we identify, what are the things, skilling and so on and so forth, and how do we evaluate and how do we give treatment. I think the first thing very important thing is identification. That's very crucial. One is identification at one point in time across the country, but also then is in future when the kids are born, and then continuous evaluation of the new generation which is coming up. So we always have a database of every citizen in the country of what he or she is suffering from, and what are the what are the unique features of that person which need to be treated, or something adverse should be treated or not. And even if there's nothing there, I mean, let's say 60% of the population, 60, 70, or even more population has nothing to report. They come to health center only occasionally once in 2 years. Absolutely fine. At least we would know the health of 70, 80% people if we have that data. And I think it's important to, it's very easy. It's important to make a layer, literally a layer, a data of each individual captured on a regular basis at one place. And that one place is the most important. I mean, Karnataka can do very well and have it in their database, but at the national level, if you don't have it, now that Karnataka, if he travels to Mumbai to work, and in Mumbai he goes to a hospital, instead of carrying his whole record, so that medical file, 50 pages, can that just the doctor in Mumbai just access this, because that is a unique database which is available for every doctor to access, provided of course the patient allows that, and that's how it should be. So I think it's very important to first create a network, what the government is now doing, and that's the aim. In fact, I'm a CGHS beneficiary, and I got the message the other day that you have to register as a ABHA, take a ABHA number, Ayushman Bharat. There's a number which is to be taken, and the essence is and that's how it should be done. It has to be mandatory, whether I am a CGHS beneficiary or not, or whether whatever you are doing. If you're going to a private doctor, if you're going to a hospital, you must have a unique number. You must have a number, a unique national, like Aadhaar based. Aadhaar is one way of how we have integrated, the identities of everyone. Unique identities. We know we can tag you, and I can pull up information based on Aadhaar. Since Aadhaar is not compulsory, but at least health information is something which should be definitely be something, a database should be built using a system like this. And that time, I think if we have first the digital base, second is a universal way of surveying, identifying and screening every person in India at one go, gradually, but at least once. And then you build upon it, and whenever the person comes to next time to a health center or a health clinic or a hospital, and then you build upon it, keep building upon it. It's also important, same hemophilia, as Dr. Ghosh was mentioning, not everybody would know in the rural areas, in maybe even in tehsils. Some health care professionals may not even know, because they don't have the expertise, apart from your national conclave that you're doing. But that information has to flow to the state level, it has to flow to the district level. That knowledge base has to be there, and I think that's where capacity building of doctors and all healthcare professionals is important, which your organizations are very ably doing. But of course, the states and the union territories must get together to support this. And I am of the opinion that if you really pitch it well to a state administrator, whoever the secretary or director of health or whoever it is, I don't think, because everybody is trying to, the main goal is to actually address and the health concerns of the state, and I think it would be something which would definitely be taken forward. But building upon it, I'm just taking it forward. I mean, hemophilia is one disease which you're talking about today, but I'm sure there are many other unique diseases where only a fraction of people suffer, and we are not aware. And probably the same thing would happen. So every professional, every healthcare professional at the tehsil level or district level may not be aware of all those 100, let's say, just for discussion's sake, 100 such diseases. So how do we then have a system of identifying the potential patients and people who are suffering from all those 100? We want to talk about all those 100. Why only one? So I think what is important is building a tool which should be part of the screening at the local levels. How this, I'm talking about the Ayushman Bharat digital number unique database of every individual. So we should have tools which raise their flag of what the person could be suffering from. If they have one or two, if you say yes, then a follow-up questions on what it could be, and therefore possibility of A, B, C and D, maybe four possible diseases the person could have, nobody is aware. Then that flag could emerge, and then we could have a system of rolling out a follow-up screening of the person through a specialized, through a campaign mode, and not only identify. Why I'm saying that is that making a lot of effort for one disease would not be that fruitful, and it would not be a consistent effort. But if you do it in a systemic way, where we set up the screening and have this questionnaire kind of a thing, where it could then possibly lead to us to decide whether yes, the person could have this or could have that, and maybe in that village then we realize that there are not only hemophilia patients, but there are also these 3 other individuals who have these unique diseases which only at the national level we've been thinking out, and probably not even at the state level. And that is, I think this is what is very important as we go forward, and that's how I think it can be done. When I have a discussion with the Health Secretary in India, I will definitely share this now that I've got the opportunity. But I think these are my 2 bits of wisdom on this day, but I wish you all the best, and I'm sure you had very good, I believe, lot of discussions yesterday, and I hope everybody is a delegate and not a participant today. Thank you so much. All the best.
Thank you, sir, for enlightening us with your words. Now I call forward Dr. Mansi and Dr. Deepshika to provide our members of the dais with a token of appreciation. Now I call upon Dr. Sujata Matthew ma'am to kindly deliver our vote of thanks.
Good morning, everybody. I've been given the privilege of giving the vote of thanks. First of all, our sincere gratitude to all the dignitaries on the dais, Mr. Bhalla, Dr. Kanjka Ghosh, Mr. Premrup Alva, our chairperson, Dr. Naresh Gupta, who's an inspiration for all of us and who have brought us here together. We are truly inspired, and this society is his brainchild, and we've come together because of him. Thank you so much. Our President, Dr. K.K. Kaul, our dynamic Secretary, Dr. Sunita Agarwal, the other members of our team, Dr. Bilal Ahmed, our Vice President, Dr. Varun Kaul, our Joint Secretary, and Dr. Ruby Khan and other members. Thank you so much for being with us and contributing to this momentous event. I would also like to extend our heartfelt, sincere appreciation to all our esteemed and eminent faculty who have come from all over the country to share their vast experience, expertise, and knowledge in contributing to this conclave. And also all the delegates and participants, the special invitees for taking out time from their schedule, again coming from all parts of our country to come and help us in this endeavor and give their support to this initiative. I would also like to thank our event managers, Dr. Anand Sethi and his team from MS Artwares. And lastly, but not the least, our sponsors, especially Roche, for all their support in logistics and other organizing activities. And also other sponsors like Novo Nordisk, Alpha Drugs, and Takeda. The greatest form of appreciation or gratitude, said once, was not to utter words, but to live by them. And that is what this conclave is about. Thank you all so much for being here. And that is our theme for our conclave this year, bringing practice, best practices in hemophilia and healthcare. Thank you so much.
Without any further delay, let's commence with our first session discussing the contrasting role of clotting factors and factor mimetics in hemophilia treatment. Leading this insightful exploration, I would like to invite Dr. R.K. Nigam sir to take the stage as a chairperson for this session. I welcome you to the stage, sir. Welcome. I also welcome co-chairs for this session, Dr. Geetanjali ma'am and Dr. Praveen Bharti sir. I request you to please join us for this important discussion.
Now I invite Dr. Sunita Madam, who is Director Professor Medicine, Maulana Azad Medical College, and Secretary of this organization, to deliver a talk. Please, Madam.
Good morning, everyone. Topic given by sir is to be the clotting factor and non-factor therapies in hemophilia, basically factor mimetics. As we are already late by half an hour, I will try to conclude in 20 to 25 minutes to save the time. First is this: what is hemophilia? We all know it is a bleeding disorder due to the lack of either factor 8 and the factor 9, leading to the incomplete coagulation, leading to bleeding. What happens if there isn't bleeding? It is mainly in the joints, and sometimes it lead to the life-threatening bleed into brain, abdominal cavity, chest, etc. But mainly it is a musculoskeletal bleed in which bleeding into the muscles and joint are the maximum, and joint which are affected more are the knee, ankle, elbow, because they are the most commonly used since childhood. So what will happen? There is not only the direct damage to the joint due to the bleeding, but there is also indirect damage to the joints, in which the direct damage, whenever there is bleeding, there will be the direct damage to the cartilage, and it lead to the continuous inflammation at the level of synovial cavity, and this synovial membrane become hypertrophied. As a result, later on this lead to hemophilic arthropathy due to the recurrent bleed. This scenario in our HTC and hemophilia daycare center, we usually see if there is no primary prophylaxis given to the patient, after 3 to 4 bleeding, patient starts limping, and this is the common scenario we see by the age of the 10 if they are not put on effective therapy. So if survey says that mostly 80% patients are having the hypertrophy and this hemophilic arthropathy. Along with, due to this hemophilic arthropathy, this is the affecting the health related quality of the life, and these are the unmet needs of the hemophilia, which can say due to the repeated bleeding. First is the pain. Whenever patient bleeds, it is the excruciating pain, bleeding inside the joint, lead to very much pain ki patient cannot tolerate, and he has to remain in that position. He cannot move, leading to he cannot move his legs. Then ultimately the repeated bleeding, it lead to the lot of mental health problems, especially the stress, depression, insomnia, fatigue, anxiety. And we are usually see, we do the survey, almost more than 70 to 80% patients are suffering from the mental problems. Not only the patients, their family also. And it causes the impact on the caregiver. This is the study in which the more than 50 to 60% of the caregivers are also affected. And it lead to financial burden to the family, to the society, to the hospital. It is a huge economical burden if it is not treated adequately. And due to this financial burden, sometimes they leave the education because they are not getting admission, and even they are this financial burden is basically due to the patient. They are not educated, they are not the skilled, and they don't get the job. So these are the all unmet needs we have to address in the patients of hemophilia. And ultimately there are so many lifestyle limitations. They cannot play sports like the cricket, football, and like this. They cannot participate in so many activities. In the physical education program in the school, they are not allowed until unless we make them aware that we can treat this bleed with the primary prophylaxis. So what should be the long term of hemophilia treatment? It should be the health equity and functional core. Of course, one country, one treatment are the basic goal. So how will we do? First, we have to see the how to prevent the, we have already achieved this target. We have already increased the life expectancy of these patients. So with the minimal joint impairment, that is decrease the bleeding rate, decrease the annual bleeding rate, it improves the joint health so that they can participate in the daily living. Freedom from the spontaneous bleed. They are afraid. Whenever I play, whenever I travel, I will have bleeding. So there should be some freedom from this spontaneous bleed. It can be done by effective prophylaxis if it is given at time. they should attain normal mobility. Due to this, they can attain the normal family life, normal career, normal workplace. Able to sustain minor trauma. They are very afraid of trauma. So if they are not afraid, they can lead the unrestricted lifestyle. Even they should be ensured that they can undergo surgery at any time, because there is no basically confusion regarding the availability of the factor and the multidisciplinary care to these hemophilic patients. Ultimately, goal is normal hemostasis. Just already said, it is the insulin deficiency in the diabetes, it is the clotting factor deficiency in hemophilia. Just replace it and you will do each and everything. However, cost is a big factor here, but we have to see that there are large number of the diabetic and there are very few number of hemophilic patients. And this is the evolution of the hemophilia treatment. We would say that this is the only disease which have so much evolution. Medical scientists and the pharmaceutical company have come together to work over these drugs. If I say that in the 1950s it is the blood and FFP was the mainstay, 1960 cryoprecipitate, 1970 some factor was available but it was mainly derived from the plasma. Due to the infection rate and due to then the later on new technology, genetic engineering, combinant factor, and there are so many modification in the combinant factor. Due to the as we do the more and more we get the feedback from the patient, we get feedback from the doctors, new and new modification are done. Now we are having the third generation recombinant factor. Still the science didn't stop here. Then now we have the, because there was the risk of the inhibitor developments at there. Then for the treatment of the inhibitors, factor 7 was developed, factor 7 concentrate was developed, even the APCC was there, which were used in the treatment of the inhibitors of these patients. But due to the financial constraints, repeated IV infusion, lot of travel and the lot of financial burden, then the factor mimetics came into the action. These are the non-factor therapy, which are the subcutaneous injection. So now, and to increase the half-life of these factors so that the repeated intravenous transfusion can be decreased, extended half-life products came into market. We have already discussed, it is the normal person life expectancy increased over from the 1970 to 2018. It is the all in the mild, moderate and the severe hemophilic. They are the nearly normal life if they have the adequate comprehensive treatment starting from the childhood. Even at my center I have 15 to 20 patients who has crossed already 60 years. So we have a good number, they are living the near normal life expectancy. This is the whatever therapy we are giving, either we can give the episodic therapy or either we can give the prophylactic therapy. This is the episodic therapy in which whenever bleeding occurs, give factor at that time, but it doesn't hamper the joint damage. Whenever you have bleeding, there are the minimal amount of the joint damage, and with the repeated bleeding you have the hemophilic arthropathy. Aim of this on demand to decrease the pain and to stop the bleeding time. But if you give the prophylaxis in which you are preventing the spontaneous bleed, you are trying to prevent, maybe you cannot prevent 100%, there will be some breakthrough bleed. At least the patient will be not afraid of spontaneous bleed, it will be decreased. If the annual bleed rate is 14 to 16 times in that patient, it can be reduced to 1 to 2 times. So number of bleeding in decrease, and there will be no afraid, no social stigma, and no mental health will be very high in this patient. Even I have given the, India is a basically developing country, so we cannot give the full dose, or we are not able to give the full dose. So in our center I am giving the low dose prophylaxis in hemophilia A and hemophilia B, 10 unit per kg weekly in hemophilia B and bi-weekly in hemophilia A. They are very successful. I have at least 115 patients and they are very happy. They are coming regularly and bleed rate has significantly decreased. And when I analyze the number of the hemophilic factor used in that year and their previous year, it was at least 30 to 40% less, because whenever you come with the bleed, you try to correct at least 40 to 60%. Here our goal is to maintain between 1 to 3% so that we can avoid the spontaneous bleed. These are the various. Now I will focus on what is the difference between the various factors. This is the plasma derived factors. These are the first developed. We issue with the plasma derived factor, we need the donors. So interrupted supply, it will always be a problem, because we cannot get enough donor to make the demand of so many patients. And maybe chances of risk of infection, however, with the improved technology, it is very less with the plasma derived as compared to previous one, still it is here. Then I have already discussed first generation, second generation and the third generation. Now the third generation recombinant factor are in use, and it is basically at par with the plasma. It is much, patients are more comfortable with the recombinant, but WFS says ki both are equally effective. You cannot deny if you have the plasma derived factor, both are equally effective in preventing the bleeding. So preferably whatever the available with your whatever the government gives you and what is the available, try to give it, but try for the recombinant. Then these are the basic problem ki half life of factor 8 is 8 to 12 hours and the factor 9 is 12 to 16 hours. So whenever patient comes, then you have to give the repeated dosing, at least twice in hemophilia A and the once in hemophilia B. So especially it is a difficulty, especially in the children, maybe 1 to 5 year, maybe 3 to 6 months, because the repeated venipuncture you will not get the veins. So to overcome this, doctor, increase the half-life of this patient. These are the new factors which are coming, the factor 8 extended half-life and the factor 9 extended half-life by this technology like the pegylation and albumin infusion. If it is their extended half-life product, repeated venipuncture will be decreased and it will lead to more satisfaction to the patients. Mainly is the low the catheter central venous access will be this few monitoring, and the rest mechanism of the action will be same, everything will be the same. So WFH recommended EHL both if available in hemophilia A and hemophilia B. Of course inhibitors, they are not affected as the standard half-life is there. This is the basically chart showing the you have to give the thrice weekly, and in the extended half-life in the factor 8 you have give the twice weekly, and maybe in the this hemophilia B you have given the once weekly only, because half-life will increase 60 hours. These are the various trials, Pathfinder trials for the EHL, in which shown that there will be the 1.6 fold terminal half-life in hemophilia A in extended half-life factor 8. It will increase the trough level more than 3%, efficient prophylaxis, ABR decreased 1.18 to as compared to 12 to 13%, and the spontaneous ABR was 0. So 100% pediatric patient with target joint resolution in the Pathfinder trial when they are followed for the next 5 years. So this is the for the glycopegylated EHL factor 8. This is the trial, paradigm trial for the N9GP, that is the extended half-life factor 9. This is the various arms of these trials, and the various patients used more than 12 years, less than 12 years in the children like that. And overall result that no increase in the inhibitor, no safety concern, no thromboembolic, no neurological signs, and patient were very happy with once weekly doses. But what are the current challenges? Still we don't have the unpredictable pharmacokinetic profile. Still we need the intravenous access, and pegylation some have safety concern because it lead to the accumulation into the body, but later on it found it does not add significant toxicity as compared to normal individual. Still we don't have long term safety data because they come in the market from last 3 to 4 years. With the standard half-life product we have a long term data at least 20 to 30 years. And due to the PK variability, breakthrough bleeds still common in these patients. So against how much they prevent from the life-threatening bleed, it's still a question here. It is just the repeated intravenous infusion can be prevented, and you can make the life of the patient more comfortable by decreasing the travel time and by decreasing the school absenteeism, and a little bit less afraid that we can lead the normal life. Then come to the non-factor therapy. What is the non-factor therapy? It means you are not giving the factor concentrate, you are not giving the factor 8, you are not giving the factor 9 to these patients. Then what are you giving? These are the basically monoclonal antibodies. These are the various in the coagulation profile. If you say there are the various anticoagulation protein also, so you have to inhibit them. If you will inhibit them, then the whatever the coagulum is made, it will be there and it will be help in stopping the bleeding. So this is the factor 8 mimetic bispecific antibody which will basically bridge between the factor 9 and the factor 10, and it will directly activation of the factor 10 on activation of the common arm of the thrombocoagulation cascade. Anti-TF by gene therapy and siRNA will be covered in leg structure by Dr. Arihant. I will focus only on the emicizumab. I have already discussed these are the what are the site of the action for the monoclonal antibody, especially for the factor 8 mimetic. This is the, we have already discussed how does it act. It activates between the factor 9 and the factor 10, and direct activation of the factor 10 leading to the activation of the common arm of the coagulation and leading to the formation of thrombus. Beautiful thing about the emicizumab, it is not intravenous, it is subcutaneous, and it has a long half-life, at least 4 to 5 weeks. Due to this, initially after the loading doses, which is weekly, then you can give plan for monthly 6 milligram per kg or 3 milligram per kg bi-weekly. So it is subcutaneous like the insulin. Patient if the traveling, they can keep with it, but it is available in vial form. You have to reconstitute it, and the patient should be trained for this subcutaneous injection, then you can give it. But patients are really happy with this emicizumab therapy. I have 20 patients from the ESI and the CGHS, and it is very useful, especially in the children, especially the age of 2 years, 3 years. If they are the CGHS beneficiary, I know they will get till the 21 years of age, but at least 21 years of age, if they are the free from pain, and we can counsel them to adopt some government service and to get something, and maybe the things will change at that time. So we are putting these, especially the children of the CGHS beneficiary and ESI beneficiary, over this emicizumab subcutaneous injection. They come to our center, they take it, they are very happy, and they just forgot they have any disease. They are participating in their school support, and they have to come just on Saturday, so no school absenteeism is there, and they are basically growing with the grade, because they had some fear that we have to read, we have to educate ourselves, otherwise how will we afford it. So there is something that they are trying their best effort to get good marks, and when you see their mark sheet at the end of the 1 year, it seems that they are the topper of the classes. We usually encourage them every year in our Haemophilia Day. We call them on the stage, and we call them to participate in the fancy dress competition and to dance, and they are just love it. Though this is a boon for these patients, subcutaneous injection in which there will no specific training is required. In the intravenous, you have to train the family, and still they are not trained in the till the 10 years of the age. But in this, you have to just tell them subcutaneous. These are the various Heaven trials. Heaven 1, adult adolescent more than 12 hours with inhibitors. Heaven 2, pediatric less than 12 hours. Heaven 3, without inhibitors. Heaven 4, without inhibitors, and in which the various doses are compare weekly, 2 weekly, 4 weekly in the various trials, and the result is that as annual bleed rate, whenever you are progressing with the treatment, it turns out to be reduced in every patient in both hemophilia A with or without inhibitors. Even patient with zero bleed are there. The proportion of the participant with the zero bleed, this is the chart, this is the proportion of the bleed in Heaven 1, Heaven 2, in which the zero bleed percentage was shown. Even 95% of the patient target joint resolution is there with emicizumab therapy. It is consistent with this for Heaven 1, 2, 3, 4 trials. So conclusion is that they continue to show improvement in the bleeding event and the target joint resolution. Zero bleed was increased. Beyond proportion of the participants with zero bleed increased across each treatment interval beyond week 25, and it is approached 100%. Maintain low bleed rate regardless of the age inhibitor. You can give in the inhibitor also, because in the inhibitor you are not targeting the factor 8. It is a monoclonal antibody which acts at a bridge. So if there is an inhibitor is present in the body, it will not hamper the mechanism of action of this drug. And the target joint lesion, well tolerated, safety profile is consistent. Even during these trials, focus will be done on the major surgeries also. The total 233 surgeries were performed, in which 215 was the minor and the 18 was major. It was result that the 15 out of the 18 major surgery, they required some amount of the regular infusion of the clotting factor, but 3 they are only maintained on the emicizumab. and the minor surgery, they didn't require any additional factor treatment. But problem is that we again, we are talking about the laboratory support in which the normal PTTK measurement is not useful. You have to go for the bovine chromogenic assay for the factor 8 assay in these patients. So it should need, it needs the specific reagents and it needs the experience in this. Even the World Haemophilia Federation 2022, they make some guidelines. It is used to prevent the bleed, not treat the acute bleed at this time by the guidelines released in 2020, both in hemophilia A with or without inhibitors. And whenever they have the acute bleed, then you have to give the clotting factor replacement therapy if there is no inhibitor, factor 7 therapy if there is inhibitor, because there are three patients in trials, Haemon 1 trial have the thromboembolic events, but later they were analyzed, it was basically APCC was given into these patients. So it was said that rather than APCC, give the factor 7 in these patients. If you are forced to give, then reduce the dose to the 50 unit. Surgeries, they have the recommendation. Amisuzumab with inhibitor who undergo the major surgery or invasive procedure, close clinical monitoring for thrombosis, conjunctive coagulopathy and the thrombotic. Hemo with inhibitor who use the bypass, clinical monitoring and the laboratory monitoring is required. If your patient is going, the patient is receiving the amisuzumab therapy, and these are the some risk factors for the venous thromboembolism, obesity, smoking, infection. I am just finishing. This is the comparison between the SHL and amisuzumab. We have already discussed intravenous, subcute, half-life difference, annual bleed difference, and resolution of the bleeding. Hemophilic arthropathy you cannot prevent with the SHL, but you can resolve the target joint. This is the between the EHL and the amisuzumab. Again, the major difference is the IV and the subcute. Half-life 22 hours, 24 to 5 weeks. Inhibitors, you cannot say without, if the patient is having inhibitor on the EHL, you have to go for the factor 7 concentrate or APCC, but amisuzumab can take care of it. This is the paper published in 2024 April by expert on opinions on the management of hemophilia A in India, role of amisuzumab, in which the Dr. Naresh Gupta was the main author, and we are all the co-authors. They just finish. The last few slides are left.
Thank you, madam.
But just last, jab I'm summarizing. Pipeline, I'm going for not for the details, sir. This is the goal. This is the shift basically from the factor to we have the combinant EHL non-factor therapy. Government is supporting us, listed in Right of Person with Disability Acts. Many country HTC are opening well-trained physician. So so there is always hope for the hemophilia. Don't give up. We can achieve our goal with our comprehensive approach, with the support. If all of us are together, we can treat the patient as a primary prophylaxis since birth. We should be hopeful and we should not give up in these patients. They cannot be treated. Thank you very much.
Thank you, madam, for your nice presentation. From plasma derived, now we are factor with inhibitors and non-factor therapy. So future is good, so that one day will come when all hemophilics will get something without inhibitors and they will enjoy normal life. Any question, please? One or two can be taken. If otherwise.
Yes, sir.
Ma'am, you said about the low dose prophylaxis that you are using at your institute. Ma'am, need to know one thing, ma'am. How much is the ABR decreased with that?
So basically, we are treating, we are giving in only the severe hemophilic patients. We are not giving it in the mild to moderate hemophilia. Our aim is to maintain the factor 8 level more than 1%. if I say the previous data, when it was a basically thesis topic, so we compared the data of the previous year of the same patient and when the patient were on the low dose. Annual bleed rate was decreased at least 80 to 90%. Initially it was 14 to 16 times per year, maybe more than, maybe 20 in some patient. Now it is decreased to 1 to 2 times. But sometimes it is the hemophilic arthropathy, the synovium is very fragile, you cannot prevent the breakthrough bleed. But still it has a significantly and clinically significant and the statistically significant difference in the ABR, and the consumption of AHF is decreased when I calculate the doses of AHF previous year and this year. It will decrease to 35 to 40%. Our aim is not that to stop the bleeding, to decrease the bleeding with the low dose prophylaxis, because I cannot afford to give 25 to 40 unit per kg.
Thank you, ma'am. Ma'am, you are using it on all the patients or you have selected a subgroup?
जो मेरे पास प्रोफिलैक्सिस हफ्ते में 2 बार और हफ्ते में 1 बार आने के लिए हाँ करते हैं. Sometimes they don't agree for it. हाँ, yes. We take the consent from the parents also and from the patient also. If they are ready to come, they are ready to travel to my center. We fix the time ki come at 9, we will make you free at 9:30 or 10. Or come on the one day for the school going children, we have kept the day of Saturday for them.
My question is regarding factor mimetic, that is monoclonal antibody, imisusimab. Can you elaborate the clinical and laboratory monitoring in a child who is getting this monoclonal antibody?
Sir, in the clinical monitoring, if I say ki what my experience है कि I have 4 or 5 children which are the age less than 5 years, and at this time I didn't experience any bleed rate in these patients, and they are very happy and they are going to the school, play school and all these things. And one jo bigger even in the adults, breakthrough bleeding is 1 or 2. Otherwise there is no bleed for the last 1.5 year to 2 years, sir.
No, that is right. I also have the patient on this monoclonal antibody. My question is, can you elaborate the clinical monitoring and laboratory monitoring on this?
Sir, clinical monitoring, I look for the spontaneous bleed and the bleed rate, annual bleed rate. And for the laboratory monitoring, I don't have the chromogenic assay. Whenever they come to us, we cannot do the factor 8 assay level in this. That we just focusing on the PT. We cannot do the laboratory monitoring because it needs the expertise, or I don't have facility for it.
My concern is more towards the hypercoagulation.
No patient has shown there is any hypercoagulation. No patient reported to the thromboembolic event. None of the patient reported any hyperviscosity symptoms. At least for my 18 to 20 patients for the last 2 years, I didn't experience any episode of thromboembolic phenomenon in these patients. Maybe time will tell in further, but at this time I didn't say.
Is there any absolute contraindication or any adverse effect other than anaphylaxis in this monoclonal antibody?
Sir, contraindication, of course, if the patient is having, I don't think so there is any contraindication until unless the patient is having anaphylaxis. Even some say ki maybe the antibodies against this molecule will change the clinical profile of this, but it is again negated in the various trials. Anaphylaxis, sir, I don't think so ki it is very difficult, sir. I didn't experience any anaphylaxis.
So patient with hypercoagulable state,
yes,
for example, nephrotic
basically
syndrome.
उसमें बताया कि जब भी ये पेशेंट जाते हैं तो you have to do clinical if the patient is obese, patient is a smoker, which are the high chronic inflammatory states. Then you have to be little bit vigilant and you have to call the patient repeatedly for the clinical monitoring and you have to ask the symptoms.
So PWH with nephrotic syndrome can be given?
I don't think so, sir. PWH with nephrotic syndrome we can give, sir.
Okay, thank you.
Okay, thank you very
But
much.
need the clinical monitoring
Thank
again.
you very much. Now you can ask some question during lunch hours and we will proceed further.
Thank you.
Thank you, ma'am. I extend my gratitude for the enlightenment session. Moving ahead, our next session will delve into the discussion about upcoming products like circulating procoagulants and anticoagulants and their complementary roles in hemophilia treatment. Leading this discussion, I would like to invite our esteemed chairperson, Dr. Manish Bansal sir, to please join us on the stage. Dr. Manish Bansal sir. I also extend a warm welcome to our co-chairs, Dr. Sudhir Atri sir and Dr. Ankit Jain sir, and request them to please join us for the discussion.
May I invite Dr. Arihant Jain for his presentation on circulating procoagulants and anticoagulants, complementary roles in hemophilia treatment, please. Thank you.
Hi, good morning. Dr. Arihant, there is only one request that please be concise and try to save some time if possible, please.
Dr. Arihant is DM in clinical hematology from PGI Chandigarh, and he is associate professor in Department of Medical Oncology and Clinical Hematology, PGI Chandigarh. Sir, please.
Thank you, sir. And so the topic as is highlighted, circulating procoagulants and anticoagulants. So I'll start with where ma'am left. So we know the conventional therapies and novel therapies. Conventional therapies, the plasma and the plasma derived products. The novel therapies, the EHL and probably emicizumab. And I would like to, but we are still talking about alternative treatments. The question is why? If factor replacements are good, then why do we still searching for alternative treatments? Well, there are certain problems. The original plasma derived products, we know there were issues of transfusion transmitted infection. The recombinant products, there are two major issues: the disease burden related issues and the treatment burden related issues. The disease burden related issues mainly derive from the high bleeding rates which continue despite prophylaxis, except for Altuvio, which is FDA approved, which is a factor VIII with a once weekly dosing EHL. The remaining still have a short half-life, and therefore they are predisposing to microbleeds. Inhibitors are an issue. 30% in patients with people with hemophilia A, 4 to 5% in people with hemophilia B. ITI is cumbersome. Bypassing agents have their own issues in monitoring, failure rates and thrombosis. Most of these drugs are IV, and then therefore they are painful and there are compliance issues. So EHL products, though there was a achievement that our annual injections in people with hemophilia A decreased from 200 to 150 in a year. However, there were still issues which mainly arise from that the zero bleeding rates were still less than, in most of these things, they were less than 50%. So there was a next drug in development which we all have been using, which is emicizumab. However, emicizumab also has issues. The first one, that these treatments, there are issues when we use it concomitantly with bypassing agents. Then there are issues of thrombosis, and there are breakthrough bleeds as well. Secondly, the emicizumab has its specific storage needs of refrigeration, need to warm, then need to be transferred to a vial. The emicizumab does not cater to people of hemophilia B with inhibitors, and then there were issues in monitoring these drugs as well. So there was a quest of developing newer products. So this is our, can I have the pointer please? So this is our coagulation pathway, and we know that there are so many products, so many plasma proteins which can actually be targeted. So this is the intrinsic pathway which is usually deficient, and because of that the final endpoint, which is the thrombin generation, is becoming less and the clot is unstable. So the goal of any hemostatic therapy is to ensure a stable and balanced thrombin generation. However, factor 8 pathway is not, or the factor 9 pathway is not the only way as to how we can increase the thrombin generation, and therefore we have other non-factor products which can help in doing this. So this is the state of balanced hemostasis in a normal individual, where the procoagulant proteins are balanced with these anticoagulant proteins. In a patient with hemophilia, without hemophilia they are balanced, and therefore there is a stable clot which is there. However, in a patient with hemophilia, there is an imbalance, the anticoagulant proteins are more and there is a deficiency of procoagulant proteins. And therefore, if we are able to decrease these anticoagulant proteins, the balance can be restored. Scientists identified, Dr. Kanjangsha was yesterday telling us the story, that they observed that not all severe hemophiliacs were bleeding equally. There are severe hemophilia patients who co-inherit various prothrombotic mutations, and therefore they have a milder phenotype. So this bleeding phenotype, we all know that in hemophiliacs the factor 8 is deficient. In antithrombin 3 deficiency, we all manage the thrombosis clinic as well. There is increased tendency to thrombose. So if there are ways as to how we can rebalance this thrombosis. This one way is by targeting the tissue factor pathway inhibitor, and we have the antibodies for that. The other way is targeting the antithrombin 3, and we have the siRNAs for that. So therefore comes the newer classification of anti-hemophilia therapies, where we have conventional therapies, the novel therapies, and this I tend to call as novel therapies. The siRNA therapeutics, the TFPI inhibitors, the other serine proteases, and the gene therapy. So this is the way, this is the entire pathway, and this is where these are the various targets where these newer drugs are acting. So if we look at the mechanistic classification of the various hemophilia products, we have factor mimetic therapies, emicizumab, which we have already talked about and will be talking in subsequent sessions, mimate, and then we have these rebalancing therapies, and I would like to go one by one and touch upon those. So if we look at the various phases of anticoagulation, this is the initiation phase, this is the amplification phase, and this is the propagation phase. The anti-TFPI therapies are mainly acting at the initiation phase, and this has a bearing as to how and when we can use them. Similarly, emicizumab is also acting at the amplification phase and the early initiation phase, and therefore all these non-factor therapies are predominantly used only to prevent bleeding. However, they have their limitation when there is a breakthrough bleeding, and in that scenario we usually end up giving our conventional products. So starting with the first novel drug, which is MIM8, so this is a next generation factor 8A mimetic bispecific antibody. Basically this is a rival of emicizumab, I would say. So it is again a bispecific antibody where one arm is binding to the activated factor 9 and the other arm is binding to the activated factor 10. So this next generation factor 8 mimetic is again has a subcutaneous prophylactic dosing, can be used in both patients with hemophilia A and B with or without in patients of hemophilia A with or without inhibitors. It is a fully human IgG4 antibody, and the binding epitopes are factor 9A and factor 10. So the question is, what is the difference between emicizumab versus mimate? Both are acting at the same, both are the bispecific antibodies and both have the same target. So there are three basic differences. First is the binding site. This novel molecule is binding to the activation domain epitope of the factor 9A on one arm, and again near to the activation domain of the factor 10 as well. So therefore the thrombin generation is more robust, and thirdly, the administration volume is different. So this drug has been optimized to enhance the proteolytic activity of factor 9 by 23,000 fold, and this is where it's kind of scores over emicizumab. So because it is binding to the activated factor 9, it only has a mechanism of action in the membrane localization. However, in the free circulating form of factor 9 and factor 10, this antibody does not bind, and therefore in the systemic circulation it is not causing thrombosis. There was a recent question whether there are thromboembolic events with emicizumab. Well, there were some in the Heaven trials, and the MIM8 is designed to function only at the site of bleeding, and therefore the claim is that probably it will not have non-specific thromboembolic events. So the rationale and concept is that it has an optimal affinity as well as a optimal cofactor activity, and therefore it only it has a very good therapeutic window, and which combines the low binding affinity and a high cofactor activity, reducing the risk of non-specific binding while providing effective thrombin generation. These are the comparative graphs showing the blood loss in the mice model of MIM8 versus emicizumab, where they said that even at lower plasma concentration, this drug was scoring better. And the preclinical safety was kind of cleared, and basically just 4 days back on 13th May, the company announced that once weekly and once monthly MIM8 dosing demonstrates superior reduction of treated bleeding episodes compared to on-demand or prior prophylaxis in treatment of patients with hemophilia A in the Frontier 2 trial. So this is where we are on the MIM8 drug. This is kind of a factor mimetic therapy. Next we come to the rebalancing therapies. In rebalancing therapies, the most advanced ones are the TFPI inhibitors, and there were a host of antibodies which were kind of planned and were being developed by the various pharma companies. However, the one by Baxter, the Bax49 aptamer, the befozizumab, they all kind of phased out because one, they were causing more bleeding, and the other problem was that there were certain thrombotic events. The ones which are in more advanced phase are the concizumab and the marstacimab. So this is the anti-TFPI pathway, and this is and in the next slide I would like to show. So this is the tissue factor pathway inhibitor protein. This protein actually has 3 domains. They are called as the Kunitz domains, the K1, K2 and K3, and this binds to the factor 10 and factor 7 at the plasma membrane. So this is the structure and function of the TFPI. So basically TFPI protein in the blood, it is in the human body, it is in the 2 isoforms, TFPI1 alpha and TFPI1 beta. And the 3 domains have 3 different binding site of action. The K1 domain directly acts on factor 7A, the K2 domain acts on the factor 10A, and the K3 domain localizes it through protein S on the endothelium. And then there is this TFPI1 alpha, which is also produced by the activated platelets. So the K2 domain actually first binds to the factor 10, and then it facilitates the binding of the K1 domain to the factor 7. So so these 2 events proceed stepwise, and then they lead to inhibition of the thrombin generation. And if we have an antibody which targets both anti-TFP1 alpha and beta, then the thrombin generation can be restored. So basically there are 2 main drugs, the concizumab and the marstacimab, which have been developed. So the concizumab acts on the K2 domain of this tissue factor pathway inhibitor protein, and thereby it kind of restores the thrombin generation balance. So this is how it is acting. It is a subcutaneous, it is a first-in-class anti-TFPI antibody, again subcutaneous, and it can be used across all hemophilia subtypes, independent of whether you are a factor 8 deficient or a factor 9 deficient, whether you have inhibitors or no inhibitors, and is acting by enhancing the initiation phase of coagulation and allowing sufficient thrombin generation. So it binds to both TFPI1 alpha and beta, and primarily it is acting in the circulating form. So the other big advantage is that it comes as a injectable pen with a 32 gauge 4 mm needle, which is low volume and it is ready to use, and therefore it improves the compliance. So the patients can very easily be trained to self-inject it, and this was done in the regulatory trials, and these injections can be administered at any time of the day. So these were the various trials, they are called as the Explorer trials, and there were various phases, and in August 2023, the Explorer 7 trial findings were published in the prestigious NEGM, and they could attain the primary endpoint of the decrease in the annual bleed rate, which was around 1.3 as compared to 11.3 in people of hemophilia with inhibitors. This arm was in the on the on-demand bypassing agent prophylaxis arm. The trial had an adequate representation of various minorities, including India. There were KEM St. John sites, 27 countries. So this was the trial design, and so basically coming to the, so again there was a minor halt in this trial because of the thrombotic events. Basically there were 3 arterial events, 2 arterial and 1 venous event which was noticed. There was 1 myocardial infarction which was noticed, there was 1 renal infarction which was noticed, and then there was a DVT which was noticed. So then they finally revised the dosing regimen. The dosing regimen now says that you give on day 1 you give the 1 milligram per kg of loading dose, and from day 2 onwards you give 0.2 mg per kg of the daily subcutaneous dose, and around week 4 to week 8 you do the PK modeling and you do the drug level. If your patient is having less than 200 nanogram per ml, you increase the dose to 0.25 mg per kg, and if it is less than 0.15 mg per, and if it is more than 4000 nanogram per ml, you decrease the dose by 0.15 mg per kg. And as I said, that the drug was able to meet the primary endpoint. There was the median annualized bleeding rate was 0, and 63.6% of the patients receiving concizumab prophylaxis had actually 0 annual bleeding rates. So the safety was kind of after the dose modification was made, except for certain hypersensitivity reactions which were again rare. There were no major safety signals, no DICs or TMAs that were identified. There were anti-concizumab antibodies which were found in the circulation. However, they did not have any clinical bearing. If we look at the health survey, most of the whether it was the general health, vitality, social functioning, mental health, even on all these domains, the patients who were receiving concizumab prophylaxis had a statistically significant outcome. So this is the summary which has been there, and the drug is considered safe and well tolerated in hemophilia A and B with inhibitors. And this is the current regulatory approval. So while Canada has already approved it for patients in hemophilia B with inhibitors, the regulatory approvals were submitted to USA, Japan and European agencies. However, in May last year, the FDA rejected the concizumab FDA approval request, and they asked for additional biosafety and dosing information. So the other drug in the same category is the marstacimab, which is from the Pfizer. Again, the concizumab already phase 3 trials are over, but this drug from Pfizer, again a TFPI inhibitor. This concizumab was having a daily dosing. This drug is having a once weekly subcutaneous dosing. The results were presented in the ASH 2023 this year, and the trial investigators say that the dose was well tolerated. There were no thromboembolic events, not even, so this is the only non-factor therapy where the regulatory trials, no thromboembolic events have been reported till now. And the investigators claim that most of the patients actually want to extend into the continuation phase of this drug as well. So let's see what's the future for this drug. So if I compare the two TFPI inhibitors, concizumab versus marstacimab, one is from Novo and the other is from Pfizer. Both have proven efficacy. This is a daily subcutaneous dosing, and this is the once daily dosing which is there. However, there are limitations. The limitations is one, that because they are acting at the initiation phase of the clotting pathway, so TFPI inhibitors do not serve breakthrough bleeds. The other unique problem is that they act via a target mediated drug disposition. So they have a very high affinity to their target, and that is why their PK is actually affected by the PD, and therefore they require a very frequent dosing, and therefore again the search for the safe therapeutic window kind of becomes complicated. So the advantage is that this is the only, these are the anti-TFPI inhibitors probably because they act independent of inhibitors. So emicizumab does not work in hemophilia B with inhibitors, and this drug kind of answers that question. Probably this drug is being investigated in other rare bleeding disorders, including Glanzmann's and other platelet disorders as well, and maybe even in those areas these drugs may act. Coming to the next class of drugs, which is the siRNA therapeutics, we have the fitusiran, which is in the advanced phase of trials. This is manufactured again in combination with Sanofi. So it acts by targeting the antithrombin level. So initially, when the drug was designed, they aimed at a target of decreasing the antithrombin level by less than 10%. But during their various Atlas phase trials, they again encountered various thrombotic events, and therefore they revised their dosing strategy, and now they target the decrease in antithrombin level to 15 to 35%. And at this therapeutic window, the thrombin generation is kind of adequate to stop the bleeding as well as not to cause thromboembolic events. So this is the mechanism of action. We all know that antithrombin. So basically, this is a antithrombin. Fitusiran is a SI signal interfering RNA, and this acts at the serpin C gene. And after, so this drug is acting at the hepatocyte level, and that is why the transaminitis is an issue with this drug. And basically, it is inhibiting the antithrombin synthesis and therefore causing the upregulated thrombin generation. So these were the various trials, and again they could prove that the annualized bleeding rates were decreased, the safety signals were there, and basically the company had to voluntarily hold the trials because of the various cerebral events which were happening in this drug. And then these are the breakthrough bleeding events which were there, and this is the the bypassing agent dosing capping, which they have already told about. And these were the and with the revised dosing, now the company says, the trial says that they are safe, and these two major publications came in the Lancet that fitusiran prophylaxis was in both hemophilia A and B without and with inhibitors. The drug is safe and with high rates of zero bleeds which were there. So what is the advantage? One advantage is that this is the only drug which has a reversal agent. We have the antithrombin 3 concentrates which are available, and if you thrombose, you can just reverse the drug by giving that. The transaminitis is an issue which is there. So this is the kind of comparison between emicizumab, fitusiran and concizumab. All are subcutaneous drugs, all are the thrombin producing. The monitoring is again an issue. You can monitor antithrombin level for fitusiran, while you would need a thrombin generation assay for monitoring concizumab, and you would you usually use the bovine chromogenic assay for the emicizumab. So the last is the HAPC 31157, which targets the serpin C gene, protein C, again in preclinical phases of development. So coming to my final two slides, basically what are the concerns and pitfalls of the non-factor therapies. First is the safety. Almost except with the marstacimab, all non-factor therapies have had thrombotic events which were encountered during their regulatory trials. The cost of monoclonals continues to be an issue. We don't know how to manage concomitant trauma in surgery when we are using these non-factor products. In patients who are competitive athletes, these prophylactic doses, the experience is lacking. Patients who have cardiovascular risk factors, smoking, diabetes, obesities, there are thrombosis concerns. Monitoring thrombin generation is again an issue, and a lot of non-clotting functions which these proteins are acting, that is again a concern which is there. So this is the comparative slide. So I would conclude by saying that our armamentarium of hemophilia therapies is increasing. The non-factor therapies will continue to co-evolve with factor therapies, and the standards of care will continue to change. Are the factor therapies dying? No, but they are definitely getting senescent, and the newer therapies would probably be the way to go in future. Thank you.
Thank you, Dr. Jain. Please stay. Thanks for the very elaborate discussion and the recent advances in the medical field in hemophilia. The house is open for a question, but I would request only one question, please. Rest you can take it up in your break. Thank you, Dr. Jain.
Thank you, sir.
For the next session, I would like to invite our respectable chairperson, Dr. Shubha Patke ma'am, co-chairpersons, Dr. Alka Yadav, Dr. Kanwaljit Kaur.
Namaskar. Thanks for making me the part of this very, very important meeting. Now we ask the speaker, Dr. Beena V, to deliver her talk on one factor, many possibilities. Dr. Meera, please.
Thank you, ma'am, and thank you, organizers, for giving me this opportunity to share my experience. Today, I'll be talking about the gamut of opportunities and it's the role of extended half-life products in our daily practice. I'll start with sharing some of my experiences in the use of these products. The first is was a 28-year-old male who was a case of severe hemophilia A, and he had bilateral recurrent bleeds in both the knees and elbows. He was a software engineer, and his elbow bleeds were particularly causing him a lot of discomfort, and he was not able to work properly, and he was missing work often. And also because of his the job requirements, he could not come regularly for even taking the treatment because he needed permission to take the day off and all that. His ABR was quite high, and his target joints were the right knee and elbow, and they were fixed flexion deformities as well. So he was having 2 to 3 spontaneous bleeds at least in a month. And his inhibitor screening was negative, and initially was an on-demand treatment. Then we shifted him to prophylaxis with standard half-life products, and in spite of it, he was quite regular with the prophylaxis once he understood the importance of it, and when he saw that there was reasonable improvement. But in spite of it, his problems persisted, and he continued to have breakthrough bleeds. And we increased the frequency of infusions also, and it still didn't help. So then we thought of putting him on extended half-life product, hoping that would, because of more sustained blood levels and also the chances of his even better adherence with this product, hoping that he'll do well. And we started him on extended half-life product, and by 6 weeks he was doing quite well, and now he has continued on the product. and he has shown significant improvement, and there is a good improvement in his HJHS and annual bleed rate. So after starting the extended half-life product, there were no more breakthrough bleeds. His target joints have started resolving, and all his patient-related outcomes have shown good improvement. So this is one of the scenarios where the extended half-life products do well, and data has shown clearly that on the continued use of extended half-life products, the ABR shows a continuous reduction, and it goes on improving year on year. So the proportion of patients who experienced no annual bleeds increased with each year of treatment, and about 64% of the adolescents and adults had 0 bleeds at the 6th year of treatment. So the target joints show good resolution with the continued use of these extended half-life products, and almost 100% target joint resolution is seen over time. So the studies have shown that with the standard doses, more than 90% of the target joints improve with, for example, with factor 9 when it's given once weekly, and about 66.7% experienced no bleed at all. This is, we have also used it with surgeries, and this is one minor surgery which we did with our patient with extended half-life product. We did a cataract surgery, and we just gave him one good preoperative dose, and after 24 hours we gave him another dose, and he did not require any additional doses, and the surgery went on successfully. We also did another minor surgery, circumcision, and we got away with just a single dose. So the hemostatic success rate has been very good with the use of these extended half-life products, and it has been excellent in about 51% and good in about 44.9%, and the overall success rate of 95.5%. There have been a couple of breakthrough bleeds when the extended factor 8 has been used, and they've all responded well with the reinfusion of the same extended half-life product. And overall, the hemostatic efficacy has been reported as good to excellent. And in the trial, they have also studied the factor 8 activity with the chromogenic assay, and it was as per the recommended levels. And there were no new safety observations or thromboembolic events, and there were no inhibitor developments or any adverse events which required the patient to withdraw treatment. So with respect to factor 9 extended half-life products, the results are really much more remarkable, because the extended half-life factor 9 prolongs the half-life, has a much longer half-life, about 5 times that of the standard half-life product, and almost the time taken to, for the factor level to reach 1% is about 22 days. And even up to a week, the trough levels of the factor 9 is very good. So in the trials, they have used a single preoperative dose of 80 IU per kg, and they have achieved excellent success rate. No patient required additional doses, and just a median of 2 injections were used in the next 6 post-operative days, and there were no thromboembolic events, and the hemostatic coverage was very good. So the hemostatic success rate was very good, and you can see that there was a sustained level of the factor for more than 24 hours. We have also used this product for an on-demand bleed. At that point of time, the factor was not available in the system, and this we got it as a compassionate grounds. So 40-year-old male who was a known case of hemophilia B also had some target joints and other mucosal bleeds in the past, and he had presented us with the left upper motor neuron facial palsy and slurred speech and some weakness in the limbs. And when we did the CT, he had a intracranial bleed. And so at that point of time, since we didn't have the medicine in the system, we used this product and we gave him a stat dose and then repeated the product every second day. And with just about 5 doses over a period of 2 to 3 weeks, he responded very well. And we also continued him on the weekly prophylaxis for about 3 months, and he is doing very well. So if you look at it, if we had used this, the standard half-life product in him, the amount of factor that we would have used would have been much more, about 820 IU per kg compared to what we used in him. It was only about 245 IU per kg, and with good response. So that is the beauty of using extended half-life factor 9, because the half-life of this extended half-life factor 9 improves tremendously. Almost it is 5 times that of the standard half-life product. And for mild to moderate bleeds, just 1 dose of 40 IU per kg is more than sufficient. And if it is a major bleed, you can give a stat dose of 80 IU per kg and additional doses as required and as per the bleed that you have encountered. So this is the recommendation for use of extended half-life factor 9. For mild to moderate, a single dose is usually sufficient, and if it is a major bleed, you give a stat dose and further doses as required. And since we had used this extended half-life product, the advantages that we could see was the lesser number of injections, and there was no need of any specific dose calculations. And there was good resolution of bleeds, and whenever you use this bleeds, most of the patients have only required 1 or 2 injections, so that makes it cost effective in the long run, and it was well tolerated. So these are some of the advantages that I feel would be there when you have the extended half-life product also in the government system. In the long run, when you look at the annual factor consumption, it is much lower, and because of the sustained factor levels which will remain in the patient's body, there will be the chances of bleeding episodes are much fewer, and since there is reduced hospital visits and reduced IV infusions required, the treatment burden is also lower, and the hemostatic efficacy is much better both for surgery and if there's an on-demand bleed. For example, if you have to treat a psoas bleed, you would require probably, even if the patient comes early, 1 dose or maximum of 2 doses when you give extended half-life product, whereas when you use the standard half-life product, you will require a much higher dose and more frequent dosing. So these bleeds which are neither a joint bleed nor a critical bleed, in those scenarios many a time extended half-life product, a single dose is doing wonders. And because of the higher trough levels, the results are much better, and it is possible to effectively use prophylaxis much better with this product compared to a standard half-life product, and thereby the long-term joint damage is much lower. So to summarize, even with the standard, when you give the standard half-life product, still the results can be suboptimal. So there is a scope for further improvement, and these extended half-life products allow better efficacy, and the number of infusions are lower, and because of the higher trough levels, there's a higher bleed protection, and in the long run can be more cost effective. So the take home message is, with these extended half-life products, the patient adherence and convenience is much better, and the injection frequency is lower, and thereby the treatment burden is much lower, with a much better quality of life, and there is lesser school and work absenteeism and a near normal life. Thank you.
Any questions from the audience?
My compliments for having delivered such a lucid talk. I have
Thank you.
just one question. What should be the timing of the pre-op dose of EHL in case of, with respect to the timing of the surgery?
It is the same timing, just before you give the anesthesia on the day of surgery.
Okay, thank you.
Very nice presentation. Actually,
Thank
you
you.
have quite some experience with extended half-life factors, so my compliments.
Thank you.
So I had one question regarding your case one. You were giving thrice weekly prophylaxis, which was ineffective. So what protocol you were using in that patient?
About 15 to 20 IU per kg.
15 to 20 IU per kg thrice a week. So
Yeah.
you did not go up higher on the protocol.
We were already on thrice weekly, and this made better sense rather than going further up on that.
So you used 40 unit per kg weekly prophylaxis.
Yes.
So, I mean,
Eventually, it became once in 10 days also, once he started doing well.
because the Pathfinder study, they have used 50 units per kg every 4 days. Because
I think
extended
for,
half-life of factors 8 is only 1.3 times more.
Yeah,
So
there are
giving
two
it like
doses, I
once a
think.
week
For major,
in
it
a
is
patient-
50, and for minor, it is 40.
Yeah, so they use 50 units per kg every 4 days. So,
Yeah.
and half-life is little bit prolonged, only 30% or maybe 50% more prolonged. But like that was, I think, bold
Again, it
decision
is
to give
it depends on the
weekly.
patient's pharmacokinetics and
Yeah.
what trough level he is able to maintain.
you use
So there is scope for
pharmacokinetics
individual. No, we couldn't do it, but there is scope for individualization.
Yes, we can do pharmacokinetic studies,
yeah.
like 1 or 2 levels, and
Yes.
it gives an idea.
Yes, yes.
So regarding your cases number 2 and 3, they were given extended half-life to cover factor to cover the surgery.
Yes.
So they were on EHL prophylaxis only, or they EHL was used to cover the
Only the surgery.
bleeding event.
Only the event.
Bleeding and the surgery.
Yes, yes.
Same, the intracranial bleed was also given
For the
EHL
event.
to cover the
Event, yeah.
So that makes even more sense, because in such cases, if the factor 8, we know that if we give in excess, like during the bleeding episode or during the surgery, the inhibitor formation is increased. So I think that may be one more indication to cover like acute bleed, to decrease the incidence of inhibitor formation.
Yes.
Thank you.
I have one query in my mind, just to know for myself, because when we give it, in the SHL versus EHL, so we just calculate the percentage. I mean, when a patient has to get operated, we just calculate that we give this percent. In the SHL, we know that it is 50%, 60%, or 80%, whatever is the type of surgery. So in case of EHL, can we,
No, there is no scope
can
for
we
calculating percentage. The product comes with this dosage recommendations, and there is a slightly higher dosage when there is a major surgery or
can't
major
judge the
bleed.
percentage,
So it is as
what
per
would be
the
trough level?
body weight.
It's, we can't judge the percentage.
Yeah. No, that's, I think whatever their recommendation, if you follow, there's no issue, because we are just attuned to using the percentages. But when you follow the dosage recommendations, when it's a major bleed, you don't try to cut down the dosage, and you
In
give
case
the
of
standard
surgeries,
dosage,
in case of
and it
surgeries.
works well.
In case of surgeries,
And one more thing that you
post-op.
can do is, you don't have to use the product first time on the day of surgery. Before that, you can give the product and do their factor levels. So you know how much is the percentage increment. So you already know. And you can subsequently use it for the surgery. Then you will not be diffident.
I congratulate ma'am for the nice experience and a very wide experience on use of EHLs. But my question to you is, like, is there any major cost differences involved when we
Major? Cost.
when we put these patients on EHL prophylaxis versus the standard half-life prophylaxis?
Yeah.
Because the doses almost are the same, like twice a week or thrice a week for SHL as well as EHL.
Yeah, the cost is it comes through the government system. So I think it is the cost information is available. So even
Otherwise, also we need to convince these people, patients, like they have to travel again twice or thrice a week.
and most of the time this product comes as part of the system. So it's not, when it is out of pocket, yes, you have to think about that.
There is a
Yeah.
cost involved in
Yes. Yeah. Yeah.
Yeah, thank you, Dr. Meera, for such a wonderful presentation. And I would build upon Dr. Alka's question. So when we are talking of the cost difference of these two factors, as of now we know that it's twice costly.
Yes.
So if we are shifting the dose to one half of the SHLs, what you have done probably with this patient, like you are giving now, as you said, like every 10 days. So the cost is going to decrease.
Yes, and not only that, there is scope for further individualization.
Yes, yes.
You can follow them up and look at their breakthrough bleeds. If they are being bleed free, we have gone up to 2 to 3 weeks eventually. We are giving factor 8 almost factor 9, almost once in 2 to 3 weeks as prophylaxis. So there is scope for improvisation, and I think all the resource constrained countries do that, whether it is emicizumab or extended half-life, we come up with our own low doses. And I think the data is also the time taken for factor 9 extended half-life to become 1% is about 22 days. So you have that much of a margin, because as long as there are no breakthrough bleeds and patient is doing fine, you can always prolong and delay the next dose.
Thank you, Dr. Meera, for your presentation. How do you decide which patient has to be on SHL and which patient has to be on EHL? Like, how do you decide, like, what is the criteria you take that this patient I want to treat with EHL and not SHL?
Yeah, as you know, even Dr. Gupta was saying, the main thing is their distance, how far away they stay, and how much it is feasible for them to come very often. Usually when the children are very small, they can still bring the child. The schooling is not an issue, and initially the parents are also much more anxious and enthusiastic. So as if the venous access is not an issue, up to 5 years, many times we try to give them SHL also. And as they grow older, for them it is difficult to miss school and work and come often. And if their joint health is relatively okay, up to early target joints, we can still consider EHL. Once the joint health gets worse, then you also have the option of non-factor therapy. It's a continuum, and EHL is definitely more relevant in those without inhibitors. When there is an inhibitor, again it is non-factor therapy. So no inhibitors, the distance from the hospital is relatively not too far, and the joint health is reasonably good, then EHL is a much better option. And as it gets worse, the non-factor therapy is a better option.
So in your rate contract or in your RC, how much percentage you keep SHL and how much percent you keep EHL?
Yeah, initially, of course, in most systems, a small amount of EHL comes into the system, and then once we use it and we understand it, I think the percentage gradually goes on increasing. But I believe, and as we have already discussed, the SHL percentage should never become 0. Because the PK and the various data of these products and the long-term safety and the list goes on is not fully known. So the SHL products are also required, and the percentage can go on increasing over time.
This experience is the most giving a very important and the most important message for all of us and to the country is that now everyone should get prophylaxis, and it should not be the distance or something to decide which dose to be given. It should be what is scientifically right. There is lot of experience worldwide, and now all of us, including our center, have lot of patients on emicizumab and all this. So with our experience, we should tell the government that if prophylaxis, the factors have to be, or the drugs have to be given for home therapy. And for compliance, there can be website where online they upload the geotagged photo of the infusion being given while being opened or something. So compliance can be. Asking somebody to come regularly for prophylaxis is really probably defeats the purpose of giving prophylaxis. So now we have the number of patients. In UP, all patients are mapped, so we know their weights, and cost calculations can be done so that we give a concrete plan to the government. Sit together, give a concrete plan to the government and tell what is scientifically right. And as everybody has shown that it will be cost effective. So the amount of funds being used by the government for such type of on-demand therapy will be probably better utilized, and the whole next 1 year, our target should be really making systematic program meetings with the government and with the industry so that we have a plan. And I would suggest that 2025 conclave, our objective should be cricket possible. So all children, all boys want, there is nobody, I don't like cricket, but I don't know any boy who doesn't want to play cricket. And all these hemophilia patients, as Dr. Sunita said, that fear of trauma and all these things, we have to take care of that and say that every boy with hemophilia can play cricket, and maybe in a decade or so there will be some Gavaskar or Kohli or Saurabh Ganguly with hemophilia in our cricket team. So I think a targeted efforts of planning and making this possible for prophylaxis, I think 1 year would be enough to make these all calculations, and this is the target for 2025 conclave. I started hemophilia treatment in '89 because as a medical geneticist we wanted to do prenatal diagnosis and genetic counseling, but there was nobody to take care of these patients. And then in 2025 December I will be retiring, so I want that no patient with hemophilia is admitted to our ward, and we are free to take care of more rare disease patients like spinal muscular atrophy, Gaucher disease and mucopolysaccharidosis, for whom the treatment have become possible, and government is paying for their treatment under rare disease policy. So I think this is a landmark conclave where probably we just target and put our foot down with the government to say that make this possible. Thank you.
Thank you.
My sincere thanks to the speaker and chair for an enriching session. After discussing about factors and their role in the treatment, we'll now delve into our next section, discussing about making budgetary sense in hemophilia, exploring the practical approach to prioritize the patient subset and resources. For the next session, I would like to invite Dr. Tulika Seth, who will be leading as a chair for this session, and accompanied by Dr. Joseph Drone and Dr. Bobby Gulati, who will be the co-chair for the session. I extend my warm welcome and invite you all to the stage for the discussion.
So, thank you very much. We have a very interesting discussion, and I'd like to invite Dr. Rahul R., who will be presenting the practical approach to prioritize patient subsets and resources, making budgetary sense in hemophilia, and he'll be presenting the scenario from Kerala. Welcome, and please, we have 10 minutes each for these very important presentations. So, audience, please pay attention to this. This is really useful.
Good afternoon, everybody. First of all, thank you for this opportunity, because my experiences and insights in hemophilia actually begins from the last year meeting conducted in the same hall. So, from the lessons and the inspirations that I gained from the same conference last year, all the activities that I have taken up in my last 1 year has been inspired by the last year event. Thank you once again for inviting me. So in Kerala, we handle the hemoglobinopathies through our state-specific project funded through NHM. The project is named Ashadhara. It is a value-based, patient outcome-based program wherein we actually target the better patient outcomes on the same cost without additional cost burden, how to handle this. So for moving forward, there were a few steps that were taken up. The first was to analyze what is the actual situation that was existing. So if we see the system that was existing prior to the implementation of Ashadhara program, there was only one hemophilia treatment center in the state catering the needs of known cases of hemophilia, which were around 1,500 to 2,000. So another thing was there were duplication of care, fragmentation of care, which all resulted in wastage of available resources. Another issue that we found was that we don't have a robust data system wherein we can, which can help in policy making and the program framework. And also there was little awareness and focus on the outcomes and the quality of life of the patients concerned. And also, if we see the previous data, what we understand is that there was a disproportionate budgetary consumption. There is about the 60% of the total budget being utilized for the management of hemophilia was being catering just the 10 to 15% of the total patient population. So based on these things, we were ready to set up and define what the goals that we needed to achieve in the state in hemophilia management, which we again subdivided at the patient level and the health system level. So as far as the patients were concerned, we were targeting that we had to increase the disability, increase the longevity, we have to have a disability-free living, increasing the quality of their life, no structural deformities, and school absenteeism, work absenteeism, how to reduce all these things and have a better patient experience as well. When we come to the health system level, initially when it was more focused on the on-demand care being provided, how to shift it to prophylactic thing and improve the patient experiences and how to develop the access to newer treatment availabilities, accurate forecasting and the optimal budget allocation. Now, when we try to fix this concept, there were four major pillars that we focused on. The first thing was to develop a registry. We already have a hemoglobinopathy registry, the Ashadhara web portal registry, wherein we have the details of all the cases registered with hemophilia, sickle cell anemia and thalassemia. So we have 2,094 patients identified with hemophilia, and we have around 982 patients with sickle cell anemia registered in Ashadhara, but now we already have the National Sickle Cell Elimination Mission, so that is being handled. The registry of sickle cell diseases are being handled as per the sickle cell program. So that was one major achievement, wherein we can see their annual bleed rate, we can see their admissions required, we can see their factor consumption rate over the year, and all these can be used for the further policy making, etc. Another thing was to develop a state policy for the management. We developed a state policy for the prophylaxis. For children less than 18 years, we have a prophylactic treatment available in the state. We have separate strategies for patients with inhibitors and without inhibitors, and on-demand therapy as well. So other aspect was to strengthen the health system and develop a care pathway for hemophilia, which not just focuses on the factor supplementation or factor therapy, but it focuses from the prevention to the rehabilitation aspect as well, which I'll explain in detail. And the last thing was how to have these all done with the available budget. Now, if we go to each element, the first aspect that we had to fix, one was with the health literacy or the preventive aspect. So for the hemophilia management in the state, we have multiple levels of care centers. One is the daycare center, that is DDCC, District Daycare Center, we have in all districts in the state. Then we have hemophilia treatment centers, which gives the comprehensive management of hemophilia. And apart from that, we have the government medical colleges. We provide additional supports as well. And the government medical college also helps in the development of treatment protocols and all the other major complication managements. So these are basically the activities that happen in the initial blue colored part. What we see is the various levels of health prevention activities that happens at DDCC and HTC for patients and the caregivers of patients. So at DDCC level, we have weekly fixed day sessions where regular awareness events happens, self-care counseling, screening camps, and linkages to various social welfare schemes, etc. happens. At HTC, diet counseling, prophylactic therapy, eligibility awareness, awareness on target joint, advanced testing, then post and pre-surgical sensitization, home-based care training, physiotherapy training, etc. happens. So, and medical college, as I said, is more concentrated on developing the guideline aspects as well. And apart from this, we already have the family tree mapping of the patients done, and based on this, various events are being coordinated at all these levels of care. Now, when we come to the detection and diagnosis, we already have the facility for inhibitor testing at DDCCs, and inhibitor assay is being done at SDCs. It's not moving. Okay, thank you. So this is regarding the management part. For the management part, we currently have 96 centers across the state where hemophilia management is happening, including the medical colleges, hemophilia treatment centers, DDCCs, and apart from that, we provide on-demand therapy at all taluk hospitals. And at all taluk hospitals, we also give the second dose of prophylaxis. So they have to visit at least once to the DDCC, and for the other dose in the week, they have to visit only the taluk hospital. Now, coming to the rehabilitation aspect, focusing on physical, mental, and social well-being, we have targeted activities at all these centers. And here we have utilized the already existing programs, like there is an RKSK program for adolescent health. We have linked the counseling with the adolescent AFHC counselors. Similarly, we have utilized the DEIC under the RBSK program for the continuous physiotherapy of children. And similarly, we already have the support from the Panchayat Raj institutions, also from the Social Justice Department. All this has been integrated into the rehabilitation and care. Now, these are the various services which are already explained, just consolidated. Now, how then comes the point of how we switched from, started using the non-factor therapy, identifying the patient subsets. So initially, we started the non-factor therapy, that is the emicizumab, for children with hemophilia A who were inhibitor positive. So these were based on a selection criteria based on their ABR, based on their target joint or joint involvement, and multiple other factors. And based on a technical committee recommendation, we started using the non-factor therapy initially. So this is how it evolved over years. Then, after including the children with inhibitors, we are currently in a position we are supporting all our hemophilia A children with inhibitors. They are all on emicizumab prophylaxis at present. And at this point, I would like to say that we had only 2 episodes of traumatic bleeds, breakthrough bleeds in this case. Apart from that, we don't have any single incidents of spontaneous bleeds. So currently this is the status. After that, we have now started taking adult with hemophilia A with inhibitors as well. And also we have started including children less than 5 years where the difficult venous access is a major issue. And currently we have a total of 98, where 79 are children and 19 are adults. So coming to the budgetary savings in crores, here we have made use of an internationally published study for estimating this, because as per that, an ABR of around 18 was found to be there on on-demand therapy with bypassing agents. So estimated calculations has actually made this saving over the years when shifted from bypassing agents to emicizumab. But now to answer.
I have to interrupt because we do have other this thing, but I think that's very interesting. And have you published this?
No, we are on a phase of publishing.
Okay, so can you just summarize quickly?
Yeah. So that can, just to summarize, these were our goals, these were the objectives. One was to strengthen the health system, other was to strengthen the healthcare delivery, and the other thing was to have a better governance and accountability. So these are how we chose the subsets and how that has actually helped us provide quality care in the same budget or on a better, on a lower budget. Thank you.
Thank you. No, that was brilliant. So Dr. Rahul, can you join us here? And that was very systematic, and I really was impressed with the way that you had the whole life cycle approach for care and had looked at all the gaps and had converged with the health systems. So I now invite Dr. Bilal to present his experience from his state. Dr. Bilal, we're really interested in listening to your experience as well.
Thank you, organizers, and a very good afternoon to all delegates. It's a very difficult topic for me because to make the budget, I'm not the right person, but what I say is I take it as what is the standard of care. So I take it the challenge like that, but I make the budget as a standard of care. So it doesn't matter whether the administrators like it or not, I do in that way, and in a way I am getting a good budget in that way. Can move by this one? Movement? Can I move the slide? Oh yeah. This is the this year's, I want to share the theme. And with this scientific, I will go because India is the second highest this for the hemophilia. So how to make the budget? It really depends upon, every center has to make the budget on these criteria. I mean, how you have to get the registry, how many total number of bleeding disorders you are registered with your center, and what are the various types of bleeding disorders you have, like hemophilia A, with or without inhibitor, B, with or without inhibitor, other von Willebrand, factor 7, and other type of bleeding disorders. So you have all sort of that registry. Registry plays a very important role, because on that way you can just take the things. And then the severity of the bleeding disorders, like hemophilia A, mild, moderate, severe, and similarly B and other bleeding disorders, how they, what are the various severity, less than 1%, 1 to 5, or 5 to 40, mild, moderate, severe. So then you can also take the past history, what was the ABR, I mean whether they were on demand or prophylaxis. So usually previous history, when the factors were limited, so every patient was, I mean, we started in 2019-20 prophylaxis, but before that, every patient, because of the limited, availability of the factors, we started with we were on the on-demand therapy. So we compared what was the, ABR before, I mean, the prophylaxis and after prophylaxis. So that also gives some overview. And type of therapy, which type of therapy you are giving, on-demand or regular replacement. Again, on RRT, you can have the, LD, low dose prophylaxis, intermediate dose prophylaxis, or high dose prophylaxis. So you can calculate on that way what are the units or milligram, whatever drug you are using. So what is the monthly consumption of that, and what is the lifestyle of the person with hemophilia, whether it is a student, whether it is a laborer, whether it is a runner, whether it is a sports person, or what is his this daily routine. You can just monitor the activity of that patient, and you can accordingly have the levels in his blood, so that he acts as a normal person. And you should have all the weights of whatever the patients are registered with, in our center. You should have all range of weights. So I mean, I have 421 patients registered. So I have all the sort of, what are their, weight and BMI. Everything is, recorded. Although we don't have the electronic part, because it's a government setting, I am always, pressing hard to get a computer or the whatever are the software. So there are limitations in that way. Although I am getting drug, but for the software part, I am very, it is very difficult to get very small things in the government setup. So those things are very important. And then the dosage, which I have already, and then the accessibility, because ours is a very tough geographical terrain, and also the weather conditions are very extreme. Fluctuating, and sometimes it's too cold and sometimes it's too hot. So that, and accessibility and the transport and the connectivity from the other regions, because ours is a different scenario than Kerala and other states of the country, that we have only one center, nodal center in Kashmir, that is Government Medical College Srinagar. So that is there. So those things we have to get, and the surgical procedures we do, and how many surgical procedures, major, minor, and do we in a year, because we go to the back registry, and then accordingly, and how many emergencies we get before on demand and before prophylaxis and after prophylaxis. So we just take all the scenarios, these subtypes. This is very important. So then we calculate the weight and dose, and we calculate it very manually, and then see how many units we need for a year. And accordingly we prepare our budget. So this is our scenario. We have 299, 49, and all these subtypes, and 421 registered, and these are the severe ones, and moderate and mild we have all in the registry, hemophilia A, B, C, and these are the past history of ABRs. You can just see that before prophylaxis, 60% were, hemophilia, severe hemophilia, 15 times they has 15 ABRs, some 40% has 10 ABRs. So the ABR was very high. More than 2-digit ABRs were there before the prophylaxis. So, but after prophylaxis, definitely, as ma'am also said, that's a global standard of care. So this is I have taken from Dr. Naresh Gupta's this policy and protocol. So this he has beautifully calculated about a standard dose prophylaxis about different categories of the drugs, like where we have SHL, you have AHL, or you have a non-factor therapy. You can see per month consumption, like sometimes with SHL it comes like 20K, and with the non-factor it comes 91K, and with some these 1+2 the cost really comes down. So these are the different, you can just calculate the budget according to that. If you go, some go for standard dose prophylaxis, or even if you go the low dose prophylaxis, definitely the cost will come down. So how to prioritize? So there are hemophilia related and how to non-hemophilia related factors like ABR, life-threatening bleed inhibitors, target joint, and these are all factors you can just keep in your mind while calculating your budget. So this is the low dose and intermediate dose prophylaxis in A, B, 1 blend is also, and accessibility is also very important. How to calculate. So these are the, we have 109 patients which are very close, and rest all 300 patients are away from the center. And this is our the average we do at least 14 major surgeries in a year and 20 minor surgeries in a year. Also we calculate according to that. We get usually, before prophylaxis we were getting 20 emergencies in a year, but now we don't, actually we get only 1 or 2 emergencies. So this is the beauty of the regular replacement therapy. This is the way how we I have taken a screenshot from my way how we give a procurement agency our budget as annual demand. They ask us an annual demand, so we calculate on these variables. So all these variables are there. We calculate. It takes us at least 1 week manually to calculate, and then we make them accordingly. These are the number of patients, this is A, this is B, this is all the just for their administrators. This is the expenditure of drugs, and this is the, we have this year we gave the diagnostics also, the reagents. These are the reagents involved, so that because we are able to for the lab reagents, they are also, so we include that cost also. And this is the way we just give different molecules and different strengths depending upon the calculation, and total budget is about 25 CR, and they have approved it, and we have all got the factors, and this is all the things how we calculate the budget. And these are the things we have to take all these things, and but only as yesterday we are discussing, only one irony is there, that our patients have all the factors in our, the corporation. The 25 crore they have purchased, but they are not releasing. So that is the, because of the quality control issues and all those, we are struggling for that. So thank you for the patient listening.
Thank you, Dr. Bilal. We'll have the question and answer session. Please join us on the dais. So it's my pleasure to invite Dr. Cecil Ross, who has been spearheading one of the early states who got the factors through a movement of, movement through the political sections and advocacy, and he has spearheaded the hemophilia registries as well. It's a pleasure to hear from him about the Karnataka story.
Yeah. So thank you, Dr. Naresh, for having invited me to give a talk on this, making sense of the budget. How do you make sense when so many problems are there in the country? So what I will do is, I will, it's not moving. It's not moving. Oh, sorry. So what I will do is, I will talk to you on hemophilia, the progress, what has happened, the cost implications, the value of a single bleed. How much is the value when a patient bleeds in a knee joint? And then I'll tell you the practical approaches to prioritize the patient and with whatever resources we have. So if you take all this, long-acting factors was a major advance, like what we heard in the morning, somewhere between 2014 or so, that made a major impact. But with inhibitors, there was nothing much happening. At least you had a long-acting factor for hemophilia without inhibitor, but with inhibitors, nothing much came till limozuzumab. And then, of course, you have now the novel reagents, which Dr. Arianta has explained to you very beautifully. Now, if you look at the total number of patients that get inhibitors, is about 30% or so. And once you develop an inhibitor, the cost goes up from, say for example, a 60 kg person, the cost goes up to managing a 30,000 rupees per bleed to about 6 lakhs per bleed with either fever or over 7. That is the magnitude of the problem when you develop an inhibitor. So if you look at the government of Maharashtra allocation, that is the number that you see. A small amount of 1.9 crore is used for a large number of people, 4,500 or so. 97% of the population consume 1.9 crores, whereas 3% of the population of inhibitors consume 11 crores. Does it make sense? Okay. Now, if you look at the country, okay, inhibitors in the country, I mean, that is the graph that shows how much is the magnitude of the problem of inhibitor. And you can see that the the orange bars that you see across the age group, very small number. But if you look at the total number, it is quite high. 593 people in India have developed inhibitors, and large number of people are in the productive age group, about 19 to 44. Okay, so that is the problem. And how do you manage these people with the resources that you have? Now, if you take patients without inhibitors and with inhibitors, there's a greater difficulty, all of you know, of achieving hemostasis. The second thing is a 70% higher mortality in patients with inhibitor. There's increased risk of uncontrolled bleeding and progressive joint disease with inhibitors. And of course, a threefold rise in the annual cost of therapy and increased disability, increased assisted mobility devices and so on. Quality of care is very bad in patients who have got inhibitors. Now in India, if you look at and do the math, this is all courtesy listening to and talking to Joseph John, because he's interested in all this health economics and making sense of the budget. Now if you look at all and do the maths, a single bleed will reduce your life by 2 weeks, about 15 days or so, if you look at the maths. Okay. Now if you look at then the age group that we have in India. Now if you look at, say, the US or the Netherlands or the Italy, you see as the decades are going, the quality, the life expectancy is increasing across the country. In India, this is all in hemophilia I'm saying. Now in India, in 1990 and compared to 2022, again it is increasing. 1919 it was 19, 1990 it was 19 life expectancy patients inhibitor, whereas 22 it's increasing. Now if you look at the registry data, okay, it bears for the fact that we don't have many, we have large number of people between 19 and 44, but there are not many people after 45. Okay, because all of us are young fellows. So what are the parameters that we need to discuss, to take decision? Because when we have scarce resources, we have multiple competing interventions that are there, healthcare expenditure increasing, a lot of comorbidities and a lot of unsatisfied needs. Efficacy, this is again from Joseph John's thing, does it work? Effectiveness, how well it works in the real world, and what are the clinical practices we do, what are the dose we give, how we modify, what the medical staff that is needed and so on and so forth, the resources. So a unit price treatment to full cost of treating a disease. And if you look at cost effectiveness, is different from cost saving. Does it really matter that you save the cost at the cost of cost effectiveness? And cost saving, large number of studies you look at, I mean, not in hemophilia but across the world, for across the diseases, many treatments are not really cost saving. They may be cost effective but they're not cost saving. You take cancer and other things also. So now there is a societal norm. Now this is something that is important for you to understand, that how come a small population of inhibitors consume large budget of country. Now there is something called the distributive justice, that it aims to have equal degrees of power across the state group benefiting least advantaged members. They have also a right. Now there is a procedural justice where legal, hearing, so on and so forth, those are all procedural problems. And then of course the human rights which prevent discrimination again and upholding the dignity. So I think that in these type of justices, it is important that we also look at the distributive justice, that it aims to ensure equal degrees of power across social groups benefiting the least advantaged of the members. Now if you look at various factors, this I'm not going to go through because this is explained by Ariant very well. You look at the direct medical costs, the non-direct non-medical costs and intangible costs. Now look at hospital drugs, transportation, indirect costs, all these have been discussed earlier. Pain and suffering. Okay, levels of HTC, again, with both clinical variability and laboratory variability across the country, and the companies offer patient assistance programs, there is government funding and so on. So then you have the society to deal with. All these, if you look at the IECR report that says Institute of Clinical and Economic Review says that Hemlibra, which is approved, there is emicizumab which is approved by CDSCO, the society have to answer that, and they say that's a very rare win-win situation in a small popular patients with hemophilia with inhibitors, especially in whom IT has failed. It improves the quality of health and health outcomes in these patients. No much drug manipulation is necessary. There's cost savings to the healthcare system because of prolonged half-life, and there is no immunogenicity in patients with MS. When I look at the data, that is practically zero bleeds, and this is in patients who have got very severe disease. Now, if you look at again the maths of the patients with on-demand therapy with BPA, as well as patients on prophylaxis with AHF, and if you look at the maths, the cost of putting a patient on treatment with emicizumab prophylaxis is about 20,000 more per annum, and this is assuming that you have a 25 IU thrice a week. Cost per unit is about 10 rupees per unit, and the ABR is taken as 4, and 10% develop inhibitors, which actually I told you this is about 10%, which is lower than what we normally see, but about 30% develop inhibitor. But I have taken 10% for this calculation. The incremental cost of treating a patient with inhibitor is about 2 lakh per annum. Okay, so that number that you see in the budget to me is quite massive. Small person taking that much budget, but if you look at the distributed justice and look at the society and look at the process, about 2 lakh per annum incremental budget is not too much for patients with inhibitor, and therefore I'm just putting out that if you take FIBA or NO7 or factory replacement from 30,000 to 1 lakh to 6 lakhs to 11 lakh to treat a bleed, it really makes a lot of difference to take patients. And this is our own population of Karnataka, and we have about 110 plus. Mira has about 110 people on emicizumab, and I have about 15 or 18 of them, and to my mind this makes a lot of difference in people. So what do? We look at cost effective analysis. Mira sits down along with us in the government decision bodies, and we try to negotiate prices. We prioritize patient access, integrated healthcare models like we have across the country: thalassemia, sickle cell, hemoglobinopathies and hemophilia. A lot of advocacy, public awareness through Haemophilia Federation India, collaborative decision making. We all sit down, make a decision with all the government people, and then figure out who has to get factor 8, who has to get extended half-life, and who has to get emicizumab. This is the program that we have. Thank you.
Thank you, sir. Thank you for the interesting presentation. So we've heard 3 perspectives from Kerala, Srinagar and Karnataka. So house is open for discussion.
Would you like to make your own comments first? You are all stalwarts as much as you can start.
Okay, so Dr. Rahul has made an impressive MBA type presentation there. So just one quick query is, what was the data capture flow for you to get the metrics done? I mean, impressive way of putting the entire process together of structure, the processes and the outcomes. So how do you capture this data?
We capture the data from all the treating centers basically. So including the taluk hospitals when the patient comes for the infusion, either it is a prophylaxis or with a bleed for on demand.
Digital.
Yeah, digital. Yeah.
And it is a must that every patient who comes, takes a service, has to be
Has
entered
to
in
be
the system.
entered, yeah.
Without entry, it is not possible.
And this is being monitored by the nurse care coordinator at the district level.
So so you did emphasize on the accountability part through the monitoring. What were your KPIs for the individual HTCs? What is the mandate given? I mean, in the sense, how do you monitor the HTCs on the utilization of the factors?
We, whether they adhere to the protocol and use, adequate dosage is being used, and the data quality also is being assessed.
So who monitors that?
This is monitored at the state levels.
Correct. Okay, so you had some question for
I just wanted to know from Dr. Villal that we have, in Punjab, we have not got
any permission to use emicizumab, neither from NHM, and it has also not been included in the EDL list also. So we are having some problems in getting permission or to start emicizumab or to put more patients on emicizumab. How did you get this permission and how?
We are lucky in a sense because nobody raises the question regarding this thing, because we as an end user, as a technical person, what is best for our patients we decide. So we give them the requisitions that look, these are our patients. We have all the data. So we need this, what is updated science, what is required. So we need, I don't know, nobody has raised right till date, from last 12 years we are giving the hemophilia services. So nobody has raised the question why you need to have a permission for using any drug.
Yeah.
I
So
don't know.
I think so. Health is a state subject, so I think we need to go. Yes, sir. You had a question.
What Dr. Bilal has said, that it's definitely a big problem in Punjab, because I also get telephones about these. Now the biggest difference is J&K is a union territory this time. All the decisions are from, most of the decisions, they are from centers, and the local government has taken it seriously. The health and medical education is on priority list because DM neonatology has been started, and whatever you want in the interest of patient care, that by and large we get it.
Yeah, that's
That
very
is
good.
it.
So I had a question for all the three speakers. So Dr. Rahul, you said you had 2,094, and you had about how many patients? 421. How many patients in Karnataka? 2,400 patients. Okay. And what was your budget from NHM? 35 crores?
Ours was 7.7, something like that.
0.7. So in the budget allocated is not just for factor, it is for the whole thing, for reagents, for diagnosis, for rehabilitation. Is that how you utilize your budget?
In NHM budget sheet, it is mentioned for the hemoglobinopathies and blood disorders. So that covers the hemophilia and hemophilic drugs. They are not mentioning it for, we can procure the reagents also out of that.
You can, right?
Can.
So, Dr. Bilal, you got about 25 plus crores, right?
Right.
What percentage was from NHM? What was from the state?
So NHM is not yet, because NHM is support. They say us we are supporting. We can support you if somebody something remains deficient. We can support. They just go to the previous utilization.
So what is the distribution?
So we have to submit them the utilization set.
About this 27, everything is from the state as of now?
As of now, it is from state, but NHM is supposed to give some. We have given a PIP around about 9 CR.
Kerala is completely this 35.
That's your
NHM or
state.
Kerala, the total budget for hemoglobinopathies under the serial number 154, that is 35 crores, which covers the procurement of medications plus diagnostics plus operational expense of all these STCs and DDCCs. Apart from that, for the surgical management, any other hospitalization care, we have separate schemes. Like, for example, less than 18-year children, if they require any procedures which are not included under RBSK but are
So what will
hemophilic.
be the total budget? 35 plus how much more?
No, that budget we
We
cannot
don't know.
estimate properly because it is being handled by a
So nothing
state
from
health
NHM?
agency. NHM actually takes care of the diagnostic part, the medication part, the training
This is
part.
within the
and
35 or
operation
outside of
part.
the 35?
Yes.
Within?
Within that. No, I think your utilization is actually very good. My only query was, how did you find out what was wasted? Because you said there was some fragmentation and duplication. So that's always a difficult thing to track.
So that thing I was mentioning prior to the introduction of the Ashadhara program. At that time, it was the factor was procured by the government through the KMSCL Karunya outlets. So with a prescription, the patient can go to any n number of outlets and procure the medications. So it was like with the same prescription, they can go to any.
So how have
center.
you stopped that now?
When we streamlined it to the Ashadhara program, the medicine availability shifted to the hospitals rather than through the outlets.
That's very good, very good.
So one last question to Dr. Cecil. You mentioned a whole lot of principles of value and the cost. Were you able to incorporate this in any of your advocacy processes with the government, and did they take note of that?
Yeah, because Mira sits in that committee along with us, and we try to convince them that, and if they ask specific questions, we answer them with the data. So in that decision-making committee, in that NHM, Dr. Mira sits, I sit, and some other people are there. So we sort of have a meeting with them and convince them. And Mira briefs them before, I think. What is the pros and cons and so on and so forth. And so we sit down.
So we have one last question from the audience, and then we'll have to end. Yes, please.
Ma'am, I am from ESIC organization. Earlier we are getting these factors and all these drugs very easily, but from the last, I think 6 months or so, these drugs has been removed from the rate contract, and we are facing very difficulty to getting these drugs. And we are now somehow...
ESIC is a separate thing from the state, and you are independently administered, so you will have to talk to your administrators on that. But this has been a very informative... Yes, sir. Last comment, sir.
I have just one comment. I heard all the three speakers, very well spoken, and I was amazed basically to see a very good infrastructure which the state of Kerala actually has put. Infrastructure and flow system. Budget, we have to do the advocacy and get. Like Dr. Bilal's 25 crore budget for 429 patients, of which 115 are milder, it comes to about 15 lakh per patient per year. Your probably comes 1 lakh rupees per year or less than that. But the structure you have put in is commendable, and I think in the morning we heard our administrator who came and talked about the structure. Your structure is a commendable one from the...
Thank you. Now, I was exactly going to make a similar comment that we need to learn from the states that are doing well, because we don't need to reinvent the wheel, and there are other exceptionally good states, even states like UP, Rajasthan, there are many other states who are also doing well. And thank you, all of you, for sharing your experiences, and I think there should be more interactions and learnings from each other. Thank you so much.
Thank you for the thought-provoking and informative session by the speakers. Next, before the lunch break, there is a session on the management of hemophilia. I request the chairpersons to come to the dais, Dr. Cecil Ross sir, and the co-chairs, Dr. Shubha Patke ma'am and Dr. Sujata Matthews ma'am.
So moving forward, I'd like to invite our speaker, Dr. Gerald Donald, to speak about value of emicizumab from bench to bedside.
So it's just thank you very much for asking me to speak to you. I'm aware we're running behind time and lunch is ready, so I will try to make up time so that we're not deafened by rumbling tummies during this session. This is my third visit to Delhi. I've never been in the summer. Wow. So I'm enjoying this nice, comfortable environment, air-conditioned environment. I was very interested in hearing the previous discussions. It's always struck me how well Indian people speak English. You speak it much better than the majority of people from the UK, certainly better than Americans, and often better than Europeans. And yet you still make a slight mistake, as we do as well, because we all refer to registries. But if you actually look at the definition of registry, a registry is a place where a register is kept. So just to enhance your reputation as perfect English speakers, maybe a little tip. Anyway, so this is my institution in London. So many of you who have visited London will have walked past there. As you can see from this empty bridge, this must have been about 3 o'clock in the morning, because it's normally packed full of visitors. And I'm usually in about 200 selfies every day as I walk across the bridge. So these are my disclosures, and this is a disclaimer. So just to sum up some of the very interesting and very high quality discussions that we were discussing before. So this whole concept of haemophilia is basically that we are trying to generate thrombin, or the treatment of haemophilia. As you can see in this initiation phase, when tissue factor and 7A generate a small amount of thrombin, and then in a feedback with factor 8 and factor 9, very crucial, you get a big burst of thrombin, and that generates the stability and quality of the fibrin clot that we need. And it follows then that if we don't have factor 8 or factor 9, then the ability to form stable and effective clots is very much weakened. And so that governs everything that we're trying to do. We're trying to address this. And historically, the only thing that we've had to use is factor 8, which we've spent some time talking about, and I know you will talk about again. And I think in a previous talk I described how haemophilia is really quite straightforward. It's a simple deficiency state. And if you had B12 deficiency, you wouldn't give a little bit of B12, you would give people what they need. If you're iron deficient, you wouldn't give people a little bit of iron, you'd give them what they need. And yet we have never really either tried or been able to do that for haemophilia. So we spent a great deal of time trying to dance around the minimum effective therapy, which inevitably means that we get it wrong a lot of the time. So the Swedish pioneers way back in the 70s decided that rather than wait until somebody bled and suffered bad disability and maybe even risk of death, perhaps we should try and give people factor 8 before, and of course that follows this whole concept of prophylaxis. And every single form of prophylaxis is better than any single form of on-demand treatment. And there's a whole myriad of benefits, as you can see here, been summarized. And every national or international body has recognized that that is the standard of care, prophylaxis. And there have been historical attempts to define what the best way of prophylaxis should be. Sweden has always been the fat cats of Europe and Germany because they're rich and they've got a relatively small population. And they've always given relatively high doses of factor 8. But 3 times a week, and any respectable pharmacokinetic physician or scientist will say that's a little bit daft, giving factor 8 in that way. The Dutch tried to get away with using smaller doses and less frequently, and the Canadians recognized that it's very difficult to deliver high-quality prophylaxis to young children. So they start with once a week and then try and build up to twice a week and then alternate days. But recognizing that in that early phase, there's still a high risk of bleeding, which will have long-term consequences, but there isn't really much way around it. So I think all of them to date recognize some key principles, that you have to give prophylaxis early And we've been hampered in doing so because of venous access to little chubby children with poor veins and screaming and distraught parents. It's actually very difficult to establish, and so they often bleed before they get any form of prophylaxis. You have to give sufficient treatment to prevent all bleeds, otherwise you undo all of the investment that you've already made. And then, if consistent hemostatic cover is not deliverable, and I think the first graph showing the peaks and troughs shows that you don't get that with standard half-life factor rate, and you don't even get it with extended half-life factor rate. And if you can't do that, then you should institute some sort of pharmacokinetic monitoring and also institute surveillance for early signs of joint disease. And we have to do, or we should do, and we spent decades talking in very complex discussions about pharmacokinetic monitoring, based on the fact there has not yet been, until recently, a one-size-fits-all regime for patients with haemophilia, because they're all different. And many of you will have been to the presentations from our colleagues in Hamilton in Canada, where they have a computer program to look at pharmacokinetic monitoring. Fascinating and good mathematical modelling and interesting science. We almost never use it in the UK because it's too complicated. It's complicated for the staff, and the patients can't really be bothered with it. It's too complex for them too. And it's all based around, this is the sort of graph you'll get, of how having to deal with these peaks and troughs and trying to monitor to measure to guide their activities around about that. So another very salient point, we're way back, the Dutch, who, the Netherlands is a tiny population. It's probably the size of population of one city in a relatively small state in India. And yet they contribute a lot to the science or the research in haemophilia because it's very highly centralized. So pretty much all the patients are treated in one center. So they just looked at people aged 19 and looked at when they started prophylaxis. And you can see here that those that started later ended up with worse joint disease. So you can miss the boat with haemophilia. Then you pile in lots of money and effort to to maintain prophylaxis, and it will be helpful, but you won't undo that early damage, and therefore you have to start early, which means very young children. In the UK, we've looked at our situation. We were doing this before we made the switch to emicizumab as a national body, UK CDO, and you can see these graphs showing that even on those with prophylaxis, very few are on demand in the UK, there's still significant evidence of joint disease by late adolescence and early adulthood. It does work, it's still better than on demand, but you will still get joint problems. Another myth way back, I could hardly believe this, but at one point it was a policy in many countries to start prophylaxis in childhood and end it aged 18. Like somehow at the age of 18 your body loses the ability to bleed or they don't get joint bleeds, which is crazy. And again, this slide shows that you have to continue, because if you stop, you will undo all the effort. And we've heard some very interesting discussions and challenges in trying to get the budget for haemophilia. And what's the point of throwing it all away if you then just delay the point at which people start bleeding and get terrible consequences? And of course, the benefit of prophylaxis is not just joint disease, it's preventing other things like death from intracranial hemorrhage, which is a significant issue. Just as an anecdote, in one of the biggest hospital in London, Great Ormond Street, they had 2 intracerebral bleeds in young children before they instituted prophylaxis with factor VIII, and it was a terrible tragedy. And they've really re-examined their whole policy, and their whole policy now is to shift way forward in the institution of prophylaxis, which means using subcutaneous therapies, really. So that's just a run through the history. So, okay, prophylaxis definitely helps, it definitely works, and it definitely improves the health, well-being, and quality of life of patients. But does it deal with everything? So in the UK, we spend a lot of money on factor VIII. We use a lot, and we have increased our use over decades. This little blip here is because a lot of patients were dying of HIV and were exiting the statistics. But the remarkable increase has all been through the introduction of prophylaxis, and fairly intensive prophylaxis. And yet, so you would expect that we are probably equivalent with Sweden and Ireland as the highest users in Europe, if not the world. And yet, if you look at our patients with severe haemophilia, less than 30% are bleed-free. And that's despite pretty close monitoring, having a national policy, not really much in the way of restriction on factor use. And we know this is because of a number of significant challenges. One, it's intravenous, so it's really difficult to get proper IV prophylaxis in young children. So a subcutaneous administration could, and in fact in our experience has, revolutionized that. Even with extended half-life, never mind standard half-life, it's frequent administration, which will threaten compliance. And then if you could then address that by something that was genuinely long half-life, it would be a major advantage. And this important thing, this continuous protection, until the advent of emicizumab, which is the only licensed subcutaneous product in the UK, in my fairly long career in haemophilia, we've never been able to provide continuous protection, apart from those short periods of time around surgery with continuous infusion IV factor VIII. And of course, with any form of factor VIII, as Cecil presented earlier, is that you have the risk of inhibitors. So that's why we didn't just stop here, because there are still some significant deficiencies in the management of haemophilia. And so onward and upward, we have moved on to novel therapies, of which we've heard several interesting presentations. I'll just point out this slide, I think, just illustrates that of all of the emerging therapies, which are fascinating science and a real feat of engineering and achievement to deliver, but I think, this seems to be the most physiological of them, because it's using another human immunoglobulin and modified to do very similar job to factor VIII. This very consistent pharmacokinetics has meant that we get away from this bottom graph here showing this peaks and troughs and dips, and we think that's pretty much responsible for the emerging joint problems even in people who are compliant with prophylaxis. We've already heard that there's a very good body of evidence, and if you think back on the quality of evidence from some of the therapeutic agents we used to use, which was not great, the challenges now are really quite strict. The bar is quite high for anybody to bring a new drug to market. And the Haven series of studies is probably one of the biggest that have been reported. And again, just to reiterate some earlier presentations showing this marked reduction in bleeds and target joints. So it's been available in the United Kingdom for several years now. So initially, it was only funded for inhibitor patients. And I don't know what discussions you've had, because somebody was talking about the interaction between pharma and the funding bodies, but the thing that swung it in the UK for non-inhibitors were two things. Number one, overnight, the inhibitor patients who are the most disadvantaged in our population, Pareto's law, 20% of your patients take up 80% of your time. We never saw them. They never came to hospital. They didn't need to come to hospital. It was a real struggle to get them to interact with us because they're just sailing. So the big question is, well, if you could deliver that to patients with inhibitor, why can't you deliver it to non-inhibitor? And then I think Roche, without betraying too many commercial secrets, worked with the funding agencies to work out a price based on the cost of inhibitor treatment, bypass and factor VIII, to get somewhere close. So there was a kind of combined cost. And so the situation now is last year these graphs crossed. So this is the decline in the use of factor VIII and the rise in the use of emicizumab. So it's now more patients in the UK are treated with emicizumab than factor VIII, which is quite a massive change. And there's still a bit of variation in the use in different centres, and it's possibly, I think that some of them up here, like almost 87% of the patients are now on emicizumab. They're often the ones who were involved in clinical trials and got early experience. But the whole graph is shifting in that direction. In our own, this is a year or two old actually, but in our own centre we have all of our inhibitor patients are on it. We've traditionally had quite a lot of inhibitors and a large proportion are non-inhibitors. And it's roughly split 50-50 whether on weekly or fortnightly. So again, when a new kid on the block comes around, you often find an examination of their competitors, of what was there before. So for instance, nobody looked at fibre or APCC until Novo7 came along. And then suddenly a big flurry of studies and publications on it because they realised there was a threat. So I think when emicizumab comes along, there was a re-examination of the evidence for factor. So this was to describe the actual experience. I showed you a summary earlier on, really, which basically shows that a large number of our patients were still bleeding despite compliance with prophylaxis, and that the joint problems were happening at a fairly early age, and so that was driving our push forward. This is another study which was looking at patients who were already on prophylaxis, and this was an observational study showing quite a high percentage of them had target joints and more than one target joint, and that during their continued treatment with prophylaxis, their bleed rate wasn't changing. So they were pretty much status quo. So either people couldn't improve the situation by giving higher doses or more frequent, or the patients weren't taking them, or there was just it just wasn't good enough because of the lack of consistent cover. And the proportion of patients with zero bleeds and zero joint bleeds didn't change either. And most of the bleeds were joint bleeds, which is interesting. And then another interesting group of studies was done before the Haven studies. So Roche and Shugai were looking at the published evidence for factor, looking at the bleed rate across a whole range of studies. And you can see here, this covered a whole range of different factor concentrates, standard half-life and extended half-life, showing that all of them reported a significant bleed rate. So they were all having bleeds and having joint disease, despite these papers being published to justify the use of the factor concentrates. And so this is where we are on the threshold. And a lot of the discussion at this meeting has been on where the role of these new therapies will be. And I think we'd all accept that the rationale for using them is there's a problem with the current treatment. It has certainly advanced, but we're kind of stuck now. So with the Hemlibra studies, actually, the good quality studies across the whole range of them had shown this very low bleed rate, which was very reassuring. And it showed that the bleed rates reduce over time, which is quite striking. And there have been two interpretations of this. One is that the patients are more confident that they're not bleeding, because there is a bit of a change in mindset for patients when they switch to a reflex, oh, I've tripped and fallen, I better give myself factor. Oh, I've got a little bit of discomfort in my joints, it must be a bleed. It takes a while for patients to get confident that A, they don't need extra treatment, or B, it probably wasn't a bleed. The second alternative explanation for this improvement in joints is it's a bit like treating a target joint. So you give a target joint continuous treatment to reduce the synovitis and to reduce the pain. And I think myself, this is probably my own interpretation, that this continued protection against bleeding is helping the joints calm down. And patients often spontaneously report the joints feel better, which is counterintuitive, because we will always say to them, oh no, you've got joint disease, that's never going to get better. But in actual fact, it's opening up another interesting concept. And the same will happen with gene therapy. Again, one of the improvements has shown the reduction in target joints, and it improves over time. So a pretty positive experience in a large number of patients who have been treated worldwide. This, I think somebody referred to novel and then not novel. And I think you're right. I think this is now pretty established. And in fact, for the first time last year in ISTH in Montreal, I heard a couple of presentations referring to emicizumab as the gold standard, whereas it was always factor VIII before. And I think it's probably true. And I think when you're really looking at gene therapy, I think this is where you should be looking at these kind of novel therapies. So we cooperate fairly well despite what you read in the news in the UK. So we collaborate when we switch. So when we switched from one product to another, we were able to show that you don't get inhibitors, whereas it was a dogma before saying switching products gives you inhibitors. It doesn't. And so we looked at emicizumab, and again, just to check, does it do what it says on the tin? From all of these clinical studies, do you actually get this translated into real-world benefit? And it does. It shows this reduction in the bleed rate in patients who were on prophylaxis before emicizumab, and we had records going back a long time for each patient. Intra-patient, and we also saw a significant reduction in the target joints in patients between emicizumab and previous factor VIII. We only saw one antibody in 673 patients, which was 0.15%, which compares very favorably to factor VIII, and then that one patient discontinued. And we also saw a pretty good safety profile. Now, one of the other interesting concepts when you talk about emicizumab is there is this thing, I think somebody mentioned hypercoagulable state. I don't think emicizumab gives you a hypercoagulable state. It gives you a coagulable state, which is different. And I think we have talked a lot about the heart attacks in people with haemophilia, but it happens with factor VIII, it happens with bypass therapy, it happens with emicizumab, and it will happen with other things. If you improve the clotability of blood, which is what we're trying to do, then you're just allowing the natural history of what else is going on with them. I don't think you're getting an extra risk of a heart attack. It just might be, you've got a terrible risk of heart disease, and by preventing bleeding, that may unmask. And there's a wide body of literature of it happening in factor VIII and bypass therapy, and it's almost always around periods of intensive treatment. So anyway, there are real-world data, 0 bleeds in a high proportion of patients, reduced number of target joints, only one problem with neutralizing antibodies. So the other thing people think about is what to do if patients bleed, because what we're doing currently, I think the future, I think Roche are working on I probably shouldn't be saying this, but at the risk of being arrested, I think they're working on a son of emicizumab, because one of the issues with emicizumab is you cannot get the ceiling to change. No matter how much you give them, you're still stuck. But it's a pretty good level. And Peter Lenting, who does a lot of work in vitro and on animals, has estimated that the factor VIII equivalent you get, in fact, from emicizumab is somewhere between 15 and 20%, which is pretty good. So we're converting people from having severe to mild haemophilia. And so if they have significant trauma or need surgery, they're going to need help. And there's abundant evidence of the safety of concurrent use of factor VIII. So the only real safety issues were inhibitor patients getting fibre at high doses for prolonged periods of time. And in the UK, we just simply don't use fibre anymore. We only use Novo-7, which is always shown to be safe. Treating bleeds is not common. It's almost always associated with significant trauma, and we just give the standard doses that we would normally give. If they fall down a head injury, we give them 50 units per kilogram. It's useful to check recovery, but again, you should use the bovine assay. But if you know the patient doesn't have an inhibitor, it's probably not necessary. Similarly, surgery, again, very straightforward. We use exactly the same standard dosing. We've had 10 arthroplasties, a TAVI, cabbage, abdominal surgery, and they've all gone well. And it's interesting how knowledge and real experience changes over time. Because at one point it was said that if somebody had to have surgery on emicizumab, you'd have to stop the emicizumab, wait 3 months and do the surgery, which is nonsense. Anyway, very, very, very quickly, even though I'm well within my time, so the other therapies, what do we think of those? Because they will be licensed soon. So the strengths are that they are subcutaneous, continuous protection, not affected by antibodies, shouldn't generate. You can use them for haemophilia A and haemophilia B. The big problem is conceptually, this is a complex system we're dealing with here. And one of the issues I have concerns with, do we really know what we're doing by interfering with that in every circumstance? If you look at the trial recruitment for these studies, such as anti-TFPI or fituzaran, anybody with a risk of thrombosis or cardiovascular disease is excluded. So you're dealing with a fairly clean population, often children. Do we really know what it'd be like? Are you confident you could risk profile your patients to be able to use these new therapeutic agents and in every circumstance? Because we know, for instance, that TFPI is involved in inflammation and infection. So what happens if somebody gets sepsis as well? Fituzaran was halted because of one thrombotic death, and there were other non-fatal thromboses. And it works at preventing bleeding, but we also look after thrombosis patients, and the antithrombin levels you get down to are pretty scary. And certainly if the patient didn't have haemophilia and had an antithrombin level of 20 or 30, you'd be pretty worried about them. So what happens if they come in on a Sunday night at 11 o'clock and they've had a car accident? Are you going to just give them factor VIII and leave them with an antithrombin level of 20 or 30? Or do you also have to give them antithrombin concentrate? And I've never actually been to presentations where people have convinced me that we have a clear policy to know what to do in that situation. So I don't think personally in the UK it will take off for factor VIII. With anti-TFPI, again, I like to think, so my colleague Mike Lefan at Hammersmith does a lot of presentations on this. It's a bit like you don't get anything for nothing. If you drive the hemostatic process to prevent bleeding, you probably inevitably run pretty close to thrombosis. And if you drive it really hard to get zero bleeds, then I think you'll probably tip over. And perhaps if you don't drive it that far, it won't be so good at preventing bleeding. So it's a very dynamic situation. Bayer ceased development because of several cases of thrombosis. Novo halted because of thrombosis, but then restarted. And Pfizer have no reported thrombosis. But it does seem that the risk is probably class-related than rather drug-specific. And then I know that Savita, my colleague and friend, is going to talk to you about gene therapy. But is that the nirvana? And the answer is no, not yet. In the UK, it's now approved. We can prescribe factor VIII and factor IX gene therapy. Factor IX gene therapy, a lot of interest. It's much easier. The results are better. Factor VIII gene therapy, it's still a big gene. We have to chop lots of bits off to get it into a vector. And then the other interesting thing, there was some great scientist in Montreal last year was explaining hepatocytes don't normally make factor VIII. Hepatic sinusoidal cells do, but so we're forcing a cell that doesn't make factor VIII normally to make factor VIII with gene therapy. And so it's still very early in our experience to know what's going to happen. And so this is the latest results that were presented at ISTH showing you get a response and then it sort of tails off. And then where does that go? Because we still don't know. We haven't extrapolated right out to the end. So is it worth using? And then there's a significant number of people who have returned to prophylaxis, and we have that experience. We have patients in the first biomarin trial and some are now on emicizumab. It is a wake-up call, though, because I know that India is very interested in gene therapy, and you've got a lot of innovation going on. And gene therapy will come at some point. But what's the point of delivering somebody to gene therapy with their bad joints and disabled and a poor quality of life? Because it's probably not going to get a whole lot better post-gene therapy, and therefore you've undermined the optimal outcome from that treatment. So maybe we need to up our game now to make sure that patients go into those programs in a much fitter state. So just to end, prophylaxis, we really need to think about making it easy for the patients and ourselves. There'll be far more compliance. We would prefer not to monitor. The whole reason we're doing all this measuring and monitoring is because we know that we are in danger of getting it wrong for a lot of patients with factor. And maybe over time, and we're thinking about this now in the UK, how much attention do our patients really need when they're on these treatments that deliver a pretty much normal life? And one thing I would ask you to reflect on is how much monitoring and attention do you give to your mild haemophilia patients? They do need some, and that's effectively what you're creating by putting people on this treatment. Okay, so I think it's a fascinating time, and for all of you who have had experience of the bad old days with treatment, and for those of you who are entering haemophilia at an early stage in your career, it's a fascinating time. And before, it was a pretty dull. There's one variation of factor over another, and it was really difficult to convince anybody there was any real differences between them. But this is totally different. It's a game-changing situation. In the UK, it's only improved subcutaneous prophylaxis, probably in India too. It is now our #1 treatment. So here's another interesting thing, because there are going to be new variations, and Mimi's going to come along, and then even the son of Emmy is going to come along. Given that patients don't generally bleed and have such a good level of outcomes with emicizumab, how would you show a difference? How would you show a difference between the different products and even gene therapy? It's going to be a real challenge. And if you went to your payers and said, oh, I'd like to use this new treatment, they'll say, well, what advantages can you prove it's going to bring, particularly if there's going to be any financial issue? And I think that's something we need to really think hard about, is generating meaningful and effective outcome measures for our patients. So I've kept you from your lunch long enough, and I'd like to thank you again for your attention, and happy to answer any questions in the lunch break. Thank you.
Maybe one question also. Any burning question? Yes, sir. Yes, Aryan.
If a patient or any emicizumab needs surgery, should we wait for the bleeding to occur so that we can start the factor, or should we start the factor along with the emicizumab? Patient is already on emicizumab, he requires surgery, because emicizumab is prophylactic drugs. It must have prevented the bleeding. Should we start the factor before the surgery so that the bleed is zero, or should we wait that bleeding, if occurs, patient should be given factor rather than preemptive treatment with the factor?
So it's a good question. So again, this is a conceptual one, that haemophilia patients and parents and doctors have been brought up to think any bleeding is abnormal. So if I fell off the stage and hit that statue, I'd probably get a big bruise and I'd probably be bleeding. But I don't have haemophilia, and I'll stop bleeding. And that's the concept that we have to get across to our patients with haemophilia. If they fall on the playground, they will bruise, but it's not a disaster. And so what we say to them is wait for an hour, and if it's settling down, then do nothing. Just take some paracetamol. For serious bleeds, if somebody has a car accident and a head injury, then we don't wait, we give them factor, because it's how you would treat somebody with mild haemophilia effectively. And for surgery, then you're not really, I mean, for minor procedures, so we've had people having ports removed, dental surgery without additional treatment, apart from tranexamic acid. But for major surgery, you have to give them factor. And that's the one area that for the hospitals, they just need. And it's it sounds complicated, but it's just simple to have the assay available to measure factor rate when somebody's on emicizumab. So you need the chromogenic bovine. But I'm sure Roche or Shugai, whoever's managing, will help you in that situation. But the one thing we doctors are really bad at is telling the laboratory. So you have to tell your laboratory colleagues the patient is on emicizumab, otherwise you'll get unreliable results.
Yes, sir. Yeah. Last question.
Sir, thank you, sir. So this is regarding emicizumab dosing in specific needs. As you have more and more adult patients, and a lot of time, at least in our experience, they have obesity and extremes of body weight. Sometimes they have renal failure, and sometimes they have liver issues. Maybe they have hep C, and so one, is there a capping dose which you practice? And in obese patients, do you take the actual body weight, or do you use the adjusted 50 body weight? This is the second thing. And do you think that at least in these special group of patients, we need to monitor? And if we have to, like routinely, we are not monitoring patients on emicizumab. And if we have to monitor, what would be the test of choice in the ones with inhibitors and without inhibitors?
So all very good questions. So we do cap, and I think it's in the official SPC for emicizumab, they're capped at a certain level. I think all of the official dosing is as per the SPCC for EMI, so we tend to follow that. But I think with the advent of experience and time, we will probably fine-tune it a bit better. We do measure the emicizumab levels on patients once a year. And we do that largely for a check on compliance, to make sure they're actually giving it, and also just to reassure ourselves that the patients are in range. And the vast majority of cases, they are. We've come across a few cases where people are a bit lower, and so we've had to investigate. It turns out the technique is all wrong. So we have to slap them around and get them trained by the nurses again. And we found that helps. We do find some patients who are slightly higher than the therapy range is probably still a bit crude for ME, and we're not quite sure what to do about that. Should we reduce the dose? I think one other thing that we should think about is that sometimes there's minor variations on our dosing just on practicalities. So the vial sizes, we don't want to be breaking vials or throwing stuff away. So we'll often change the frequency of administration to make the best pharmacokinetic sense. So the bottom line is, I think, given your interest, and a lot of people are very interested in it, you might want to look at levels over time. You might find some interesting data to do further studies on. What the Dutch have said, and I'm not advocating this, I'm not advocating it at all, or else I'll be shot by Roche, is the Dutch looked at people who were a bit under the therapeutic range, and they found it was just as effective. So the patients were not reporting bleeding. So I think what we don't have in the way that factor VIII, we don't have a clear level to fine-tune, but I'm not excluding that as a development as time goes on and our experience continues. But what is clear is very safe over a wide range of levels, and it's very effective over a bit of a range as well.
Thank you for the very nice talk. We are all thrilled with this particular drug, and in India now many of us are, our patients are getting this game-changing medicine. So it's time, I realize that many centers are giving and the numbers are quite big. So it's time that we should collect the data of all the patients on emicizumab from India. Not only for publication, but to make cost calculations and put the facts and figures to the government, so that whatever your policies you are suggesting that are supported by the data on the Indian patients, and we can make our case successfully with the government for funding. Thank you.
Lunch?
I extend my gratitude and thanks for all the chairpersons and the speaker for an interesting session. I am certain we are all famished by now, so I request everyone to please join us for lunch as the food has been served. This is going to be a quick break as we are running short of time, so I request everyone to gather back quickly so we can re-begin our session. Thank you. seated on your places. Please be seated so we can move forward with the next session for the day. As we are running late, let us promptly resume the session. I trust all of you enjoyed the delicious lunch and we are ready to continue. As we continue, our next session features a panel discussion on the optimal care of hemophilia in India. Let's engage with our experts as we delve into the crucial topic. For the next session, I would like to request Dr. Sheikh Ahmed Bilal to please come on stage as a chairperson for the next session. And also I would like to request Dr. Naresh Gupta sir to please come on the stage as moderator for the session. The panelists for this session is Dr. Tulika Seth, Dr. S.P. Verma, Dr. Joseph John, Dr. Cecil Ross, Dr. Anupam Datta, Dr. Poonam Diwan, Dr. Ruby Khan and Dr. Gerard. I request all the panelists to please come forward on the stage so that we can resume with our session.
Welcome back. Very good afternoon. We'll have a continuing session on optimal care of hemophilia in India, where emicizumab does play the role in improving quality of life. ये आप कर रहे हैं? ओके. Where is he?
Thank you. So let me start with what Dr. Gerald was talking about. We will be restricting to hemophilia A, which is the deficiency of clotting factor 8. I don't know why this factor 8 is troubling us so much. Tulika, why do you think this factor 8 is troubling us so much? We don't know whether it will come from liver or it will go to damage the liver when we are doing some extensive therapies. We don't know why we can't do with replenishment. Iron deficiency, you give iron, it goes up. Vitamin D, it goes up. Diabetes, it goes up. Why is factor 8 misbehaving?
Why do we have factor 8 deficiency or?
No. You see, the point was we have many more drugs coming up for treatment of hemophilia A, that means factor 8 deficiency. We are still happy with the EHL for factor 9, number is small and they seem to be behaving well. But here we are not achieving. We heard that if you replace clotting factor 8, maybe about a third of them will have no bleed, which is not a very good scenario. So I was extrapolating from there, is it misbehaving? We give good dose and still it does not. If we give more than that, it also will have thrombotic impact, which is unlike other clotting factors. High factor 8 level is associated with the thrombotic effects.
Absolutely, and in many inflammatory conditions, factor 8 is high.
It's non-specific.
And, and often we worry about those patients because they can have thrombosis, and when we're doing surgery, we have to monitor the factor 8 levels, because if you go above 100, you may again induce thrombosis. So I'm not sure why it is so problematic. It is too much is not good and less is obviously not good. But we know that factor 8 and 9 are not exactly the same. Factor 9 has a lot of extracellular distribution, and that is one of the reasons why some people think that people with hemophilia B have less bleeds or maybe have a milder phenotype than hemophilia A. So I think there's a lot of things that we don't know, but I think what is important to emphasize is that with our standard half-life clotting factors, and even for patients who were on prophylaxis, we were actually told that when we kept the trough levels less than 1%, the ABR of 0 was probably not going to happen. So that was something that we accepted, because on-demand therapy, patients would have ABRs of 20, 30, and so we thought, if we have ABR of 1 or 2, that seemed good enough, but I think the goalpost has definitely changed now.
That will change. Dr. Cecil, factor 8 doesn't seem to be coming up to our expectations, but non-factor mimetics seem to be exceeding our expectations. Where is the catch?
So the catch is, I think, in our mindset. See, factor 8, I cannot remember a single drug or therapeutic agent in medicine that gets approved with a 30% inhibitor level as a side effect, and still we say it is safe and effective. It is not safe. It is not. So the question also is that, once you develop inhibitor, it's a big nuisance because patients die early, they bleed much more, it's misery. So that's what I'm saying, that though the other thing is, you see, factor 8, again, if you look at the CPET study and, which I was involved in a little, I am biased on the CPET study, that if you take plasma-derived factor, which is von Willebrand rich, the level of inhibitor comes down about 20-25%. Okay, so it's safer. Now, why is that? Because I believe that when you take a plasma derived, it is more in conformity with the normal plasma that we have, plasma factor 8 that we have, in contrast to the recombinant factor, which is basically a foreign protein. So any foreign protein by default will have its own antigenic differences and will have its own antibody responses, and therefore the effectiveness of it is questionable. The second thing is, if you look at the evolution of factor 8, You had first the whole length factor VIII, then they said B domain deleted factor VIII because you want to reduce the size of the factor, and then you said B domain deleted all bad news, so we don't want any factor, so they put it a truncated deleted factor VIII. They said that if you truncate and keep a little bit of B domain, then it's better, is less inhibitor. So it's not really the factor VIII, but there are a lot of things which we don't understand about factor VIII, and therefore, I think still that plasma derived factor VIII with which is von Willebrand rich is more in conformity with our own immune system, and our own immune system will recognize it as self, and therefore the chances of inhibitor in plasma derived von Willebrand rich activity is not there. Therefore, but the only problem is how much of plasma derived factor is being used is a questionable thing, because you can produce only that much of factor VIII, plasma derived factor VIII. Whereas in normal factor, in recombinant factor, you can escalate the production to astronomical levels. But in factor VIII, plasma derived that much only you can make. So that's another thing. So supposing we had only safe plasma derived von Willebrand rich factor, I suspect that life would have been better. But you cannot scale up the production of this product.
Okay.
So there are those issues with normal factor VIII and recombinant factor VIII.
So it is a little more complex.
Biology is different.
What we think it to be. Yeah. Dr. Donor, you did bring out the benefits of the clotting factors versus the mimetics, and you spoke on many things. The question we were talking about was, is factor VIII really behaving differently? We use many proteins for treatment of many drugs, all antibodies, specific, even normal immunoglobulins. We do so many. Do we know of conditions where 30% of them go into not formation of antibodies, but inhibitory antibodies? Or is this unique situation?
Is this on? Well, I guess we have people with rhesus, or people, and certainly in the UK, a big problem in the sickle population is the fact that many people of Afro-Caribbean origin don't donate blood, so they're getting Caucasian blood groups, and they develop antibodies, and it makes it very difficult to cross-match. So people will develop antibodies against it. I suppose the question is why more people don't develop inhibitors if they don't have the gene. It's a bit surprising that an even higher percentage do. The CIPIT study is interesting because I think I know that India participated and Egypt and Flora Pevandi produced apparently clear results. But it's a bit odd because in the UK, where we have used recombinant for decades now, our inhibitor rate is about the same as the plasma-derived arm in CIPIT. So in fact, there was no real incentive for us to switch to plasma. And I don't know if you're aware in the news, but this infected blood inquiry in the UK is very hot, and it's actually going to report on Monday. And it will be pretty devastating for some of my former colleagues, many of whom are deceased. And it's all about how you manage the risk of an unknown risk of infection. And I think one of the things in the UK that persuaded us was, if you accept as a reduction in inhibitor rate, what's the trade-off? So if you or your family were presented with two identically therapeutic agents, one was made from 20,000 donors and one was not, which would you choose in an era where zoonoses are becoming increasingly of a concern? And one of the issues, many of you are too young to remember, but one of the issues with HIV was that the majority of patients in the UK were infected before anybody had heard of the word AIDS. And the vast majority had been infected by hepatitis C decades before it was identified as a viral agent. And that's one of the issues about continuing to use plasma. And it's what drove the production of recombinant, because the haemophilia community asked to be released from the burden of infectious disease. I know it wasn't the same in India, but in Europe and America, if you went to a haemophilia conference in the 80s or 90s, it was completely dominated by infectious disease and how to try and get rid of them from plasma. And now it's barely mentioned. So it's been a huge advantage. And I think one of the reasons why there might have been a delay in development is there was such a rush to get recombinant on and used that then was a taking stock of, well, what comes next? And then once people could breathe a sigh of relief and not worry about infection, they started thinking about efficacy. And that's when things went along, I think.
That's a very, very important point. We tend to claim that the plasma derived is as good, as safe as the recombinant. But there are good scientific reasons not to think that it might always be true. The uncertain microbes that we are not aware of, we don't know. But one more important point that has come across, which Dr. Donald is making, is the HIV story in hemophilia. And mind you, hemophilia was the one that bore the brunt. All HIVs nearly of that time have died, so hemophilics have died because of HIV. It has not gone away from Europe, it has not gone away from Scandinavia, it has not gone away from America. In fact, HIV may have been swept under the carpet was it not for the hemophilia fraternity. It was initially called the gay-related immunodeficiency syndrome, GRID, and it was attributed to the abnormal sexual behavior. It is only the hemophilia fraternity. In America, it has been the Holocaust. In Britain, it has been the parliament that has been bearing the brunt even now, even when, how many, maybe 10% patients would be left or fewer than that, I don't know. In Scandinavia, the Danish health minister was flashed out on the newspapers as Dr. Death. In Sweden, they did a different way. So the impact of doing something wrong can have very long lasting effects. And that alone can become a good reason. And Dr. Cecil Ross said, what kind of a drug is it? 30% side effects, serious side effects, and we call it is effective. Maybe we have, beggars can't be choosers. Dr. S.P. Shalendra, we were speaking about these antibodies. So naturally occurring clotting factor or plasma-derived clotting factor 8 causes these in 30%. What about the monoclonal antibody? That is also a protein. It doesn't cause emicizumab.
Yes, sir. So the thing is that routinely the tests are not available to check whether how many patients are developing antibodies. But if you see the Heaven studies where antibodies have been investigated in these patients, so very few patients, maybe 1% or so, they develop antibodies against these emicizumab, and most of these are not destroying the effect of the drug. So they are non-functional type of, just detection of antibodies is there. So that is what is happening in current scenario.
So it brings us back to the circle that Mr. Factor 8 is actually very
debilitated,
difficult. Yeah. So we heard that it is 1 out of 700 something that had the antibody effect, and but Anupam, even if it is infrequent, now we are seeing 1 in 600, 700. Eventually, 100,000 patients or 1 million patients may be taking the treatment. If you have to go by Alfonso Lorio, that the number of hemophilia patients actually may be 3 times of what we estimated earlier, 400,000. So if hundreds of thousands patients are going to take, these side effects will also become important, antibody side effects. Is that so?
Yes, sir. Obviously, if the number of patients are, more patients are on, we will identify more patients. But I think, sir, they say in India where many cases are being undiagnosed. Who are being undiagnosed? Who are not bleeding? So probably the milder cases are not the bleeders, they don't have the phenotype, and those, and we also know that the phenotype keeps on changing. not all patients with the same level of factors. So not all of them will actually go to a proper treatment with the frequent dose, and we are also doing in a low doses. So who knows, many of them may not develop the inhibitor which we are saying. So it's only time which will say, but till now the record shows that the inhibitor development is quite low, and if though they have that, still they are clinically they are not that much affected like those in case of those with factor deficiency with inhibitors who bleed profusely and need a lot of much care. So, but it's an open question and open answer, sir. Time will tell.
So science says that antibody formation is not really dose dependent, even though it might need a certain criteria. So Dr. Joseph, we come to the scenario that even these mimetics, the antibodies, may not be required to be used for all the patients, mild, moderate, and everything else. So do we have some areas where we think it is going to make a bigger difference than the standard recombinant or otherwise factor 8?
Yeah, so like we discussed earlier also, the in a resource constrained setup, if you were to use, the top priority would be to pediatric patients with inhibitors. That's the first choice. Then would be adults with inhibitors.
So those with inhibitors, nobody should have any doubt?
No doubt.
Nobody should have any doubt. So if, I'm sorry to stop you here. If hemophilia A with inhibitors, the drug of choice, is not only the drug of choice, it's the only drug, is emicizumab, is that a strong reason that it should be made available on priority?
I would say absolutely. If it is a resource optimization situation, then I would say at least for pediatric patients with inhibitors, at least they can prevent the damage, because the consequences of using the alternative bypass agents of factor 7, cost-wise and efficacy-wise, would be much lower as compared to emicizumab. Much higher.
Much higher.
That will be high, yes.
Dr. Bilal, I think even Haven studies speak of inhibitor patients being treated actually have a marginally better response, though not statistical, compared to the non-inhibitor patients. So it should be given to all. Will it benefit treating inhibitor patient with emicizumab much more than treating the non-inhibitor patient? Case to case basis.
I think to my experience, when we started in June 2021, we started with the inhibitors. We had 14 patients of inhibitors, so we started when we got the emicizumab. So we just directly put first on the patients who are on inhibitors. So ultimately, by time, just by observation, we saw that their life has dramatically changed. Their lifestyle, the quality of life indexes, they have dramatically changed. So after 1 year and 2, and now it is 3 years now. So in between then, we got the resources also, and we then shifted to the pediatric age group. So less than 16, 18 years, because we didn't want them to become, specially able, right? So in that context, we started with the pediatric age group. So we, without inhibitors also. So I think now right now we have 102 patients on this Haemophilia from this. So, but as per the clinical response and the lifestyle changes, it is an amazing thing that we are seeing that all the indirect costs, even in the previous slide I have said that we are getting 20 emergencies per year, but we are not getting any emergency now from last 2 and 3 years. So that hospital cost, travel cost, admission, direct, indirect cost, so that has really gone away, and even our wards are very empty, which were very full. So that is gives us satisfaction.
We want to make the wards and healthcare workers redundant when it comes to
for other people, right?
Yeah. So the other thing is, with respect to what Bilal was saying, supposing a child with inhibitor, definitely yes. Any child with or without inhibitor who has had a CNS bleed, you have to give emicizumab. Third, any adult with a single episode of IC bleed will have to be given. So these are priority people. Any child without veins or difficult to find veins will have to be given. So there are some critical areas, and if you want to restrict the use of emicizumab to certain target groups, I think these are the 4 groups that is very essential to be able to give emicizumab. The remaining all depends on many other factors.
So that's very well brought out, that the one major one was the presence of inhibitors, and the 4 others where emicizumab would stand out to benefit these patients would be what Dr. Ross has said and is listed here. Dr. Ruby, you use a lot of this. Do you find particular areas where it could be very foremost drug, choice drug, the emicizumab, apart from the conditions that you heard?
So definitely, like we are just started with this emicizumab in our state. So most of the doctors who asking, basically those are asking for the drugs with like the pediatric patients, which like only single episode of bleeding or no episode of bleeding with known history of hemophilia, or they have recently diagnosed with hemophilia, to give better care or better life, quality of life to those children. So I think, sir, I don't like apart from these things.
But you are using it.
Yeah, we had started recently,
Dr. Pooja, what about you? Are you using it?
So we are not using it because we don't get it through the hospital supply, and our patients are, most of them are not CGHS beneficiaries or ESI beneficiaries. The drug is still to be approved for Delhi government hospitals usage. And whenever we send a demand to procure the drug on grounds that we have a patient with inhibitor, a child with inhibitor, it's cut down straight away saying that you already have factor with you. Why do you want this drug? Treat with factors. This is outrightly cut. And one patient we did manage to treat with the help of support from an NGO, and the child showed dramatic recovery in his joint health, and he was not able to stand and walk, and he was kind of literally walking at a good pace, literally running, sir. So
was he with inhibitors or without inhibitors?
He had inhibitors.
He had inhibitor. So how do you treat your patients with inhibitors if they are not giving you emicizumab?
So most of the times what we have treated with FIBA, and we have used FIBA prophylaxis also, but then again we are very cautious because of the risk of thrombosis is always.
But did you not tell them it is so expensive to use FIBA as a prophylaxis?
So, FIBA they gave us in hospital supply on local purchase, but emicizumab is refused.
So
it is
I
costly.
think we need to rationalize it. The points are very clear. We are coming to conditions where it makes a difference, but here is a lady who cannot use any drug, effective drug for hemophilia A with inhibitors. Sir, first you, then Dr. Kaur.
Can I add? Means yesterday evening we discussed that money should not come on the way when you are discussing science. So if that part is taken, and we have heard about emicizumab, in that case 100% of the severe hemophilia patient should get emicizumab. Whoever is going on prophylaxis, that is number one. But anyway, that is not the ideal world. We live in a world which is much more restricted and different. If we consider that part of the story, then we have to rationalize, as has been started, that we start with children with inhibitor, children without inhibitor. You wanted various other subcategory where it can be used. One subcategory could be, as we have repeatedly said, that look, children below 2 years, if they have severe hemophilia and you need to give factor, they are at high risk of developing inhibitor. So either they should be treated with Novo-7 or up to at least, and then so they become one group under 2 years severe hemophilia. They become one of the group where this could be given. Then you see, inhibitor is not really in hemophilia, is not uniformly distributed in all genetic category of hemophilia. Obviously, we say inversion 22 has an intermediate high risk. There are certain moderate hemophilias these are known as high risk mutation. There, if you give factor 8, he will develop hemophilia inhibitor. 15, 20, 30% will develop hemophilia. So, if in an ideal situation, if someday we can do the mutation of most of our patients, and if some of them come to be known as a high risk mutation patient, they ideally should get. Then we know, it has been discussed, that under what circumstances we develop inhibitor. Factor 8 is one circumstance. You asked why factor 8 is the culprit, immunoglobulin is not. Because in that way, factor 9 is not culprit. In hemophilia B, we are only having 3% patients who are having this kind of thing. But factor 8 is there. It has different reason. First of all, it is a glycoprotein. It is a very, very big protein. So it has very many kind of thing. And it comes from evolutionary from a gene which is discoidin gene, which is related to a fungal kind of gene, and it has relative affinities with factor 5. So it has many reasons why factor 8 and inhibitor can develop, even in normal people, even in otherwise normal people, though that inhibitor is different, if you give a sufficient inflammatory stimulus. For example, in a normal individual undergoing cardiothoracic surgery, a normal person undergoing a gastrointestinal surgery, a small proportion of them will develop spontaneous pregnancy, will develop inhibitor. These inhibitors are different from the inhibitor in hemophilia. So there are a lot of reasons for development of inhibitor. And mutation under 2 years of age with severe deficiency, where chances are there, and of course all these things have been discussed.
Thank you for clarifying. I'll just this is so important, and you said, I am told that NHM has created their own essential drug list, and they have not included the non-factor mimetic. Is that right? Yes. And that also happens to be the reason they said we don't have it in our EDL, essential drug list, so we'll not get it for you. Who makes the EDL? Doctors. No administrator will put his thumb on a list which concerns health. Doctor, you want to say something? No.
No, WHO have an essential drug list. In that there may not be
They have cryoprecipitate, you said. He said.
Cryo will be there for different reasons also.
Yeah, we discussed that yesterday. Dr. Donald, I want to come back to you. Emicizumab is one drug that has been studied in children also. Otherwise, we don't treat them. They have gone down infants also. Is it approved for that in UK?
Yeah, in the UK, it's approved for everybody with severe haemophilia, irrespective of age,
irrespective
or
of
inhibitor or non-inhibitor.
Your restriction the button you are asking, you ask about FDA.
Okay.
Why the government has not put in the AD?
Okay. Let us hear so that we
can
address
actually,
it.
in my view, because I am the when the EDL is going to discuss, like the policy of the government is the EDL means that drug, because EDL, the list of the EDL drugs are separate for each facility wise. Like for PSC, the EDL list is different. For CSC, the EDL list is different. For DH, the lists are different. EDL means it is an essential drug list. That drug must be available in those facilities in all over the state. So the drug, it means that because there are certain KPIs of that state which regularly monitored by some software, like every state may have some software where there are some points for availability of drugs. So what happen when these kind of high cost drugs, if like it is like mandate for each and every facility to make these drugs available in each district hospital. Like if you'll ask me for Madhya Pradesh, we are having 53 or 52 districts. So once I will include these drugs in the EDL, then whether the patient is not there or not there in that district, it is mandate for that district hospital to keep that dose or drug in that facility.
Is that doctor's opinion or administrator's opinion?
This is
That the
doctor's
cost
opinion.
is doctor's opinion.
Yeah.
A doctor
Sir.
should not think of drugs. Now
Sir,
tell me
sir,
one thing.
sir.
Tell me one thing. Is clotting factor 8 included in the EDL?
So this year, like in
No,
since-
no. You just tell me as of today, is clotting factor 8 included in the essential drug list?
So now it is included only, I think, because there are a lot of advocacy
Sir,
from the patient side.
sir, one
Otherwise,
point.
previously it was not there.
It was not there. So we still have to educate them. We have to tell them, Yes,
Sir, the
that
point
is the last comment.
Yes, sir. The point I wanted to make was, it was there in the EDL.
It was there in the EDL.
My question
Look
is,
at that. They
who is-
removed it.
So it is not why it is not being added. Who removed it?
No, no.
It was there in the EDL.
Emicizumab.
Emicizumab was there in the
What
EDL.
is he saying?
No, it was not in the
It
NHM.
was. So what happens in NHM?
NHM में तो factor ही नहीं था list में.
No. From my state, I'm saying.
I am Government of India EDL. I am talking about
Okay,
the
so
Government of India EDL.
no, they say
One question is there. Now, is it as per Dr. Ruby said? So it is better to have EDL, these drugs in EDL or not?
So there is a
No,
solution
no.
for
My thinking is very clear. I have treated hemophilia since 2007-8. It never was there, and I never wanted it. I don't even care, because if it's a drug that is going to be used for a handful of patients, you don't want to send it to districts, and that is what it happened. That when we put it on the EDL, the corner villages and districts start asking for it.
Yes.
So I never wanted it. But now what has happened is administrators are taking it as an excuse to deny it. And in Delhi, I have recommended it for the EDL, so it might come. But that is a wrong way or a oblique way of getting a drug. Anyway, I think we'll have to, I'm sorry, but we'll have to cut short because Dr. Savita Rangarajan is waiting online, and that is also a very exciting session.
Sir, can
But
I add just one question?
yeah, please, Dr.
Yeah, so like there are many states which are thinking of it, and even now you are discussing it. The thought is to first give priority to pediatric patients with inhibitors. Okay, I want to present some scenarios where, for example, we have many adult patients with inhibitors who at least once or twice a year they are admitted with major bleeds. Major in the sense psoas bleed, epidural bleed, liver bleed, splenic bleed. Okay, and if you have to choose between such a patient and a pediatric patient who is positive for inhibitor, if he is also a major bleeder, it is different, there's no doubt. But he may only be positive for inhibitor. For all you know, if you do after 6 months, it may be a transient inhibitor, and the inhibitor may go away. But he is largely asymptomatic. If we have to choose between such a pediatric patient and adult, and whereas you have a guideline which wants to give preference to pediatric, then the pediatric fellow will win rather than the adult who's a heavy bleeder who is going to utilize crores of government fund when he bleeds. So why are we putting it in print? It is for pediatric. Why can't it be patients with inhibitors with recurrent bleeds? So what is the logic? Why do you want to give it to pediatrics only, irrespective of their phenotype? Why can't the bleeding phenotype in a patient with inhibitor be a better choice? And what was the thought behind
Somebody
making
has
it
to-
only for pediatric as the first preference? Because
Okay.
that should not be the logic.
Yeah. Can I, Dr. Meera, can I ask Dr. Bobby Gulati to answer?
Ma'am, we have made a policy regarding it. First criteria we have kept patients with life-threatening situations, patients with life-threatening situations, irrespective of age. Then the age comes, then high titers comes, then
Major
patients,
bleed. It should be major bleed, not
major bleed,
life-threatening.
life-threatening or major bleed. Then lastly comes the patient who consume most of the budget.
Yes.
Even the patients who are consuming most of the budget, we include them in the for the consideration for emicizumab.
Just a positive inhibitor report should not be the license for MS.
We agree with that. We agree with that. That is, there are very good studies from the Korean Haemophilia Association, but I think we will have to end here. I would like to end only with one thing, or rather two things. One is in hemophilia, treating a patient with hemophilia with standard of care, which should be regular replacement therapy of the deficient protein, brings in unparalleled benefits to the patient. And to my information, these are unparalleled across the medical science. The armamentarium of drugs, if it is expanding, it is so much the better, because it gives an opportunity for us to rationalize their use so that we can achieve health equity. I think I am being told that I have overstepped my time so much, so I take this opportunity to thank you, Dr. Tulika Seth, Professor Joseph John, Data, Shailendra Verma, Sheikh Bilal, Professor Gerald Dolan, Professor Cecil Ross, Pooja Diman, and Dr. Ruby Khan.
That was a knowledgeable and an engaging discussion by our eminent panelists. Now for the next session on emerging gene therapies, I would like to invite our respected chairperson, Dr. Kanjangsha Ghosh sir, co-chair, Dr. K.K. Cole sir, or Dr. Sunita Agarwal ma'am. Thank you.
अच्छा नीचे रख दिया थैंक यू सॉरी नहीं ये क्या है हाँ वो ठीक है ठीक है ठीक है
You want us to be below or so that everybody
No, the camera is there. Camera is there. You will be visible to
Good afternoon to all the honored delegates, guests, participants, and we are now ready for a very exciting session from Dr. Savita Rangarajan. Dr. Savita is not a stranger to the hemophilia community in India. She has been not only driving many of the clinical trials across the world, including the gene therapy trials, but she is also running a very important hemophilia care center and unit at KJ Somaya Medical College and Hospital, and tremendously contributing to the understanding and care of hemophilia patient as we know. So without wasting much time, I will request Dr. Savita Rangarajan to start her deliberation on the future of gene therapy in hemophilia. Dr. Savita, please.
Thank you, Dr. Ghosh. It's a pleasure to have you as the chair. And I can see that Jerry is on Jerry is there as well, and I'm sure he will probably agree with me with a lot of these things that I'm going to talk about. I'm going to talk about the future of hemophilia gene therapies, and particularly in India as well, through my lens. Basically, it's my journey through the of gene therapies in hemophilia. So the hemophilia therapies obviously has moved a long way from the very start of successful blood transfusion to extended half-life clotting factors. And of course, I heard you deliberate about the non-factor therapies, particularly emicizumab in India. But of course, we also know that that there is a lot of problems with using factor therapies, particularly with the immunogenicity, which you all discussed in detail just now, and the treatment burden and adherence, particularly with prophylaxis and regular infusions, and also maintaining adequate factor levels. And what is adequate factor levels is also going to be a question when it comes to gene therapy. And what we believe, and what I do certainly believe, is that gene therapy has the potential to address much of these unmet needs. As we've already talked about, the barriers to current hemophilia gene therapy, hemophilia treatment is multiple intravenous infusion. And we know there's a problem with hemostatic control for inhibitor patients and the high cost of bypassing agents. And I know that if we have to do surgery with bypassing agents in inhibitor patients, it costs a significant amount to the patient and to the and to the government agencies. And I've recently done an inhibitor surgery in India, having said that, and it's probably costed the exchequer quite a bit. To help overcome these barriers, obviously we have a lot of other drugs non-factor therapies that are licensed and are going to be licensed hopefully in the near future. However, we'll wait and see. So, disruptive technologies, benefits and risks, obviously what we are very mindful of is that it has to have the potential for improvement over the current standards of therapy. Risks, most of it is not immediately obvious, but of course we do know some of them, and of course there will be a lot of unknowns. And as far as I'm concerned, the most important consideration, no harm. And we also know, I know you discussed, and especially Jerry discussed about viruses and the infected blood inquiry. Obviously, the hemophilia community is very, very wary of viruses, and particularly from miracle therapies. So, why gene therapy for hemophilia? For researchers and for industry, it's a perfect disease to study this novel biotechnology. It's a single gene defect, and it has a direct correlation with the phenotype. And also, we can measure something. There's a wide range of benefit. So even if I reach a factor 8 level or 9 level or 5 or 10, it definitely has a benefit for the patient. And I can go up to 150 or even beyond, slightly beyond, not obviously too much. And I still won't cause any harm to the patient, meaning no tight regulation is needed. And the progress, gene therapy has taken a long time to come to where it is now, but I think we are there. We are version 1, version 2, whatever version we think we are, but I'm sure there'll be much more change that is needed in order to resolve all the problems that are there with current gene therapies. And why do clinicians and patients believe it's a miracle cure? We already know that it's a high burden of current standard. There is continued risk of morbidity and mortality despite prophylaxis. And we know that the target level of factor 8 at 1% is not enough. There's variable compliance with this regimen, and most importantly, 70% of the world have no access to clotting factor therapy. And I heard about emicizumab and the cost and its unavailability in India. I have treated quite a few patients on emicizumab. I have given them a low dose. It has worked, but still that is not the way one needs to go about, what we call is, in Indian terms, jugaad. But anyway, I think gene therapy will probably be the future, but wait and see. So what are the goals, or what is the factor 8 or 9 level that I would look for as goals? With prophylaxis, we thought 1 to 3% was good enough to prevent bleeds, and that's what we did with prophylactic treatment. But what we have learned is that having a factor 8 or 9 level greater than 12% is probably better, because that is what a mild hemophilia would have, and the annual number of joint bleeds is almost insignificant if you have a factor 8 or 9 level. This was particularly with factor 8, but I'm just translating it to factor 9 as well. Greater than 12% would be good enough for patients to prevent bleeding, and they would be able to do day-to-day activity and also be part of the society doing all what they need to do normally. I mean, of course, if you have a level of 12, you certainly would need extra help when you have surgery or when you have some significant traumatic bleeds, etc. But I think from our perspective, it's obviously changed to 12% and above. However, the current gene therapies, certainly some of them, have reached normal levels. So I think we are now greedy to have normal levels with the gene therapies as well. So obviously, we are now moving goalposts with not necessarily investigational gene therapies, but of course, 3 of the gene therapies for hemophilia have been licensed. What do I mean by gene therapies? Obviously, it's a continuum, and there will be different approaches to gene therapy for hemophilia. And each of them will have different implications for efficacy, safety, and obviously success as well. What is now currently licensed is what we called in vivo gene therapy, where a new gene is transferred to the cell nucleus and it is expressed, and I will talk about that in the next few slides. What is then potential gene therapies is also gene editing and inserting a correct gene, not necessarily in the faulty gene, but it could be in another safe locus within another gene. So that too is a potential. Of course, this could be done in vivo as well. And then finally, cell therapies. And I know currently there is one trial ongoing in India with this particular approach, where autologous graft with lentiviral vectors giving the payload into the bone marrow cells. But that is something that has been done, and I've recently heard the outcome, at least in 4 patients, that was presented at the American Society of Gene and Cell Therapy, and it looks reasonably good. However, as I said, in any of these therapies, we have to look at long-term. So, AAV-mediated gene therapy, the 3 licensed ones, and most of the ongoing clinical trials are based on AAV-mediated gene therapies. So we know the factor 8 and factor 9 gene. This DNA is encapsulated in AAV, or adeno-associated vector, which is a degutted vector, which means it cannot replicate anymore. And then we infuse as an IV infusion over a couple of hours. And then this virus is then released into the cell of interest. And in our case, it's going to be the liver. However, it does go to various other body parts as well. Then the gene expresses the proteins, and it is then finally secreted into our system. So, in terms of AAV, they were discovered in 1965, and it was vectorized in 1984 for gene delivery. First in human, it was used in cystic fibrosis in 1996. But coming to factor 9 and the original gene therapy trials, I think I would like to go to 2006 and 2011. Systemic administration of recombinant AAV2 leads to a transient increase in factor 9, and that was the CHOP, the Children's Hospital in Pennsylvania trial in 2006. It was not a success, but at least we know that it did lead to an increase in factor 9. Then comes 2011, where we had a sustained expression, and I'm proud to say that I was part of this. Then, obviously, things have moved on since then. So, how do we make these vectors? Well, there are 2 ways of making AAV vectors. One, in a human cell line, which is HEK293, and an insect cell line, or SF9, baculovirus SF9 insect cell AAV production. So, the vector is assembled within the human cell with bacterial plasmids, and it is a 3 plasmid requirement, where the expression cassette of the factor, the ITR, and also of the actual vector is there, and it requires a helper plasmid. And this co-transfection of the HEK293 then produces magically the recombinant AAV, which is then harvested and purified. Similarly, the baculovirus SF9 insect cell line, you actually need only 2 baculovirus with its expression cassettes. It doesn't require the helper system in place, and it produces the reason I say this is because both the currently the factor 9 gene therapy with Unicure and the biomarin gene therapy for factor 8 is in this cell line, and it's the Pfizer one which is with this cell line. And the AAV transduction pathway, as I said, we have the AAV vector. It then binds to the cell surface receptor, which leads to internalizing of the vector by means of a clathrin-induced vesicle formation, which then forms an endosome. This endosome then changes to become a lysosome with release of its vector or the AAV, which then enters into the nucleus. Once it enters the nuclear membrane, the mechanism, how it enters, the mechanism is not fully understood. But the release of the single-stranded DNA, or if it is self-complementary DNA, they form the double-stranded DNAs, could have circular monomers, circular dimers, or circular concatamers, depending on the number of DNA molecules that there are. And it is this which is stable, not integrated, and then starts to produce mRNA, which then goes on to produce the protein. So that's in basic how the gene therapy works. So in hemophilia, 2 trials that established the gene therapy for hemophilia B was MANO in 2006, which I talked about, and of course the Nathwani trial in 2011. So, the first trial in 2006 achieved 12% of factor 9, but however, it rapidly reduced when the ALT increased. So clearly, there was some problem and they lost their factor expression. In the Nathwani 2011 publication, what was done very cleverly is that we gave steroids in these patients, and that helped keep up the level of factor 9, and it was preserved. And as I said, I'm pleased to say that having been associated with this trial has, brought me a long way in gene therapy. And then, of course, it was a landmark study. There clearly, because a longer-term follow-up was published in 2014, and factor usage was reduced to near 0 in 6 out of the 10 patients. So clearly, even though there was small amount of factor 9 being produced, it still kept the factor usage to minimum. And this was the publication again for long-term safety. So 2015, I received a call from Glenn Pierce saying, Savita, do you want to take part in a gene therapy for factor 8? And I thought, factor 8 and gene therapy? We all talked about factor 9 because it was a smaller gene, etc., and therefore the packaging in factor 9 AAV was better. Wow, factor 8 gene therapy. So I did get a call from the Biomarin team saying, we would like to come and see you. And I was at Basingstoke at that time, and Basingstoke was not known to be a very large hemophilia center, and certainly not well known in terms of clinical trials, although Basingstoke was one of the premier centers many years ago when there was a local center where hemophilia patients were treated as indoors or inpatients. So it was quite surprising that they contacted me. And at that time, I had something called the Southern Academic Coagulation Consortium, and therefore we managed to get a lot of patients to do this clinical trial, and very successfully for Biomarin. And let me take you through some of my one of my patients. If I can get this video to, sorry. if I can get this video to work. Doesn't seem to. But anyway. So we published that in 2017, and AAV5 gene therapy transfer in severe hemophilia A. And this came out with another publication in the same volume with hemophilia B, which was the Spark Pfizer phase 1 study, and it did have an editorial from Marieke Vandenberg at that time as a cure for hemophilia within reach. So highlights of the phase 1 study: the annualized bleed rate reduced significantly, and the factor VIII usage also reduced significantly. And as you can see, the factor VIII activity was also within the normal range. So the mean factor VIII activity levels was within the normal range. As I said, we became greedy after this trial. I remember those days when we actually infused the patients on a weekly basis. We were debating what is going to be the factor VIII level. At 6E13 per kilogram, the factor VIII level was within the normal range, and at 4E13, the factor VIII was at a lower end, but still hemostatic. And this was the 3-year data from the phase 1 study, where the data demonstrates durable expression of factor VIII. However, we do know that with time, the factor VIII in particular declines, expressions do decline. And this was a multi-year follow-up of of this particular gene therapy trial. As you know, the progress in hemophilia gene therapy has really been remarkable, and this is the phase 3 study which was published in 2023, both factor VIII and for factor IX. This was the Biomarin study, and this was the Unicure study that was published. And what I would like to show is the annualized bleeding rate was superior to factor VIII prophylaxis for the Biomarin study, both for year 1 and year 2. And again, participants with 0 treated bleeds was significantly higher with both year 1 and year 2 compared to baseline. So this clearly showed that gene therapy works. Gene therapy works, for a set period of time, certainly for factor VIII. And the reduction in treated bleeds maintained in year 3 as well. And again, that publication came in 2023. This is the phase 3 data. And with reduction in bleeds, the reduction in factor VIII utilization was also maintained. And as you can see, this is the factor VIII activity by chromogenic substrate. And as you can see with the weeks, there seems to be a decline in the factor VIII level, and with the mean being 16%, with a median of 9%. However, it was the reduction in ABR that satisfied the primary endpoints, which was sustained for two years. And as you know, that the Biomarin's getting its approval was related to. Sorry, this is the factor IX, but Biomarin's getting the license was related to the ABR. So as you can see from the factor IX Unicure, the ABR was reduced by 64% and demonstrated superiority to prophylaxis from the lead-in period. And factor IX replacement was also significantly reduced, 96% reduction. And the factor IX activity levels were sustained over 24 months post-treatment. And I can tell you, I had a couple of patients on this trial as well, and they have maintained 50% for more than 3 years now. So certainly has been helpful. So the adverse events of special interest, I think we all know that ALT elevation is of interest for all of us, and it occurred in almost all the all the studies. We have seen that happen. And really speaking, no other adverse event was of any major importance. Malignancies have been reported in both hemophilia A and B trials to date, and none of these, no evidence that the gene therapy has actually caused these malignancies. They were all extensively investigated for insertional mutagenesis. So, as I can say that there are AAV-based gene transfer programs in phase 3, and there have been 4 of them, all ongoing, even after licensing. That's because we are looking at long-term, problems that may be associated. And as you can see, there are currently 3 approved products, 2 for factor 9, the Pfizer one, and the Unicure one or CSL one, and the Biomarin one for factor 8. Sorry. So now I'm coming to issues with gene therapy. So I think one of the most important things that we need to think about is the immune barriers to successful AAV transduction in humans. And this is not necessarily only related to hemophilia. It probably is related to all other conditions as well, where we have in vivo gene therapy with AAV vectors. So we have pre-existing antibodies, which may prevent transduction. And once the vector goes in, there is activation of toll-like receptors and innate immunity does kick in. And then once the capsid is then externalized, then there's going to be some activation of MHC, capsid degradation and presented to the MHC, causing more issues in terms of ALT increases. There's also going to be generation of transgene-specific antibodies as well, potentially. So these, as you can see, published very recently by Nathwani, so 3 issues: pre-existing humoral immunity, induced immune response, and genomic integration, or that is another issue. So these are the 3 main issues that we see in our patients. Now, clearly we are treating only adult patients with hemophilia currently, and therefore the levels of AAV, the amount of AAV that we give, we don't see that much, although we see an increase in ALT and reduction in factor 8 or 9, we don't see any other problems associated with liver dysfunction. However, that may not be the case in other conditions, particularly as you can see in the neurological space or in Duchenne's or in other conditions where excess amount of AAV can cause problems. So potential mechanisms for transaminitis related to the AAV capsid, related to the genome or the gene of interest, related to vector contaminants. How much are you clearing? How much are you purifying when you make your vectors? And cellular stress. We don't know how many. So, for example, when we give an IV dose of AAV, we don't know how many of these AAVs go to a single cell. It could be 100, it could be 1,000. And can you imagine if a liver cell is bombarded with excess amount of AAV vector and they're trying to produce excess amount of proteins, there is going to be some cellular stress. So AAV-mediated gene therapy remains a dichotomy of progress and challenges. Well, we do know we can achieve therapeutic factor levels. We can achieve very low annualized bleed rates and can eliminate the need for exogenous clotting factor replacements. There are no safety signals to date and no inhibitors to date and no deaths. Well, what are the challenges? Is it safe for children with growing livers? Potential insertional mutagenesis. We really don't know why certain patients develop transaminitis while certain don't. Durability of factor expression is a problem, and variable expression of factor 8 or 9. Different people express different levels, and we can't actually, it is not really very dose dependent. And re-administration certainly cannot be done with AAV because we all develop antibodies to AAV. These are the challenges. And as you can see, the durability, especially with the biomarine, factor 8, is going to be an issue. And we do know, however, factor 9, this doesn't seem to be a problem to date. Way forward, do we give prophylactic corticosteroid to prevent this ALT increase? We don't know yet. Should we or should we not? Should we combine other immunosuppression? And what is the best time to start? Should we be doing liver biopsies to understand what these are, what's the problem? Because animal models don't translate to humans. That's the problem with gene therapies for hemophilia. Should we develop more potent and better vectors? And I think that's something that I'm going to be talking about, whether reduction in contaminants, ability to up-titrate or down-titrate and repeat infusions. Of course, the most important thing is the cost of gene therapy. It's clearly not. Currently, the gene therapy costs that is being priced is not going to be easily done in India. I think the best way forward in India is indigenous gene therapies. So how do we try to improve AAV-mediated gene therapy or other gene therapies for hemophilia A or B? So one of the things that has been already done is the expression cassette optimization. Whether it's self-complementary, I don't think that has really worked. The promoter design to improve, that too only to a certain extent. Codon optimization of actually the factor 8 or factor 9 gene itself. Again, that can improve the expression to a certain level. And clearly we have Padua 9, which has 6 to 8 times better activity. However, there isn't one for factor 8 as yet. The other way of getting it or getting factor 8 or 9 to be better expressed, I know that there was, Sangamo did try zinc finger nucleases where they tried to integrate the factor 9 gene into the albumins or safe harbor in albumin, because albumin is one of the most abundant proteins that is produced in our body. So if you put the factor 9 transgene into the albumin with its promoter, then you can produce a lot of factor 9. So potentially this can be done, and I think there's another company now, Regeneron, which is trying to do this with CRISPR gene editing and putting the factor 9 into the albumin locus. Obviously, we wouldn't be able to use Padua there because we don't want to have a factor 9 level of 1,000 or 2,000. So again, we all need to be aware how these things will evolve and change. Then, of course, capsid modification, whether it's natural or synthetic. And of course, lipid nanoparticles will probably make the change. And that may be the holy grail of all gene therapies in the future. Thank you. And I'm quite happy to take any questions.
Thank you. Thank you, madam. It was a wonderful lecture. You are doing a great job, and we are looking forward to it very curiously. There might be some queries, questions from the audience. As I know, it is a treatment which shall be available in future, and a treatment which was a passing reference about a decade back, and now we are talking it about frequently. Madam, may I know the population size, exactly in this hemophilia community, in that population, which will be benefited the most with this gene therapy? Are there some criterias, eligibility criterias for such patients?
So currently, the gene therapies for patients in the clinical trials, certainly, we have not had patients with active hepatitis C involved in any of the gene therapies. We have taken patients who have had treatment for hepatitis C and cleared it, but we wanted to make sure that their liver was in a good shape when we took the patients into gene therapies. We also then had to make sure that the patient didn't drink any alcohol for 1 year at least. And we also made sure that, any drugs that were taken after having had gene therapy, we wanted to make sure that that drug did not have any liver toxicity. So we were very cautious about whatever drugs that the patients did take.
Right. One more query. I think the patients who are under gene therapy, a peculiar situation they must be facing. That is the key differences between the hope and the reality. This one, because unknown risk, long-term follow-up, durability of this therapeutic effect, and the possibility of re-administering this vector. So,
yeah, I think, as I said, this is version 1, version 2. I think we will move on, and I think the field is. I've just come back from the American Society of Gene and Cell Therapy, and I was blown out of my mind with the possibilities in the near future. And I can say that probably non-AAV vectors would be the game changer, and you can probably up titrate and down titrate depending on what level you want to achieve, and all that could happen, and I'm sure that will happen. Yes. I know, we've been talking about gene therapy for hemophilia for last 20 years.
Yeah.
That being a reality, it is a reality now, and I'm sure the finer modifications will happen in time. And I think that is where science is going. Science will move on, and I'm sure this will be, and not necessarily only hemophilia, I'm talking about all conditions.
All the conditions,
and
yes.
Not necessarily only rare diseases. It will happen for diabetes, it will happen for various other conditions as well. So,
God willing, this will happen one day.
Gene and cell therapies are probably going to be the medicines of the future.
Yeah. God bless you, ma'am. God, I am Dr. Cole. I shall be in contact with you because I have many queries.
And not only that, we will be doing gene therapy trials in Mumbai, hopefully within the next 6 months. So
Thank you.
just anyone who wants to contact me can contact
Thank you,
me.
Dr. Savita. Wish you all the best.
Thank you.
Thank you, ma'am, for proving that distance doesn't matter and sharing of knowledge. For the next session, we have, I call upon the respected chairpersons, Dr. Arihan Jain, co-chair, Dr. Kundeep Mishra, and Zeba, ma'am. Thank you.
So for the next talk, I'd like to call upon Dr. S.P. Verma. Dr. S.P. Verma is the professor and the head of department of clinical hematology at KGMU Lucknow. And let us hear from him about the management of hemophilia patients who are undergoing surgical intervention.
At the outset, I would like to thank Naresh sir and the team for this opportunity. So, changing gears, I will be talking about surgical hemostasis, managing hemostasis during surgeries on hemophilia A patients, so this category of patients. So, there are some important aspects whenever you are planning surgery in hemophilia patients, and these are the three areas where you have to plan. So, pre-operative planning, peri-operative management, and post-operative consideration. So, whenever you are planning, all these 3 points should be there in mind, how you will go about this. In pre-operative planning, the first thing is reconfirmation of diagnosis. So, if the diagnosis has been confirmed from a very good center, then it is acceptable. Otherwise, you have to reconfirm the diagnosis, whether it is VWD or hemophilia A, and then history including frequency of breakthrough bleeds and use of hemostatic agents, whether it is prophylactic or on demand, what has been the previous surgical history, how the patient has responded to the prior hemostatic challenges and all. So these things are very important, and surgery should be planned early during the week and preferably in the morning, so that you have time and staff and the members to manage if there is any complication. Screening for inhibitor is very, very important. All should be screened for inhibitor. Previous history of inhibitor positivity also is very important. Maybe at the time of surgery, patients are inhibitor negative, but if they are exposed to factors, they are likely to develop, again, high titer inhibitors. History of bypassing agent use. But if you are missing on screening the inhibitors, then it can lead to catastrophic results during intra-op and post-op. So that is very, very important aspect. You have to assure that you have necessary resources available with you. So advanced coagulation testing, clotting factor concentrates in adequate amount, hematology consultation, and hemophilia treatment center support. So if you have all these things, more likely you are going to do good. Comorbidities of the patient should be considered. So they may have underlying renal dysfunction, cardiac or liver dysfunction, and they may be on some of the medications which can lead to increased bleeding risk during or intra-op and post-op. So there can be drugs which are affecting platelet function, there can be some dietary supplements and some medical conditions. So all these conditions have to be kept in mind, and you have to take a good drug history, whether the patient is on any antiplatelet or very rarely maybe on some anticoagulant or so. Along with that, you should also plan the post-discharge care and physiotherapy consideration. So how will you manage in the post-op period? So post-op care and reach to hemophilia treatment center should be available for the patients. Either there should be self-infusion facility or a center where patient can get care in the post-op period, especially once discharged. And then again the possibility of graded physiotherapy, the availability should be there, because without physiotherapy, post-op outcomes may not be that good. You should have a well-written hemostatic treatment plan. So this should be finalized hemostatic treatment plan, which should be communicated very well to the surgical team, and this should include about the diagnosis, type of surgery, inhibitor status, timing and need for lab monitoring, and plan of CFC support. Physiotherapy is a very, very important aspect. So sometimes the muscles of these patients are very weak, and even the orthopedician or the surgeon thinks that probably the surgical outcomes may not be that good. In that situation, your physiotherapy can help you and gaining the muscle strength before going for surgery, so that you can have the post-surgery outcomes that is good. So well-written treatment plan means like this type of plan should be there, which should be handed over to surgeon also, including patient name, history of inhibitor, previous history of inhibitor and all that, and then what product you are going to use during this surgery, and then well-written plan, how you are doing pre-op, then intra-op, and then post-op, days-wise factor plan should be there, so that there is no confusion at the surgical team end, and no doses are missed. And then you should also note down what monitoring you are going to do in the post-op period and how you are going to do. Peri-operative management. So peri-operative, we know we have the type of hemostatic agents for hemophilia. We just discussed so many products. Hemophilia A without high titer inhibitors, we have clotting factors, extended half-life clotting factors, and then desmopressin and imsunesimab. hemophilia A with high titer inhibitors, we have APCC, then we have recombinant factor 7 and imisusimab, and there are some adjuvant drugs which can be used along with these like antifibrinolytic agents. How do you assess the effectiveness of surgery? So hemostasis during the surgical procedure, so these are the guidelines. You have excellent response where the surgeon considers that the intra-op or post-op blood loss has been within 10% of the non-hemophiliac, like a non-hemophiliac patients. There is no need for extra doses of factors or bypassing agents, and there is no need for blood components. So that is excellent. Good is again when the bleeding is within 10 to 25% of the range without any need for extra support. Fair is when bleeding is 25 to 50% of non-hemophiliac, but there is some support, extra doses of factors are required or blood components are required. And poor is when the patient lends into hypotension, requires ICU setup in the post-op period, or if there is significant requirement of blood component or factor support intra and post-op. And these are the recommendations for peak factor level and length of post-operative replacement therapy. So for minor procedures and all, peak factor levels is maybe 50 to 80%, and for major procedure it is 80 to 100%. And then post-op peak factor activity goals are basically 30 to 80% for minor procedures, and every third day you can come down, so 60% day 1 to day 3, then 40% day 4 to day 6, and in the second week maybe 30 to 50%, and that will be adequate. So minor procedures you have to do factor supplementation for 3 days. For major procedures it can be 7 to 10 days, or sometimes can be extended to 2 weeks also, depending on the need of the patient. We have CFCs which should be readily available in the intra and post-op period, and it should be given 30 to 60 minutes prior to the surgery. So that was the question in the morning also. Post-op doses should be based on the T half of the product. So it is a standard half-life every 8 to 12 hourly. If it is extended half-life, every 24 hourly. Atypical or unexpected bleeding, if it is there intra-op or post-op, then stat factor level has to be estimated, and look for any anatomical causes which can be there. Bypassing agents, so congenital hemophilia A with inhibitors, FIBA or Novo7 can be used for surgeries. If recombinant factor 7 is being used, which is preferred, it should be used every 2 hourly. For initial 48 hours, it should be used every 2 hourly. Low titer inhibitor patients may receive higher doses of factor 8, but may develop anamnesis, and later on they can develop high titer inhibitors. So, during surgery, treating inhibitor patients, whether it is low titer with factor supplementation, can be, sometimes problematic. Antifibrinolytics, tranexamic acid is preferred. It is particularly effective in mucosal bleeding, and especially in the orthopedic surgeries and trauma surgeries, it's very, very important. It can decrease perioperative and postoperative bleeding, but we should remember that it is contraindicated along with FIBA, and there is no evidence of any increased thromboembolic events. What about the type of anesthesia during these surgeries? So choice of GA versus regional anesthesia should be individualized as per the patient and surgery, and probably as per the surgeon. WFH advises against neuroaxial anesthesia. Practices vary from center to center, but if you are going for neuroaxial anesthesia, then you must make it sure that you have raised the factor levels at least 50% and above. Post-operative considerations, so all patients who are intermittently or periodically exposed to factors, we know that they should be monitored for development of inhibitor, especially if your patient is developing unusual bleeding in post-op period, especially 5 to 7 days after surgery. There can be, again, the chances of development of new inhibitors, or maybe he was a case of inhibitor which was, has become negative pre-operatively, and now it is coming up. So there are some special situations if your patient is already getting antiplatelets or has to be, started on antiplatelet or anticoagulation. These are the guidelines. So for single agent antiplatelets, factor level should be at least 5%. For double agent antiplatelet, 15 to 30%. And if any anticoagulation you want to start in your patient, factor level should be 15 to 30%. On imisusimab, if patient is already getting imisusimab and you want to start antiplatelet or anticoagulation, the guidelines are not clear. But even if you start, you have to have a close observation. Now coming to some special situations when hemophilia A patients on imisusimab prophylaxis require surgery, and this patient is without inhibitors. So during imisusimab maintenance, we know that if you maintain a trough level of imisusimab around 50 microgram per ml, you are able to maintain factor activity around 18%, factor 8 levels of around 15 to 20%. So this may be sufficient for minor surgical procedures, but not for major surgical procedures. So all major surgical procedures should be supplemented with clotting factor concentrates. On the other side, if the patient is with inhibitors or with previous history of inhibitors, then recombinant factor 7 is the bypassing agent of choice, and you should avoid FIBA. There is concern of thromboembolic events, as we know, with FIBA, and use of recombinant factor 7 should be adjusted to clinical response. There was no guide, as such guideline what dose Novo 7 should be, or recombinant factor 7 should be used, or FIBA should be used. But this was the article which I got published in 2020, concomitant use of bypassing agent with imicizumab for people with hemophilia A and inhibitors undergoing surgery. And you can see that the dosing schedule is almost similar to like those patients who are not on imicizumab. So 90 to 120 microgram per kg bolus, then every 2 hours you have to give 90 microgram per kg for next 2 days, 48 hours, and then next 48 hours coming down every 4 hourly, and then next 48 hours coming down to every 6 hourly. So this is how you manage, patients with imicizumab who are requiring surgery with inhibitors. And definitely if in post-operative bleeds, when patient is not responsive to this recombinant factor 7, then you can use APCC also, but the single dose should not exceed 50 units per kg body weight, and the total dose per day should not exceed 100 units per kg body weight. So the monitoring of, during imicizumab treatment, so APTT is not reliable. That's why even in pre-op also, APTT should not be used as a, marker that you can go ahead with the surgery without any factor support. So don't rely on APTT. Factor VIII activity, again, one stage is SA is not the standard of care. Factor VIII activity, chromogenic method with bovine reagents is the way to go ahead. And imicizumab concentration measurement usually is not required, as we have seen, heard previously also, but in certain situation if you want to do it, then you can have the special assess for that. So at our center in KGMU, we have experience since 2017. Over the last 7 years, we have done 96 surgical procedures, 77 on hemophilia A, 9 on hemophilia B, and 10 inhibitor patients with positive inhibitor patients. This is the description of these surgeries. Most of these are orthopedic surgeries, but there are non-orthopedic surgeries also. So we had intra-op and early post-op hemostasis was good to excellent in most of the cases. So most of the hemophilia surgeries during intra-op and post-op, immediate post-op, you will not have any problems. The most of the patients bleed during the second week of when you are coming down on the factors replacement, and that is the time. And the repeated bleeding leads to sometimes infection of the a surgical site, and there are sometimes wound formation, non-healing wound also. So that is what complications which we have also encountered in our patients. This is a case, 37-year male. Recently we have operated this patient. So this is with the long-acting factor 8, which was the first case being operated on long-acting factor 8. Recently became available with us. So this was basically the left femur fracture, femur neck fracture. So again the same schedule we provided to the surgeons, and this is the pre and post of photographs of the patients. So with EHL availability, we can see that only maybe 10 to 12 doses or 15 doses are required for operating these patients. So the take-home message from my presentation is that surgery for people with hemophilia A requires additional planning and interaction with healthcare team. Adequate laboratory support for monitoring of clotting factor levels should be there. Anesthesiologists and surgeons should have experience in treating patients with bleeding disorders, or at least doing surgery of these patients. Neuraxial anesthesia requires more than 50 units per DL of factor levels. Adequate quantity of CFC should be available for surgery, and maintaining adequate coverage post-operative as well as during the rehabilitation post-operatively. Patients on newer non-factor therapies, they require special consideration, because now we are talking about non-factor therapies, so we should also know how to manage these patients when they require surgeries. And all surgical patients should be managed in consultancy with comprehensive hemophilia treatment center. There is always a role of interdepartmental interactions and discussing with your surgeons, making them comfortable, and the anesthesiologists also making them comfortable, and making them aware what factors, what type of support we have available with us, so that we can help them in any adverse situations. Thank you very much. Any questions?
Very well covered, Dr. SP, though it is a very complex, I'll say, topic, slightly different from what usually we keep on discussing. The index case you discussed was without inhibitors.
Yeah.
The same case, if it was with inhibitors, how your approach would have been different? You might have got that kind of case also.
Yeah, so if the patient is with inhibitors, so what we plan is actually nowadays what we are doing is we just mix plan. So initial 48 hours we support with Novo 7, that is recombinant factor 7, and after 48 hours we change to FIBA. So this is the problem, because we have to adjust according to the availability of the products. So managing surgery with inhibitor and with only recombinant factor 7 is very, very costly and very difficult also, because every 2 hourly, then every 4 hourly, 6 hourly dosing is difficult. So initial 48 hours, which is the critical one for achieving the hemostasis, we try to maintain it with recombinant factor 7, and then we shift on twice a daily dose of FIBA.
It was a very lucid presentation indeed. Question to you is, do we need to exercise some special precaution while trying to achieve post-operative analgesia in these cases, especially children?
Post-operative analgesia.
Yeah.
So if you are, if you are talking about neuraxial analgesia,
especially if somebody's undergone some orthopedic surgery
Yeah.
and is in great pain.
Hmm.
So NSAIDs, I don't think would be a safe alternative. So what do you go for?
so then above
Narcotics
NSAID and above, initially the paracetamol, if you are not able to manage the pain with that, then maybe a combination of tramadol and paracetamol. And if you are not able to manage with that also, then maybe COX-2 inhibitors like, celecoxib and all. And even after that, if you are not able to manage, then maybe morphine. So that is the way to go ahead, pain ladder to go ahead.
Any audience questions?
Thank you, Dr. Shailendra. It was good.
Thank you.
My question is like patients with or without inhibitors on emicizumab prophylaxis who were to be taken up for minor surgeries. So we don't need to, give any factor concentrates?
Yeah, because
Like any other common one?
yeah, minor surgeries can be done.
With and with the patients with and without inhibitors?
Yeah, for both.
One quick question. Sometimes, at least I face in the clinic, a lot of our hemophiliacs who are adults walk in with a grade 3 hemophilic arthropathy, bad destroyed knee joint, and we sometimes feel that we have the factor support which is available, and we sometimes feel that okay, why not just replace their knees? But the patients are quite apprehensive, and sometimes you also feel that, okay, if something goes wrong, and obviously the bed crunch is there, and this is a elective surgery. So how do you deal in your practice?
So see, if you see, most of the time the demand for surgery is from the patient side. So the patients are so crippled and the quality of life is so bad that they want something which is permanent, or something which is long lasting and can provide comfort to them. So most of the time it is from the patient side, but if it's not from the patient side and we consider that probably this patient is a good surgical case and should go for surgery, then definitely we have to counsel them that you will be having good outcomes, better outcomes, and you can give the previous surgical experience which you have and the examples which you have with you available. And then definitely the third thing is that you have to prepare them operatively in the form of some physiotherapy which is directed towards improving the muscle power and all, and the gait balance and all, so that the surgeon also feels that they have good outcomes. Mostly the surgeons feel that they will not have a very good outcome because the muscles are not there. How he will what he will do in the post-op period, how he is going to sustain. So all those things we have to take care.
Thank you.
Only one question.
Yeah,
sure.
So in case of minor surgery, if the patient is already on emicizumab, so do we need to increase the frequency of emicizumab, or we can continue with the same?
No. So we have to continue with the same. Like whatever protocol we are giving, whether it is 2 weekly, 4 weekly, or once a week, 1.5, 3 or 6 milligram per kg. So the same protocol has to be used. So that dose has not to be repeated. Only thing is, if they require additional support, then depending on whether inhibitor positive or negative, we have to give factor or bypassing agents.
Do we cut short the doses of the required doses of factor VIII or the bypassing agents? taken up
bypassing agent, just I mentioned that.
Patients on emicizumab to be taken up for a major surgery.
Yeah.
So how do we adjust the doses of the factor 8 or?
So is it like you are asking about inhibitor positive or negative? If inhibitor positive, I just mentioned that the data is limited. There is no clear cut guidelines what doses we should be using. But this the study which I mentioned, that is a collection of cases, case series and retrospective analysis, and they found that the same dose 90 to 120 microgram to start with Novus 7, and then you go ahead every 2 hourly, then 4 hourly and 6 hourly. So 90 to 120 microgram, because they found that one of the patients from Heaven 1 study who was inhibitor positive and had recurrent bleeds and needed surgery, there they did the thrombin generation assays and all, and they found that the 90 microgram the dose of recombinant factor 7 is producing the similar type of thrombin generation as the normal pooled plasma after spiking. So that was the basis of using this 90 to 120 microgram for surgical patients, and the most of the data is on that dose only.
So there is no advantage of the patient being on emicizumab?
As such for major surgeries? No.
As of today?
Yeah.
Just one last question. Where will you like to club phacoemulsification for cataract? In the major surgery group or the mild surgery?
This will be, I think, minor surgeries. Minor surgery.
Thank you for your patient listening. Thank you, Dr. Varma.
As we are, due to the time constraint, I want to make an announcement that we will not have a separate tea break. However, those who want to wish to have tea can proceed by 4:15, as tea will be served by that time. Up next, we have a panel discussion on the evolving trends in hemophilia treatment in India. For this session, I would like to call upon stage our esteemed panelists. Those come from diverse field. Mr. Prem Swarup Alva, Dr. Manudeep Kaushal, Dr. Varun Kaul, Dr. S.P. Verma, Dr. Joseph John, Dr. Cecil, Dr. Sheikh Ahmed Bilal, Dr. Shakila, Dr. Kanchika Ghosh, Dr. Maya Sharma and Dr. Monica Puri. The session will be moderated by Dr. Naresh Gupta, sir.
So a very good afternoon again, and I hope you are still enjoying these sessions. We have a very thank you. We have a very interesting session, and this is something we can take your opinion also. Industry, academia, administrators, patients, how do they perceive each other, and what can we do? there is always a distrust. What did President Radhakrishnan once said? He wrote a book actually, The Crisis of Faith. So let us discuss this crisis of faith. The doctors think we have been educated in great institutions. We know the best. The industry thinks they don't have the real world experience. They read textbook, but those textbooks are 2-year-old or 5-year-old. They are not actually up to date, and they are not in sync with the real world. The patient thinks, what do I do? Where do I go? I don't trust either one of them. They are all probably hand in glove. So let us take this forward, and we don't have much time because we are running little short, not so short, but little short. So I'll skip this slide. So we are talking in terms of addressing the issues of the payers, policymakers, hemophilia care providers, industry, patient and patient body. So let us start with the patient body. Prem Roop Alva. What do you think are the functions of patient body when it comes? We are talking only of hemophilia care. So what do you think are the function and role of patient body? How do you perceive it?
In context of advocacy, LB.
Yes, hemophilia care for the hemophilia fraternity.
So I think the patient body has, or rather, I want to say something slightly different. Maybe it'll answer your question. We believe that keeping the patient in the center, the forks of the wheel is the 4 components, which is the HCPs, the administrators, the industry, and the patient bodies. Okay. So when these folks come together, may it be treatment, may it be policy making or advocacy, when these folks are together in synchronization, the wheel is moving forward. Right? So it is a very much a part of which is very much connected. Anything which is not in sync, whether it's the medical or the administrator or the patient, then it goes off. So I've noticed that in various states it is, and states which are doing very well is when everything is in synchronization. What I think the patient body's role is to ensure that it is as much as possible in sync. Okay, and try and advocate with, because many times I see there is a gap, it's improving over the years, there's a gap between what the administrator is thinking and the doctor is trying to convey. Okay, there is a gap, and I think that's where the patient body comes in, trying to say that, look, this is what we need, okay, this is what actually the doctor is trying to convey. No? So, and try and bring it. And then yes, the industry support is always needed, so I completely believe that these are the different very vital folks to develop hemophilia care in the state or the country.
So that's the opinion from the Haemophilia Federation of India Chief President Prem Roop Alva. We also have Professor Manudeep Kaushal, who being a patient has learnt a lot, has risen to become the Vice Chancellor, and he is also taking good care that the whole fraternity is benefited. Professor Kaushal, who do you think the patient trusts or distrusts more, the care provider or the industry?
Neither.
Neither.
The patient has to trust himself. I have a hemophilia A. My factor levels are less than 1%. I meet patients regularly, sir, whenever you invite me. I see some of them very successful, doing very well, and some of them who are not. I have to have a zeal within me. I have to have a sense of dignity of labor, a zest to learn, to skill myself, to make myself more appropriate for the industry. Academia gives me a lot of opportunity. We have a Skill India campaign run by the Government of India. We have new education policy being adopted by the universities, which provide a lot of flexibility, can be leveraged by persons with hemophilia. State private universities are now running number of professional programs which give us an opportunity to start small enterprises which complement our health status at micro, small or medium level. Industry under CSR is skilling us, helping us employing, and whenever we get in touch with the HRs, they never discriminate, especially in the area of human resource, finance, information technology. They welcome persons with disability provided the skill is there, the josh is there, and they're ready to give the output. So rather than blaming or any distrust, trust myself. The parents play a very important role. If I do my homework very well, I think things become easier, sir. Thank you very much, sir.
Very well said. Doctors don't learn one thing, and that is diplomacy. The job of diplomacy is to bring everybody together and reconcile. That's very well said. Dr. Varun, do you find stuck between the two?
No. I mean, the sole purpose of hemophilia treatment is PWH. So industry also wants to help PWH, and we as doctors also want to help PWH. And if both of us, along with the administration, synergize in our efforts in giving the best possible treatment in the lowest possible resources, which we almost assume. But I believe I just happened to see maybe few months back a news that we are the 5th largest economy in the world. And still, when we had a chance to meet some of the lesser privileged countries and saw their, achievements in terms of what they are giving for the hemophilia fraternity. So I think we are still, in the process to imbibe and learn from them how they could do it. But ultimately, when all of us synergize together, I mean, we can give them the best of the treatment in the least possible resources. And Joseph sir here, he is the best possible example because he is the expert at HEOR. So we want that HEOR should be a part of each and every protocol-based decision making, wherein even Dr. Jerry was talking about registry. So when we have a registry which documents everything, and the government gets feedback of what they are going to get saved. Kerala registry was the best example. Dr. Arun was saying. So 17 crores saved in a year. It's phenomenal.
Joseph John sir, hemophilia is an orphan disease. It's an orphan disease because कोई माई बाप नहीं है. Who is the माई बाप? Sorry, I'm using your language. Let me take it further. No, because Dr. Kaul said we have a, we go towards patient's benefit. Now the point I'm raising is this disease has existed for, we know it, more than 500 years. It existed until somebody took up the cause. It was never a doctor. It was the industry. So who do you think, they take up the cause, they come with the medicine, only then everybody says, okay, we'll diagnose hemophilia because we can treat it. Otherwise we tell them like 6,000 genetic diseases, we can't do anything, we go and take some support from somewhere else.
Yeah, so understanding that question, so the question is now whether it should be a top-down approach to a disease to be addressed or a problem to be addressed, or it should be a bottom-up approach or a lateral approach. Ideally, it should be a top-down approach. The administration, the policymakers sit down together and say, this is the larger picture, this is the funds we have, how do we use it optimally, apportion it based upon the requirement or the need at the ground level. Unfortunately, that has not happened in the past. And therefore, there was a bottom-up approach to start with. If Ashok Verma started HFI, that was the initiation of that process. Along with that came the lateral approach, that is the doctors who were treating these patients and the industry who had something to gain out of this. Everybody is in it for something or the other. Doctors maybe for the satisfaction of it, the joy of it, the gratitude of it, the Maslow's hierarchy of needs we need to meet up. Therefore, we are in this profession. patients are the beneficiaries here, and rightfully Prem Group said, we need to keep the patient at the center, and then only the objectives will be very clear. If you keep industry in the center, only profit will be the motive. Doctors, it will be appreciation or the fame may be the incentive there to drive. So therefore, it is sad that industry had to drive to some extent, but I think in many states, if you look at the examples, it was the patient-driven approach. It was a bottom-up approach. Now we are merging both together and bringing the advocacy part to get the top-down as well. And this convergence, I think, is a prime example, is hemophilia. No other disease has this kind of a multidisciplinary across the specialty integration which is required, and the patients coming together and the caregivers coming together. So I think it's an opportunity which we need to harness, and we are converging there from all sides.
Holistic view. Dr. Shakila, you have been at the helm of the affairs for hemophilia care in your area. How do you perceive patients on one side demanding for more, and industry asking for the highest cost of money that you can ask for, and you have to weigh the balance?
Yeah. As we know, this is a low burden, high impact disease. So this low burden makes it very important for the patient groups to join hands with us in creating a whole ecosystem of treatment for the patient. Otherwise, if you look at diabetes or something, we don't have many patient groups who come and tell us, I want this medicine, right? And in this whole ecosystem, the patient group and the treating doctors are very, very important. As Dr. Joseph was telling, this bottom-up approach is very important, because if we have to convince our policy makers, it has to be a bottom approach. We have to tell them about the whole burden of the disease, the treatment aspects, everything has to be put out in black and white so that they are convinced and they come out with a policy. And the patients, of course, they have their own battles, and we as administrators, we have our own battles. Forget getting the budget. Even to be included in the budget or in the PIP, we really have to, go through a lot of convincing to the administrators. And once even it is convinced and it comes through in the budget, getting the tenders cleared is another thing. So we are all the time apprehensive whether the tender will come through, the required factors will come or not. Even just last tender, I heard that there were no bidders for recombinant factor 8 because of some raw material issues. So these are the battles we have as administrators. And the whole administrators, patient and the industry have to really work in symbiosis for this whole treatment. And as Prem said, patient is the focal point of the whole system.
Dr. Kanjaksha, I want to take a specific viewpoint of yours. Shakila raised the issue of tender. Is this a good practice to have? Of course, right now we don't get so many bids. But when we do get, or when we were getting bids, is it a good idea to have only one bid qualified and leave the rest out for an uninterrupted care of hemophilia care?
No, definitely one bid should not be the right way to do that. But let me tell generally, whatever has been discussed about academia, administrator, treater, patient, obviously for everything, patient should be the center of everybody's universe. There is no doubt of it. Whatever till now has been discussed, everything should be goody-goody with everybody. This is an ideal world situation. That industry is thinking, I am not making too much profit, and I am telling truly what is happening. I am not telling that this factor has some problem, it will cause inhibitor, or this factor will have that. Another industry is telling that, look, my factor is very cheap and it is as good, but means when industries are competing with each other, doctor is telling I need the higher bid of factor, then the administrator has the problem that this fellow is telling I am 2 rupees per unit and this fellow is telling I am 10 rupees per unit, both are telling I am factor 8, so what is the problem? And now doctor is actually supporting the industry, so is he taking something underneath?
No, let me intervene.
Because I am telling, because I am on both sides. I have been the president of Haemophilia Federation of India, and I have been the doctor. It is not true that the only industry does the thing. Most of the product which industry is making has been done by doctors or institutions and then gone to the industry. Industry has made that. So, and CSR is a very important kind of thing. And I agree that one product, we should not rely on only one product. That is true. We should have a portfolio of products, because obviously what has been discussed in these 2 days, and we know that one thing does not fit everybody, and hemophilia is not a simple kind of disease. Now you see, for diabetes you are now having how many medicines? At least there are 40 different medicines for diabetes. Insulin itself there are 30-40 types. Somebody is telling I need low blood sugar at 20 minutes after food. Somebody is telling it should come after 1 hour after food. Then another industry is telling it causes bladder cancer. Another fellow is telling this recombinant insulin causes this. So problem is the mistrust is created when you have introduced a mistrust between when your own rival companies or rival fellows are introducing things. And administrator has a problem, because administrator has a fixed kitty and he has to distribute it. And if you then say, look, I need the highest one. So what has been repeatedly said, that administrator has to be proved, means we have to go with data to prove that we need a mixture of material for the ideal treatment.
Okay. Dr. Sheikh Bilal, Dr. Ghosh raised a point that the administrator is stuck. There is a bid for 2 rupees, there is a bid for 10 rupees. And the question was whether one bid is sufficient. Is it not possible that we have all of them put together? We say so and so is giving for 2. Are you going to match it? Then we'll include you also as a second. And then the third. Is that a good idea or it cannot be done?
I think
it cannot be done because it does not exist in our CVC rules.
Actually, it depends upon the the specifications of the particular drug. So, and the experience you are using the drug and the clinical response the drug gives. So on that basis, technocrat can I mean, I have done at my level, I have gone for to L2, L3 also, but as per the technical expert. So if it gives a good result, if I mean your product is that it has a good impact, I have a good clinical response. So the specifications you go for the tendering matter a lot. So you have a good specifications. I mean all standard in which meet all the criteria of international standard. So even if then to my this thing, we go for the tender, because there is a rule in GFR. You have to tender it if even nobody comes once, twice, thrice. At third time, you can go for the read contract. There is no issue.
Okay, so that is how it exists in India, but it does not exist the same in the world. So you can change it. It's not that it is God sent. I would like to come to Dr. Monica Puri. We were saying, the patient, poor patient, orphan patient, does not get taken care of unless he gets a godmother. You think there is substance in it? Our doctors are not willing to support it very highly.
I don't know what we mean by a godmother, but I'll tell you I'll tell you what I see as a challenge to your specific question. Where does the world, all the ends of the world meet? Industry, academia, and patients. I am a doctor myself, practiced for 13 years. I've been part of policy through WHO, and now I'm in the industry for 7 years. What is industry, to your point? Industry actually means hard work. We say you are very industrious, you are very hardworking. That is what industry is. What is industry? You dream for, you wish for, and we fulfill. There was a time, 20 years ago, breast cancer was a death sentence for women in India. I'm talking about India, not worldwide. Today, from chemotherapy to monoclonal antibodies to targeted immunotherapies. 95% survival rate. It's not a death sentence. Why? Because doctors, the scientists, the academicians were thinking, is there a better treatment than chemotherapy? Then they thought, is there a better treatment than monoclonal antibodies? Then they thought, is there a better treatment than precision medicine? And that is what doctors wanted, patients wanted, scientists wanted, and industry delivered. And what is industry? It is the melting pot of doctors only. I am a doctor. Scientists, we have scientists. Sir said, Hopkins, Bloomberg, BARDA, talk about any international public health agency, they are part of industry. And why? Because someone has to invest. If government can invest, why not? Because government cannot put its entire money into just health. They need partners. And no government in the world, including Indian government, says we don't want industry. All they say is, we want you to come, have seat on the table, and let's have a trust. What does WHO said 2 years ago in the UN General Assembly? Let's move from a position of, risk averse to risk manage. And that is what they said about public-private partnership. So godmother is all of us. It's only us. We do not want to believe that we have a contribution because we can say, oh, this person has not done. Government is not giving fund. Doctor does not want to believe in the drug. Industry does not want to bring down the prices. Let's just come down, sit and have a discussion. If it is about volume, let's talk about it. If it is about innovative therapy, let's talk about it. Even crocin can take care of headache. Why do you need naproxen? Similarly, if blood factors can only take care of hemophilia, why would you want innovative therapy? Because why do we want to live in an archaic world? If I have a hemophilic in my family as a doctor, will I still want to give a treatment which was 50 years ago? I would want the best. You would want the best. Every one of us would want the best. Then why should not for that patient who's coming to my OPD, I should not give the best? Because my government will not give the money. I should be the one telling the government, please give the money. There is no cost that you can attach to someone's life. Because for that family, for that doctor, that patient is priceless. So I am the godmother, you are the godmother, all of us are the godmother. Thank you.
So, see, you are getting so much of claps. They have got a faith in industry. But tell me, they have a faith in industry, but sometimes the doctors tend to doubt the faith. You took the example of breast cancer. There was a medicine for breast cancer which was approved, FDA, 2008 I think. Then it was withdrawn a couple of years later. And these kind of things are happening probably a little more now. So is there a reason why we are losing faith?
See, faith is a two-way street. I trust you, you trust me. Faith can never be a one-way street. If I am willing to come and say, I can look at a price, I am willing to believe that I need to do my clinical trial in the most precise manner, in the actual protocol, then I'm not cutting corners. And you as a regulator, you as an industry, or you as a government is making sure all those steps are being followed. I mean, one black sheep should not bring down the faith for everyone. As doctors also, we have seen in our own medical practice, not all doctors are following the same faith. Although we all are bounded by the Hippocrates oath, don't do any harm if you can't do any good. But we have black sheep. We have black sheep, right?
Yes.
So that is what I'm saying. It's not about the tag, whether you're industry, whether you're government. It is about, it's a two-way street. You bring in what you want to deliver. I bring in what regulations I want. So let's just come and have that discussion.
Very good, very well said. Dr. Maya, there is a issue that comes sometimes to our mind. You know, if you look at the technological industry, they would send their interns and students to the industry. Because technology transfer is what makes all the difference. In health industry, it does not exist. In fact, nobody thinks of sending undergraduates or even postgraduates to industry, go and exchange, go and learn from there. You think there is a reason for it? Or it just happens that nobody is doing it?
Well,
Or will it benefit?
I would say, sir, there is a recent updates. Now for especially the MD Pharma students, they have to do summer internship within industry. And I think it's a welcome step, because when we talk about research, there is, such higher echelons of research which is initiated by the industry. And I completely also echo what Dr. Monica said, that again, I am a medical doctor. I also practiced medicine before I moved to the industry, which for me, for the first time, appeared like a paradigm
And
shift.
you are happier?
Much happier.
Making more money?
No, it's not about money again. Let me tell you, it's not about money again. Because as a physician, as a clinician, when I could treat, say, 30, 40, 50 patients in a day, as a doctor, as a pharmaceutical physician, I can take care of millions of patients who would benefit from the medicines which come out of the extensive research. And again, it's very heartening that, some years ago, when I entered the industry and I entered into actually the cardiology sphere, and I could see the cardiologist in all the major conferences used to quote data from either WHO or American data or European data, because that's where the research was happening. Today, whether it is cardiology or oncology or hemophilia for that matter, we are doing the research in India. Our doctors, all the prominent doctors in their respective fields, are talking about their own work. So I would say the world is a much better place because we are co-creating that world together. It's our doctors which are doing the research. So, those who are working with us would claim for us that, the kind of, I would say, ethical research that we underdo, the kind of training which happens, the kind of audit and inspections which happen to make sure that, things are on the right track, that, we are partnering only for the good things, ultimately because it is the patient which has to win. Nothing else, not for profiteering. That may be a byproduct. We say even for doctors, right, who are practicing, that making money is a byproduct because that is what we do. But that is not the goal. The goal is the patient's benefit, and we are achieving that ultimately together. And again saying that now internship is a part, and the young MD students are learning that in the industry, that what is research, what is medical affair, how regulatory function works. So all of that nuances, all the tricks, and I would say all the good work they're learning early now.
You have a reason for it. You want the pharma fellows to join the industry. You don't take clinicians, all these clinicians sitting here.
As I said, I
anyway, that was in a lighter vein.
Welcome.
No, I was saying in a, Dr. Ghosh, conjunction. I have a question for you. We were talking about these exchange programs, the clinicians included should have an exchange to find out what is happening in the industry, because what is happening in the industry today, you heard from Savita, for example, is something that will come into the textbooks much later. But I'm coming to another point, and that is what we call the consultancy. Now, consultancy is common in IITs, even in CSIR, Dr. Mashilkar got it done. In medical science, even AIMS New Delhi does not have it. Is that right, Dr. Tulika? I've been talking about it. The IIMs have consultancy. The only health-related institution that I am aware of is one NIPER. That has a reason, like Dr. Maya said, pharma guys come. So they have a consultancy. Now the reason why I am raising this consultancy, the best of the places that I have seen where they have won real high awards, close to Nobel laureate research, their labs are funded based on that consultancy. It is expensive in hemophilia, in hemostasis and treatment. Plus, it can also address questions which might be peculiar to your own environment. So, what do you think of this consultancy? Is there a fear or a apprehension?
No. There is, traditionally, the doctors have been told that you are supposed to be in the hospital and do this job. You don't have to go anywhere else. Do practice, earn money. Now question is, the whole system is slightly different, because the one gene therapy, what you were telling, many of these actually has arose in a small laboratory in the places, then the industry has come. I do not know whether industry people will agree or not. Indian industry, the pharmaceutical industry, Indian pharmaceutical industry has been largely a risk aversion industry. What they have tried to do, they have tried to copy what the other industries have done. This we have done very well. We have done so well that when HIV was wreaking havoc and many the multinational industries were also wreaking mullahs because Indian drugs will not go outside. Bill Clinton understood that there is a problem. People in Africa and other places are not getting medicine because the companies which are making medicine elsewhere in the Western world, their medicines are so costly. So he has to make a special waiver that Cipla can send.
Yeah,
and then what has happened? Then the treatment has gone. So what you are telling about why we are not trusting.
I'm raising a query.
No, one of the thing is, things are very simple. Novo 7 is an extremely good drug. It was discovered in 1988. 12 years it sat on the shelf because it was an orphan drug. It was in search of an indication.
I like that.
So what was happening? The question is you can reasonably ask.
No, it came for many.
If a recombinant protein you are getting at 14 rupees per unit, why Novo 7 should cost 70,000 rupees?
Yeah, that's right.
It could be a rational question.
I think
the industry will answer because in 1988 I spent 1 billion rupees to decide that and it sat on the desk for 14 years. So I have to get back some 20 billion rupees over the time.
Okay.
And there is no other competitor. So I will have 70,000 rupees for 2 milligram or 3 milligram of Novo 7. So here is the problem with the administration.
okay. So now let me quickly take, because we are running out of time. Dr. Meera, I can see that you want to ask a question. Dr. Monica, the question being made out is industry does not spend enough money on R&D. Is that a right perception?
I can only talk on behalf of my organization because we are multinational. If you would look at our revenue, and it is all in public domain, we are the first and the largest company in the world which is spending $12 billion only in R&D when our total revenue is around 60 billion. So you could imagine that more than 1/3 of, or almost 1/3 is going into research. And this is that research we are not even sure. For one molecule that we bring in, there are more than 50,000 clinical trials that go wrong. And one molecule that comes after a research of 10 to 12 years and actually available in the market of 20 years, look at the long-term investment. So just saying that industry is not spending enough, it will also be good to know what is the benchmark that we are talking about. If we look at our own research, I'll just say about India. If you look at our health budget in India, staggering same 1.9% of GDP on health. And if you break it down, actually the budget spent on research is less than 1% of that total budget. So before we call out industry, we also need to see what we as government are spending on research, and someone who's spending to look at what is the benchmark we want to spend. So I think there's already a commitment to SDGs that every industry wants to be sustainable, look at long-term goal, and only when the nations will prosper, the industry will also prosper. So that's the long-term investment.
Dr. Maya, do you agree with that? Because there is an impression that if you look at the developed world, there the research of the industry comes from the academicians. And they are the ones who give their patents and drugs get developed. Have you had any situations where the academia in India contributed to any of your molecules?
I would say in India, yes, it is difficult for an academic institutions to see here that, academic institutions are partnering. But I would say that it still doesn't stop us from reaching out to the academic institutions. So we are the ones, who are initiating that process, and we are reaching out to them for research. And again, to give you an idea, when I talk about the sales of my organization, Novo Nordisk, it is just, contribution is just 1% to global sales. But when I talk about what we are investing in research, it is 1.4 billion that Novo Nordisk has invested in India only in clinical trials. And because of that, what we are contributing, in terms of, I would say, clinical operations from India team, because that is what I represent, we contribute 10%, in rare disease we contribute 15%, and in some of the further rare research we have contributed up till 45% of global patient pool. So what I'm talking about it is, again, that, if others are not reaching out, should not stop us from, extending a hand to them and making sure that we pull each other up further, again, for the patients.
Thank you. That completes the whole circle. We started with orphan disease. Until America came up with Orphan Disease Act, I think somewhere 1984 or 1980s, industry was not taking it for the first 500 years because they have to spend a lot of money and get small number of patients to be treated with that expensive input of money, the R&D that is spent. But the incentive given was the industry will be given an incentive if they look after these drugs. So it's not the industry that was the godmother, it also was the government policy that was the godfather. So with that incentive, many things have come and collaborative efforts have taken it further. Dr. Meera, please give your comment. I have already overshot time by many minutes.
I just have one comment.
Yeah, please. I have overshot.
We have been having so much elaborate deliberations and discussions, but somewhere it looks like we are going back to ground zero because as Dr. Shakil also mentioned, and also in UP, there have been no bidders for recombinant factor VIII. And you're talking about matched L1. Most of the states don't have, but I'm aware that some states like Tamil Nadu have in their procurement policy the provision for matched L1. With all this in mind, and now since we're at the verge of having no factor VIII all over the country in the coming few months, what is the take? Because you're now the movers and shakers from the patient groups. What are your plans and what are you thinking of for the way ahead? Because the situation is not good. We are going back to empty coffers. You're talking so much, but there is nothing back home.
Very true, ma'am. See, that's a big concern. We can move it. We can move the tenders. We can create the budgets. We can do it. It's very important. Like earlier in the morning when I was saying, every Congress I have gone, internationally inviting pharmaceutical companies and industries to come to India. There was only one. Today we have 4. Factor VIII recombinant we have 3. But they don't have the medicines. They're not able to give it. So even this Congress, even in Paris, I was speaking to Bayer, for example. Bayer is another entrant who is there in the market. Let them come in. But this is a dangerous trend that people are, there's a tender clause that if you apply and you win the L1 or L2, L3, we are willing to give. The state is willing to give L2, L3. But the industry should have the product to give it. So they assure, when we as a patient organization, if I'm speaking to Novo Nordisk or Takeda or Pfizer or anything, Pfizer has been very clear. They said, sir, we are not going to participate in any more tenders in India. Because what we have committed, we are going to give. So that's the problem. Because if they don't participate, we need, in some states like West Bengal, we need 3 industry partners to compete. So we have to go back and tell them participate. So that's a very valid question, ma'am. That's something which we continuously put pressure on the industry, saying, do you have stock? Right now also I was asking somebody.
Many times the industry is saying, we have to import much before we win. And only if there's a possibility of being matched L1, they are bold enough.
All states, all states will give L1.
I think we are going in, that is why we said L1 should be done away with. It is coming in our way. 2008 was the first World Congress I went to, and one of the reasons was because there was only one provider in India of a plasma derived factor. And I went there and I told them, please bid for our tenders. They would not, because they thought this man, I don't know where he has come from and is asking for bidding, and they did not for many years. They did not. Then they started appointing agent. My representative is there, and I can see some of them even today. That was a good way out. And then they started having their own offices. Let me tell you, we should not be so critical. From 2007-8 and today, the situation is much better. But now we are facing our own administrative problem. We have a scenario where one state government says if there is only single bidder, whether it is your product, 7, whether it is your product, if there is a single bidder, will not buy it. Now that is a very wrong notion because the CVC guidelines permit it. So the problems are not everywhere. And I think if you put them on the table, bring many bidders, you get a competitive price. Not only competitive, I said we'll get competitive and we'll get uninterrupted supply. You can keep doing it. Plus, you can bargain on the rates. They would be happy to match as much as possible. This situation, all said and done today, is much better than what it was a couple of decades back. You have to agree with that.
Agree. And we have products. Right now, like ma'am, another thing is, if the recombinant has a shortage, if you're talking about EHL, the company says we don't have a shortage of EHL. Okay, so they say that recombinant is shortage, plasma derived there is a shortage presently. And they are assuring us as the patient organization that this shortage is very temporary. Let's see.
Okay.
Let's wait. And
Dr. Shakila, last comment, unless somebody else comes after you. We have to close it. You want to make a point?
This is a really serious question. Like EHL factor 8 is there, but when we have called a tender for recombinant, what do we do? Like,
I'll tell you my perception. You see, one of the reasons why we have these meetings is when it comes to factor 9, let's say, where you want to do it. You have a standard half-life, you have a EHL. The administrator doesn't know what these are. He says this is all factor 9. Per unit cost you count. If it is 20 times, I'm not going to buy it. 1.01 times I can consider. Now this is where we have been talking about, you should not do the tendering based on per unit cost. You need not even include the indirect cost which should be done under this, but under specifications you can include it in an indirect way. Let us see the cost of treatment of a given weight patient, given condition scenario, as to this product for 1 month cost, how much will it cost? You calculate on a daily basis. Now there is a deficiency at our level also. In fact, there was a deficiency at our level when we were trying to move from plasma derived to recombinant. They said, sir, how do you get this? We can't get it because you write only factor 8, I want to procure, factor 9 I want to procure. So please make sure that your specifications are foolproof. They are not looking as if they are targeting only one particular company. Make it open, but do include, if you want to include EHL in a different way, and you will always succeed. Sir, thank you so much.
I will just say one last statement that, at times the industry is kind of put it against each other. They're pitted against each other as if we are competing. I would say when you are running alone and if you win, what's the fun in that? The significance is when there are others around and let the patient win.
Oh, wow. I don't know, this happens amongst doctors also, the hemophilia providers, doctors and the hospitals also. The patient always loses there. Thank you so much for bearing with us, and it was really nice. I thank all the panelists for this session. Back to the organizers.
That was an extensive and elaborate discussion by our beloved panelists. Now for the next session, I would like to call upon the respected chairpersons, Dr. Arihan Jain sir, co-chair Dr. Anupam Datta sir, Dr. Pradeep Kumar sir.
You all. Okay, so thank you very much. We now move from all of these very interesting administrative and other day-to-day kind of problems to a slightly different problem. Now, you may be wondering why we're talking about factor 10 deficiency, but about 12 years ago in 2012, we reviewed all the rare bleeding disorders that we were seeing at AIMS. And one of the triggers for doing that was because I had a young man with me who had factor 10 deficiency with pseudotumor, and he was in a really bad state. And I was just wondering how rare or how common was this bleeding disorder. And in that 2012 article, which my resident went through all of our files and we published, we found that factor 10 deficiency was the commonest rare bleeding disorder at our center. And at the moment, we have 35 patients with factor 10 deficiency. And there are many other centers in the country where we also have this. This is a condition which has been reported in the West, but since we don't have population-based registries, we don't really know the real numbers. So I would invite any others who have factor 10 deficiency patients to also connect with me, and we can maybe review the data and maybe publish some papers on this. So it is an important bleeding disorder. Clotting factor 10, or the Stewart-Prower factor, is also a vitamin K dependent factor. It is one of the primary enzymes in the common pathway of thrombosis, of thrombus formation. And factor 10 deficiency is interesting because it can be both inherited or acquired, just like some of the other factor deficiencies that we see. And the congenital factor 10 deficiency is a rare bleeding disorder. It's in that group. So the coagulation cascade everyone's very familiar with, and factor 10 is activated to factor 10A, and it has a very important role in combining both the intrinsic and extrinsic pathways to lead to the final common pathway. So how do factor 10 deficiency patients present? Often it may be underdiagnosed. They may present with just bleeding or hematomas, even epistaxis, which is something that we commonly think of as a mucosal bleeding. But 33% of them can present with heme arthrosis, and they may be actually confused with hemophilia patients. So they have some, just like VWD patients can have some mucosal bleeding like gum bleeding and hematuria and epistaxis, these patients can and also have muscle bleeding. Similarly, factor 10 bleeding patients can also have a combination of symptoms, and females who have factor 10 deficiency present very commonly with menorrhagia. There is a good correlation with the factor 10 levels and the severity of bleeding. So the lower the factor 10 level, the more severe and even spontaneous bleeds are seen. So if you have less than factor 10, if you have factor 10 levels less than 10 IU, then you can have spontaneous bleeding. So this is an important factor, and even having 10% factor can put you at risk for spontaneous bleeding, and even patients with 25 to 10 IU per deciliter can have spontaneous bleeding. Just wanted to mention acquired factor 10 deficiency because this is something that is sometimes seen after infections and certain drugs like sodium valproate, and even after burns and topical thrombin administration. And usually it is a deficiency, and it's very, very rare to be due to neutralizing antibodies. And if it's due to a deficiency, then in that case also you may treat these patients with factor 10 concentrate. So factor 10 deficiency can also occur in amyloidosis in other patients, and again these are patients where obviously you would treat the cause, but you could also use factor 10 concentrate. Now, the inherited factor 10 deficiency is what we're more interested in. It's an autosomal recessive disorder. In the heterozygote state, it's usually asymptomatic but may have mild bleeding tendency. The homozygous, which is the severe form, is quite rare in individuals worldwide, mostly seen in consanguineous marriages. But as I said, in India, we don't know exactly the incidence. There's going to be a certain bias to the larger centers where all of these patients will get referred to, because that is where the diagnosis can be made and that is where they're going to be treated. And so I think it's important for us to collaborate to get more idea about this. But we have seen that there are patients in many, many states, and since we've had the product available. Now, these patients usually start off with bleeding, which may even start in the neonatal period, and the treatment which is most efficacious is to give infusions of products that contain factor 10, which could be FFP or concentrates. Now, since this is a lifelong bleeding disorder, many of these patients may actually die in the perinatal period of intracranial hemorrhages. So the true incidence we may not know because we may have lost many patients. Also, there can be massive hemorrhage even from minor trauma. And after surgery also, there can be severe bleeding. And these patients often present with disabling hemarthrosis and even pseudotumors. Since it's a rare disorder, we don't know too much about the racial or ethnic predilections. Males and females are equally affected, and patients can present at any age depending on the severity. So usually the more severe patients will present at an earlier age, and other patients may present later on. So we already went over this, but this can even present as severe umbilical cord stump bleeding, or bleeding post circumcision, as well as intracranial and hemarthrosis. So these are the rather alarming and more dramatic presentations. But patients can present with just epistaxis, easy bruising, menorrhagia, and in women they can have spontaneous abortion in the first trimester, postpartum bleeding, and excessive bleeding post any surgery or trauma, which can happen to anyone. And the pseudotumors that I have seen in patients of factor 10 deficiency, it's very hard to differentiate them from the pseudotumors that we see in poorly managed hemophilia A or B patients. So on examination, you obviously will look for signs of bleeding, and many of these patients, interestingly, often have petechiae and ecchymosis, and most of the patients that we've seen at AIIMS will have both of these. And additionally, when you do blood sampling, they may be oozing from the venipuncture sites, and many of these patients are seen in emergency rooms, and as I said, they can even have CNS bleeds, so infants can present with them, and not only can they have intracranial bleeds, but they can even present with chronic subdural hematomas. In women in particular, it is very worrisome because they have a lot of menstrual bleeding, and that can lead to anemias. They can have hemoperitoneum after ovulation bleeding. Many of these women find it difficult to get pregnant, and if they do get pregnant, then there's a high rate of spontaneous abortion and preterm labor, and many complications during the pregnancy. And we actually have a young woman with factor 10 deficiency at the moment who's interested in pregnancy, and so this was again very important to evaluate. So there are a lot of case reports where they've described that the bleeding phenotype does not always correlate with the levels, though many times they do. But again, I think this may be an area where we need to collect more data so that we can be absolutely sure. Especially during the pregnancy, it may even be important to put these patients on prophylaxis, though most of the treatment that is given is on demand. Women who are planning pregnancy need a multi-specialty team to look after them in order to successfully get through the delivery for their own health as well as for the baby. So how do we diagnose these patients? They will have the basic tests are PT, APTT, And you can see that the PT and the APTT are prolonged, and the specific test is to do a factor 10 assay, but earlier other tests would be done. The factor 10 assay can give you two different types of deficiency. It can be a type 1 or a type 2 deficiency. Type 1, it is only quantitative, while in type 2 you may have dysfunctional or qualitative types of deficiency as well. It's important to check that there's no liver dysfunction, because this may be seen in patients who have other clotting factor deficiencies of the vitamin K group. So it's important to test that. Always, we don't have students here, but it's always important to make sure you collect the sample of the for the coagulation tests. Don't squeeze the tube. Make sure you shake it very gently, and all the tests have to be done appropriately within a very short time. Otherwise, you'll get fallacious tests. So either of the type 1 or type 2 deficiency can be there, but the treatment wise it is similar. And the factor 10 levels may correlate with the bleeding phenotype in some cases, and usually patients who have more than 40 IU per deciliter are largely asymptomatic, and the patients with lower levels tend to bleed more and may even have spontaneous bleeding. So how do we treat this? Well, earlier when we didn't have factor 10 concentrate, mostly we would treat these patients with FFP. You cannot use cryoprecipitate, because just like in hemophilia B, there's no factor 9 in cryoprecipitate, and there's no factor 10 in cryoprecipitate. So it's important to remember you can treat with FFP. The other option that we had was APCC or FEBR, which also contains some factor 10. But the main issue would be if patients had pseudotumors or required surgery, then we were often at a difficult situation, because to give enough factor 10 for surgery was impossible with the FFP and the FEBR that we had available, because with APCC you are giving a lot of other clotting factors, and if you want to give a large amount of the factor 10, you would risk thrombosis. So having a factor 10 concentrate, particularly for these patients who need surgery, is actually quite useful. So if you have an acquired factor 10 deficiency, it can be of two types, either due to deficiency or immunological causes. If it is due to deficiency, again, the treatment is exactly the same as for the congenital factor 10 deficiency. If it is due to immunological causes, then you need to do immunosuppression and treat the underlying cause. So how do we use this factor 10 concentrate? This is a relatively new factor for most of us. It is a plasma-derived human blood coagulation factor. It comes to us as a lyophilized powder, and it can be reconstituted when we need it, and it can be stored at 2 to 30 degrees. It's indicated in all ages for patients who have factor 10 deficiency. And usually it's given on demand at a dose of about 25 IU per kg IV, and it comes in different vial strengths, and you can calculate the factor level that you require for surgery. And in patients who are having a lot of bleeding, you can even give it as a routine prophylaxis. And definitely around surgical procedures, even for milder patients, it can be used to prevent bleeding during surgery. And it may be used even in the acquired deficiency if there are no neutralizing antibodies. So this is the product that we have available. And as I said, there are other ways you could treat with FFP or APCCs, but obviously there are disadvantages to using those two products. And there have been a lot of studies that have been done by the company, the 1001, 1002, 1003 studies, where they looked at the use of this product initially for safety, efficacy, and PK, and then also in patients undergoing surgery and for patients on prophylaxis, which was done in the UK. And in all of these, it was found to be very safe, efficacious, and tolerable. This is their initial study, which was given on demand, and they found that with just a few infusions, they were able to get an excellent bleeding control in more than 90% of patients. So just like we have recombinant factor or plasma-derived factor concentrates, similarly, this plasma-derived factor 10 concentrate gives us very good bleeding control. It's fairly safe. There's hardly any complications that are seen. The only complications were some fatigue, a little bit of erythema seen in 2 patients, and infusional pain that was reported. The other adverse events were things like headache, arthralgia, nasopharyngitis, upper respiratory tract infections, and some nausea that was seen. The PK data shows that it has a half-life of about 30 hours, which is really good, and you can manage most bleeding episodes with only 1 or 2 doses. When we're using it for surgery, there's data that has been done, and this is a small study where they evaluated 5 patients who underwent different types of surgical procedures, and the dose for pre-surgery was a loading dose to raise the factor 10 level to 70 to 90 IU per deciliter, and in the post-surgery period, if it was a major surgery, we maintain the factor level above 50 IU. And so I'm going to just go over quickly a few cases. So this is a 24-year-old male who was riding on a motorcycle 3 years ago, and he developed pain and swelling on his thigh after a mild trauma. And the thigh swelling continued to increase, and in fact he had a fall in his hemoglobin, and he was admitted with a muscle bleed, and he was evaluated to see if he had a fracture, but he didn't have a fracture. He was bedridden and immobile, and he received several days of FFP and packed RBC. When he came to us, he had a large, hard swelling of the thigh, which had been increasing over time. He was unable to walk, and he was in a wheelchair, and he had a very increased circumference of his thigh. On investigation, it was found that he had a pseudotumor and that he had factor 10 deficiency. And we wanted to do surgery for him, but we couldn't do it with the FFP coverage. He was given a dose of APCC, and he developed an allergic reaction to that. APCC can lead to allergic reactions. Rarely, it's not very common, but there are a few patients who can get hives and itching. And he was then given factor 10 at 25 IU per kg, and the surgery was performed. He was given the factor 10 on alternate days during this time, and a lower dose of factor 10 was given during the physiotherapy. This is another case. This is a 22-year-old who had factor 10 deficiency, and she was training to be a nurse, and she lifted up a patient, and she developed a shoulder hematoma. It was a large indurated mass. She did have a fall in hemoglobin, and she was suffering from a lot of pain and weakness, and she was given a single dose of factor 10, and this resulted in a complete resolution in a few days, and since then she's actually had no sequelae, and she received this factor 10 about 6 months ago. So this is a very effective product, and I think we're running out of time, so I will just quickly go over this last case. This is actually a case that I got from an article, because we haven't gone through pregnancy as yet, but I was reading this because we have a patient who we're planning a pregnancy. So there's a 29-year-old woman who had previously had an abortion, and she had been put on APCC prophylaxis every 4 weeks. And at 34 weeks of pregnancy, she presented with labor. So she was actually managed during the pregnancy with APCC. And then at the time of delivery, she was given APCC, but she still had some blood loss. And after that, because we know that there is a risk of thrombosis with APCC, she was then switched to factor 10 at that time, and postpartum she was maintained, and she had no further abnormal bleeding. So this was a case that was a recent case of a woman of factor 10 deficiency who was managed. And just to let you know that there are several variable courses during pregnancy, so it's something that is an evolving area of research, and I think in India we can definitely contribute to this, and maybe functional assays may be required. So to summarize, factor 10 is a rare but serious condition. We know that even rare diseases are not so uncommon in India. It's important to diagnose these patients. It's important to collect data on these patients and to understand their variable bleeding phenotype. We now have good therapy, including factor 10 concentrate, so I think we can make the quality of life of these patients better. Thank you.
Well, as we all know that the factor 10 deficiency or the factor 10 plays a very important role in the coagulation cascade, and you have covered all the relevant points in your lecture, in this conversation. Thank you very much, Dr. Tulika ma'am, for the wonderful talk, and we have learned a lot out of all this. Any question is most welcome.
Are inhibitors reported, and in your 35 case series, do we have that? And
okay, so the 35 cases I talked about were all congenital factor 10 deficiency. Yeah.
No, so do we? Is like?
Oh, you're talking about the etiology of them.
Like in hemophilia, we develop inhibitors, and even in factor 13 congenital, we develop inhibitors. So is there something like this happening in factor 10?
I think we'll have to wait and see, and I think that's a really good question because we don't really have much data. Factor 10 concentrate is a relatively new product. We have mostly used 1 or 2 doses in patients, and at the moment we've not seen inhibitors, but again, I think it's important for us to collect the data to see. Yes. In fact, several surrounding states have it freely available.
Audience, sir, Dr. Nikam.
Madam, you are lucky enough, it is freely available here, but about 2 months back, 1.5 months back, one patient was in Riva Medical College, admitted, and they have asked factor 10. In the midnight, I was called. In my registry are known patient. There was no factor 10 deficient patient. So in the night, I have messaged to sir, where factor 10 will be available. In the meantime, I have conveyed Dean Riva to collect FIBA and give. That was available with the Indore. That was shifted 15 while. In the meantime, sir has given address of this factor 10 people. They have supplied only one because it is very costly. That was some political issue also. पेपरबाजी हो गई थी, वहाँ election चल रहे थे. Opposition leader was visited in the Riva, taken the photograph of that patient and circulated in all newspapers. In the home district of the deputy CM, who is looking after medical and medical education department, hemophilia is not being treated. So.
No, I think this is really important, and certain states, like I know that UP and certain states are doing a very good job with having the whole repertoire of factors that are available in India in their pharmacy. And I think that's really important because now medico-legally, if there is a product available and if we don't have it, it actually puts us in a problem. So it was actually better when we didn't have it because we could say it doesn't exist. But now that it does exist, I think it's important for the states to ensure that they have some for emergencies because it's available now. Right? Thank you.
As of today, in many of the institutions like ours, we manage the rare bleeding disorders with FFP or cryo, whatever.
Right.
Because financially.
No, see, FFP is always very important. Now we even have factor 13 concentrate, but most of us are still using FFP. So the advantage of FFP will never go away. And in certain bleeding disorders like factor 13, where factor 13 half-life is quite long, you can still manage with this. But factor 10, the problem is the half-life is also short. So you can't like go a whole month with FFP. You can't do surgery with FFP. So that's where having a factor 10 concentrate for these patients actually makes a lot of sense. We have lost patients a factor 10 deficiency earlier when they had intracranial bleed, and we would keep giving them FFP. They would get fluid overloaded, but we couldn't save them.
An option between fever and FFP, what would be a
So there are advantages, disadvantages to both. The the APCC you can give to a certain degree. It does have factor 10, but you are walking a very tightrope. So if the patients where we have to give APCC in a condition like a factor 10 deficiency, I would ask my laboratory people to do a TEG, because then you are kind of sure whether you're going towards bleeding or towards thrombosis, because even though we are all afraid of bleeding, but actually I think many times the patients die of thrombosis. So you have to be really, really careful when you're using combinations or when you're using, these kind of products in this situation. So thrombosis can be fatal.
Yeah, the rare factors are available, but they are pretty on the higher.
Absolutely, I'm completely agreeing with you. We also mostly go with FFP and APCC. In few cases, we are using factor 10. Few cases.
We'll move on to our next talk. It's about inhibitor patients, role of factor 8 inhibitor bypassing agent in on-demand and surgery in case of congenital hemophilia A with inhibitors. Over to you, ma'am.
Okay. Yeah, my slides are visible. Can you project the slides, please? Okay. Thank you. So one more talk. So APCC hasn't been talked about too much today, and I think we all have used APCC a lot earlier on, and I think we shouldn't forget our old friends. So these are a disclaimer. Okay. So now we all know what inhibitors are. I'll kind of skip over some of these because we have a very learned audience and we don't have many students here. So we know that when inhibitors happen, then they make your clotting factors not work. We know that there are different incidences of inhibitors in different populations, more common in hemophilia A than hemophilia B, and more common in severe hemophilia than in mild or moderate hemophilia. There are many factors that relate to the development of inhibitors, of which the most important are the genetic risk factors. So if you have a family where there's a family history of inhibitors, then you definitely need to be worried about it. So this we're all aware of. I'll skip over this. We also know when to test for inhibitors during the initial exposure, or if there's been a surgery or inflammation and you've been exposed to inhibitor, or whenever there's suboptimal responses. And we can, whenever there's suboptimal responses, we can diagnose these patients. So first of all, do a screening test or a mixing study. If the mixing study is positive, then you can go ahead with the more expensive and elaborate Bethesda assay to diagnose the inhibitor titer. And we know that one Bethesda unit leads to 50% reduction of the factor. So now once we know that we have an inhibitor, what do we do? So the clotting factor concentrates, whether standard half-life or extended half-life, are now not going to work, and we know that these patients have more risk of bleeding, and their quality of life definitely goes down. And whenever you have a bleed in such patients, you need to know whether you're dealing with a low titer or a high titer and manage accordingly. If you have a low titer, low responder, you may use higher doses of factor 8. Not a good idea to challenge a factor 9 patient, but if they're not having any allergic reaction, then you could. But if you're having surgery, then even with a low titer inhibitor, I wouldn't really risk it. I would probably go for a bypassing agent. And if you have a high titer that's a more than 5 Bethesda unit patient, then you should always go with a bypassing agent. So that's pretty much the treatment that we would do. Immune tolerance induction is something that is difficult and now being done less commonly. And we've had a lot of discussion on emicizumab, recombinant factor 7A. These are all different options that are available. The ITI, of course, is the standard of care for eradication of the inhibitor, but obviously not for treating a bleed. So when you're having a bleed or you're planned for surgery, what can you do? There are only two things, and that's you can use bypassing agents. And bypassing agents, we have APCC and we have recombinant factor 7A. So the acute bleeds can happen even in patients who are undergoing ITI, or they can happen spontaneously, and APCC can actually be used prophylactically, so it can be given every alternate day, either during the ITI or in patients who have inhibitors and are high bleeders, and additionally it can be safely given in patients who have inhibitors and are planned for surgery. So in surgery, what you have to do, it's been beautifully discussed by Dr. Aryan, so I won't go into, Dr. SP, so I won't go into those details. But when you're planning for surgery, it's important to, in a patient with inhibitors, it's important to, just like we plan out for the factor 8 or factor 9 for a non-inhibitor patient, similarly, you have to plan out the bypassing agents that you're going to need for surgery. It's important to understand if the patient with the inhibitors responds better to one of the bypassing agents or the other. Majority of patients will respond to both. We also have WFH guidelines which tell us that we can use alternate APCC and recombinant factor 7A in case there is poor control. But as I said, the majority of patients will respond to both of these products, and there have been many surgeries done with APCC, and the majority of them have a good or excellent outcome. In orthopedic procedures also, you can use either recombinant factor 7 or APCC. The results of these surgeries are easily available, and most of us have done surgeries with both of these products available. Sometimes the cost is an important factor. If cost is an important factor, then APCC is definitely more cost effective. The other advantage is because of the longer half-life, you can give it twice a day, and rather than having to give it in multiple frequent doses, because we all know sometimes in a busy hospital, one dose might be missed or delayed, and if you're using recombinant factor 7, that could be an issue. So this is some data of patients who were on APCC or recombinant factor 7, and as you can see, the many surgeries were performed using one or the other, and the outcomes for all of these were very good. So if you had to do surgery in an inhibitor, how would you choose what to do? So if you have a low titer, low responder, and you didn't have any bypassing agents, you could use higher doses of factor 8. If you had a high titer patient, you'd either, and they were plasma naive, you could use recombinant factor 7 boluses, and then after the first 24 to 48 hours, when the patient was stable, you could then switch to APCC. And if they were plasma exposed, and you could actually just start off with APCC, because that way you know that they're less likely to have an anamnestic reaction and have any surprises during the time of surgery. And if you have a hemophilia B patient, we prefer to go with recombinant factor 7 because the APCC does contain some factor 9, and these patients are at risk of having an anaphylactic reaction. So, are there any guidelines for the use of APCC in surgery? Yes, there are. So, it's important when you're looking at the patient to do a good pre-operative assessment like we would do for any other surgery patient. And depending on whether it's a major surgery or a minor surgery, you can choose your dose of APCC. For major surgeries, it's 75 to 100 units per kg. For minor surgeries, you can use 50 to 100 units per kg. And then you perform the surgery with this. If it is a very long surgery, like a neurosurgical procedure, you may want to repeat this after 12 hours. Monitor the safety of the dose, and you can adjust the dose if you're satisfied. If there's bleeding, you can maybe increase the dose in the next when the next dose is due. And if the bleeding success is good, you can continue with that. In the post-operative period, again, just like we have guidelines for factor VIII, there are guidelines in major surgery and minor surgery of what to do in the post-operative period, and the dosage of APCC is given every 8 hourly to 12 hourly in major surgeries, and twice a day for minor surgeries. So this way you can complete your surgery with APCC in case recombinant factor 7 is not available. Recombinant factor 7 is also approved and can be used in surgery, and many of us are using that. And similarly, you'd have a pre-operative dose surgery, and then post-operatively you'd have to give frequent doses, initially every 2 hours, then 2 to 4, then 3 to 4, and subsequently as needed. So APCC in surgical prophylaxis, as I said, there's a lot of data. So what exactly is APCC? It contains all of these factors in different concentrations, and it leads to thrombin generation. I'm not going to go over the clotting cascade, but APCC works in several parts of the clotting cascade, and that's one of the reasons why it can lead to thrombosis. The indications of APCC are hemophilia A and B patients with inhibitors, and also bleeding in non-hemophiliac patients who have acquired inhibitors as well. So these are the recommended doses in spontaneous bleed and in surgery and for prophylaxis. And as I said, this is one of the agents which can be used. There's a ProFIBA study where they've used it in prophylaxis in inhibitor patients, and it can even be used as prophylaxis for patients who are undergoing immune tolerance induction. One thing to remember is that the total daily dose should not exceed 200 units per kg per day. So it can be given usually in 2 divided doses, but maybe even in 3 or 4 divided doses, but the total dose should not exceed this much. So there was a large study where they looked at a registry of surgery in hemophilia patients with inhibitors, and there were 35 surgical procedures were performed at 19 different centers. These were all patients with hemophilia A or hemophilia B, and there was even a few patients with acquired hemophilia. And with the standard doses of APCC, they found that it was very clinically effective, and the majority of patients didn't have any problems. The mild risk procedures, there was 100% satisfaction and excellent results, and moderate and severe risk procedures had a very good, 92% had good, and 7% had fair. And the intraoperative hemostatic efficacy was again excellent. So these are the various different types of serious surgeries that have been managed very effectively. And since we're always worried about thrombosis, this is a large study where they collected the thrombotic adverse events for over 10 years, and they found that actually it was not that much. And so that was really important, and they actually found that the incidence was only 4 per 100,000, and there was only one patient that had a mortality in a 10-year period. And this was a very large study with the total units equivalent to 3,95,000. So even though we keep talking about thrombosis, I think if you follow the guidelines, follow the rules, you will actually find that it's not as dangerous as we think it is. So this is just another paper where they talked about the thrombotic adverse events, and they concluded that the adverse events were actually quite rare, and it may not be that bad. So the take-home message is that we know that inhibitors can occur, and when inhibitors occur, we have to be ready to manage these patients, and surgery in these patients is quite high risk. So make sure that you are prepared with the bypassing agents, and the 2 bypassing agents that we have in India are really good, and APCC can be used for many major surgical procedures, as can recombinant factor 7A, and if patients are plasma naive, we prefer recombinant factor 7A, and in patients who have been exposed to plasma, we can use APCC for surgery. Try to avoid APCC in hemophilia B unless you're sure that they haven't had any anaphylaxis, and in rare instances where we're not getting satisfactory results from any one of these products, we can actually use sequential use of this. So that's it. Thank you very much.
Thank you for the talk now. One query. I mean, in hemophilia patients without inhibitors, when we do surgeries, we do trough levels, peak level. I mean, what is the recovery? So when we are using this FIBA in surgical setting, how do we, clinical monitoring is there that we know blood loss. Like surgeons, most of the times they ask, what is the lab? How are we going to?
So the majority of times they tell us to just go by the bleeding. But in case you are very nervous, or you have a surgeon who's very nervous, you could use either a TEG or any other, or a thrombin generation assay in order to monitor these patients. So we often use thromboelastography, and that actually doesn't tell you it doesn't tell you any factor level or anything, but it just tells you if you are more towards bleeding or more towards thrombosis. And many ICUs and many surgeons, in fact, at AIMS, our cardiology surgeons, our trauma surgeons, ICUs, a lot of people use that, and that is another way that you can use it. So I think actually we've only used the TEG in one patient who had a brain tumor and needed surgery. He also had hemophilia. So that was a patient that we monitored just to be sure that we were kind of doing the right things. It was an inhibitor patient. So that's one way that it can be done.
Predominantly clinical.
But majority is clinical, but in case, as I said, you have a situation where you need to do it, then a TEG can be done.
Second query, with emicizumab getting more popular in inhibitor patients, where do you see the role of FIBA? Because even WFH guidelines says that you have to prefer factor 7 over FIBA in case of acute bleeding.
Yeah, so that is what but if you read all of the package insert of emicizumab, it doesn't say you can never use APCC with emicizumab. It says that you should use it with caution. So obviously if you have recombinant factor 7A, it's an easy decision. In case you don't have recombinant factor 7A, you can use it, but it recommends that you use only a total of 100 units per day. So here I said you could go up to 200 units per day, but they say don't use 200 units per day in a emicizumab patient.
Any more questions?
That's what, so a lot of time we face the situation, you have to have that high titer inhibitor patient on emicizumab, your surgery is emergent, and your Novo 7 is over. So we end up using FIBA, we start at 25 IU per kg BD or 3 times, and I think most of the time we are
Okay, so good, you have experience, wonderful, thank you. Okay, thank you.
Thank you. Thank you very much, ma'am.
Thank you for the talk, ma'am. For our final distillation session, we will hold a panel discussion quickly addressing the urgent need to create a uniform treatment policy and protocol for hemophilia care. The session will be moderated by Dr. Naresh Gupta, sir. I would like to call upon stage our esteemed panelists, Dr. Tulika Seth, Dr. Joseph Joan, Dr. Bilal, Dr. Varun Kaul,
Thank you for bearing with us. We'll not make it more difficult because we have a system. So we give a quote that this world is full of intelligent people who are full of doubts, and the stupid ones also who are full of confidence. So I think this session would go well. Before I start this session, those who want a certificate, there is a scanner just outside on the left side, white scanner. You scan your QR code and it gives you in real time your certificate. So now this particular session is need of the hour, developing uniform treatment policy and protocols for hemophilia care. All of you are stalwarts in this. And these are the kind of protocols we developed from the Haemophilia Conclave of 2023. So this was the first effort, but it has done some beginning. So based on this, let us move further, developing uniform protocols. Dr. Varun, we'll give Tulika a break for a little while. What do you say, Varun?
Sir.
Why do we need to develop this? You know, we are in a country which is a free country. Everybody knows the best. At least everybody knows whatever he knows is the best. And we think that it is my freedom. It is a democratic country. There was a conference on, WHO-led conference on antimicrobial resistance. And I met a Swedish professor there. He says, Dr. Gupta, all of you are pediatricians, many of you. When we have a child with a sore throat, we don't give them antibiotics. So he said, of course, I mean, they are viral ones and we don't, why would you give it? He said, no, I'm not talking about that. If it is bacterial, strep, we don't give it in all cases. I was taken aback because I said, you know, if I don't give it, they'll take me to consumer court, if not the high court. So it was natural for me to ask him, how do you manage? But like, you know, somebody will say there is a bacterial infection which has antibiotics and you're not giving it. He said, no, but where is the problem? We have decided. Who are we? He says, it is our group that has decided that we will not use it. The judges have nothing to do with it. The politicians have nothing to do with it. The administrators have nothing to do with it. It has something to do with the doctors. So it set me thinking that time, why is it we have so much of difficulty creating protocols? Of course, Indian Pediatric Association is very effective, but let's look at all of them. Why do you think it is so difficult?
Sir, very valid question. And first of all, we all know that WFH has already given guidelines for treatment of hemophilia worldwide. But those guidelines are very difficult to follow in all the settings, in all the different countries. So we need to have some country-specific, guidelines which can address this gap. The first thing when we have to talk about any treatment is primum non nocere. So first, do no harm. So when we are trying to manage these patients with the limited amount of resources, whatever we have available over here, and by which we can make their life more comfortable. So that can be, that is achievable. And probably, sir, that is what we have done with the HHCN guidelines. We have tried to, imbibe that spirit in which we can give the best possible treatment in the least possible resources with a scientific background behind it. So we have those tables, we have those action charts wherein we can follow them, depending on the region. So I remember we were discussing at that time the kilometer distance, but the kilometer distance is not everywhere, it will not be the same. So in Punjab, if you have to travel like 30 kilometers, it will be done in maybe 35 minutes, not even like that. But if you have to do it in Kashmir, sir will agree with me, in that mountainous region, in those terrains, or in Ladakh, that 30 kilometers is a 2 hours journey. So we have to have protocols and policies made on the basis of the geopolitical things. So that is what we have done in the guidelines, HSN guidelines, and probably that's the way forward by which we can look at giving the best possible guidelines in the resource constrained settings in our country.
Very well said. You know, just like a little while earlier we were speaking on specifications to be laid out with such clarity that if you want a EHL product, you will get it. If you want another kind of product, you will get it. So long as you don't put these specifications targeted to a given company or industry or a product, make it more generic. Similarly, what Dr. Varun has said is very, very relevant, that when we have guidelines, it should address the variations that occur across the globe, across the country, across the geography. So we can write down less than 5 kilometers, 5 to 20 kilometers, more than 20 kilometers. But it is better to write the average travel time. And as we were saying yesterday, in America, it is a standard practice that the distance is measured in terms of time and not here. Dr. Lika, even if we do it, we find it difficult to push. You know, like we have this thrust on generic medicines. Nobody wants it. We have 100 reasons for not doing it. We have protocols. If they're not going to be followed, there have to be some reasons for it. Or is it because I think I'm superior?
No, I think protocols are very important. Following guidelines, following protocols protects not only the patient, but actually the doctor is also. So it's the problems I think arise when we only have international guidelines and we don't have guidelines that are made in India by people who have good pragmatic experience and and a good standing. Sometimes in India, unfortunately, we see a lot of cut and paste things that happen, and there's something that you can't really follow. Then you sort of lose faith in them. But I'm a strong believer in following protocols. When especially they're made in India, because that sets up a good quality of care. Then the patient, if they move, they can go to another place where they get similar care, and not that what I think often happens is that when patients are dissatisfied, then they start criticizing doctors, and then the doctors also start criticizing other doctors. So we need to avoid that, and I think the best solution is to have guidelines and that are applicable to us.
What do you say, Dr. Kusuma?
So
you have your own region, you practice your, you think it will serve a purpose even if for that area we create a guideline. Our problem is, let alone the national, even institutional or departmental, we can't create a uniform guideline.
Sir, it should be a single policy throughout the country, sir. We cannot have specific things because it may further modify the very purpose, is what I believe. Even though I am a pathologist, I am to this hemophilia, I am a bit putting my baby steps now. But I have learned that one thing we should include is in the beginning itself, like maybe 5 or 6 doses after taking the treatment, we should get an inhibitor screening done everywhere. That's what is my opinion.
So like we have NCCN guidelines, it doesn't give you only one thing that you can do. So if we want to make guidelines, and as you're rightly saying, every center may be different. You may have some centers where they have multi-specialty facilities, ICUs and other things, and other centers may be smaller centers. But I think we can at least say, okay, 1, 2, 3 are the options that you can give for an acute bleed, for surgery, for other things, because of availability and other things. But at least you have given standards. So if somebody is using, for example, APCC for surgery, this is how they would manage it. If they're using recombinant factor 7, this is how they manage it. If they have a emicizumab patient, this is what they do. So at least they know that. And it's not like one thing only is correct. NCCN guidelines for any disease, it gives you so many options. So, and of course, their reason for doing that is so because insurance will cover those 10 different protocols, but here we can give 2 or 3 different things, and if you've done any of those, it's okay.
So these guidelines, the HHCN, also, you said, are more open. So it tabulates when it comes to the action tables, first choice, second choice, third choice. But even coming to that, there are a dozen variables that need to consider. Dr. Bilal, there is a problem. It is said that for following the guidelines, you don't have to apply your mind. And doctor is not happy saying that I have no mind of my own. I'll just elaborate. In our undergraduate days at AIMS, we had a student union leader. He was a real good leader. He wouldn't study, but he would boss around, and he used to write President AIMS. The director, Dr. Keswani, once he said, what does he think? President AIMS. He wouldn't write Students Union AIMS. He must have been bright. It's not that, after all, he got in there. After MBBS, he left and went to States. I believe he became a very famous pediatric cardiologist, and he has remained so. Right? And if you ask him, how did you become, he says, there are guidelines. In this sense, you have worked there, many of you have worked there. If you are doing your residency or fellowship, you are supposed to not go through Harrison all the time or that Nelson every time. You have to go through the patients. And when you go through the patients, they have a protocol for everything, whether you want to insert a line or whatever you want to do. And the senior teaches him to follow those guidelines. Because if you don't follow the guidelines, you will get into trouble. And following the guidelines, whether you qualify their exam or not is not the matter. You become a specialist. There they don't apply their mind, they say. Is that right?
I think the
applying mind is one of the barriers.
That's true, but the people who have made the guidelines, they have applied their mind, na? making the guidelines. So indirectly, it is the mind of the experts. He is utilizing by using the SOP, and the guidelines are not in a way that it is randomly made by somebody, which is not expert. So that will also give a good thing. I mean, if a guideline is there, there will be less confusion and less pressures to the doctors, to the patients. I mean, the patient cannot dictate, doctor cannot dictate, and a uniform policy. It should be transparent, and it should apply to whole country. And then the job of a doctor will become much easier to deliver the health care. That is a better thing if you have a one policy and protocol in the country.
So it is important, and there are many benefits also. There are many benefits because if you have uniform guidelines, then over a period of time, no court, no consumer court, nobody would be wanting to take you to court. They cannot, because it is a consensus guideline. And even the Honorable Supreme Court of India has said, in medical matters, we are no good. Even the administration says we are no good when it comes to making guidelines. So that is what we were saying. When it comes to getting your products available in your center, nobody will say it unless a doctor has signed it. The problem is, as doctors, we are compulsive applier of our own mind, and we think it is better if it differs from the other.
Application of mind is not based on somebody's his or her own experience. The guidelines which we have submitted, the HHCN, it is not one person's. This is based on the observations and experience over the years following their own patients. You see, we have so many classifications. We had earlier leukemia classification, someone else. But now, thereafter, we have WHO classifications. But there is not a single name. What these classifications are, these are based on certain observations, their experience, and evidence is there. Similarly, these protocols and policies which HHCN has submitted will be a basis for, at least for North India, let there be someone else. If he or she or the collective team, they feel that we have followed these guidelines and we have found these, because our teacher used to say, every patient is not a textbook. There could be variations. So we will have an intercommunication from one center to others, and accordingly, if there are anything and evidence-based, we can modify it. So at least these are the protocols and policies where Sir has equally said that no one can challenge it straight away, because it is not a single person. It is not it is based on evidence, observations over the years and their own experience, and thereafter, after discussions and thread-based discussion, and then only we have come to the these conclusions, opinions.
Well said,
we have not.
I would go to the extent of saying it is not frequently that a patient is textbook picture.
Yeah.
Yes, sir. Yeah, please.
Sir, one thing, when I have conducted this last year conference, I have made some guidelines among us, because we are facing day-to-day problem in different guidelines, WHO recommendation, and that whatever it is, that concentration is not available with us. I have made from your protocol also. So we have made at our institute, these are our guidelines. Now we will follow HSCN. That will be that fitting in our Indian scenario. And second thing, Madam was saying about the criticism. I want just to make, because at present I am also heading, looking after the charge of Madhya Pradesh Medical Council. If there are thousands of cases, at least 900 cases, some doctor is involved, who is saying, तुम्हारा ट्रीटमेंट गलत हो गया, 6 घंटे पहले मेरे पास आ जाते, 10 दिन पहले मेरे पास आ जाते तो तुम ठीक हो जाते, बच जाते, आपकी टांग नहीं कटती, आपका एम्पुटेशन नहीं होता. So, Madam has rightly said, we should not criticize, and these guidelines will protect us. हमने ये गाइडलाइन WHO से पढ़ के अकेले नहीं बनाई है, WHF की गाइडलाइन नहीं है, हमारा अपना 30-30 साल का एक्सपीरियंस है पूरे ग्रुप का, उनने गाइडलाइन बनाई है, अपने डॉक्टर्स को प्रोटेक्ट करेंगे. तो ये गाइडलाइन बहुत ज़रूरी है सर, और बहुत अच्छा काम किया है, हम उसको फॉलो करेंगे.
थैंक यू.
एक मैडम ने और सक्सेस की बात करी है अपने ग्रुप में, तो व्हाट इज सक्सेस? आई हैव हर्ड समवेयर, सक्सेस इज मेकिंग द बेस्ट एफर्ट्स विदिन द कंस्ट्रेंट ऑफ टाइम, स्पेस एंड मनी. सो दैट इज.
Thank you. Thank you. Thank you. So let me add one thing which we did not elaborate upon during the inauguration. HHCN has also come out with a policy statement. We believe in how to achieve what we intend to achieve, and after defining what should be achieved. So one of the statement is the guidelines done by anyone should be circulated. And it should be circulated for a feedback. Nobody is perfect in the first attempt. It should be circulated for a feedback, for their opinion. If they are party to it, then the acceptance will become more universal. And finally, the guidelines differ from scientific research. We keep talking about the evidence-based, because in scientific research, there are a given number of parameters that you can study, maybe 1 dozen at the most. Usually it is 3-4 primary objectives. In real world experience, that also goes to the guidelines. As you have seen, that the parameters that are not studied in scientific research can be covered from there. And finally, there is this Delphi technique wherein everybody has their own wisdom. We don't want to undermine that wisdom. We don't want to say, follow these guidelines, don't follow your wisdom. So the combination of all these three, in my view, should go towards framing those guidelines. I'm being told the time is. Any final statement? No final.
So I just wanted to share real life stories of two kids who come across to me. So one of the children, he had an IC bleed in his infancy, and we had to salvage him by giving factor 8. And while he was on the continuation part of the therapy, his venous access was a little bit difficult, and he was on levetrestam and he had seizures and all. So we were able to salvage him. Now his father comes to me, please give me emicizumab. I said, we don't have a policy for giving emicizumab right now to you. The child has to be inhibitor positive. So he said, कि मेरा test करा दो, बच्चे का test करा दो. And because he had a high dose exposure, we sent him to PGI. He turned out to be inhibitor positive, and the father was very happy. Father was very happy that my child has inhibitors, now he will get emicizumab. And right now he's on emicizumab and he's fine. Now the question comes, now there's another kid who is inhibitor positive, but low titer inhibitor positive, and I happened to give him a challenge of factor 8, and he responded. And I told him that we will give you factor 8 for some time and we will reassess your antibody titers. If it is dropping down and he's responding to factor 8, I'll put you on low dose factor 8 prophylaxis. He says, please give me emicizumab. He was inhibitor positive, now he is responding to factor 8, इसमें मेरी क्या गलती है? Now this is the problem, sir. This is the problem which we are facing, and really. So why we are not able to give at least all kids the drug which they require? That is emicizumab, by which they can be saved. So we were talking from the morning till now, we are talking about emicizumab only for inhibitors. But these are two case scenarios which are in front of me, and the parents are happy कि मेरे बच्चे को inhibitor है, और हमारी जान निकले जाती है कि बच्चे को inhibitor है.
Basic problem with this is the daily bread and weekend dosing. ये तो torture है. It's not torture for the child, torture for the parents also who are witnessing. And God forbid, it's somebody who is not enough trained for this, and you know what happens. So therefore, once a month, subcutaneous.
There are many therapies which will come in future, but this is just a question of ponderance. Like there are two scenarios in which, when we are, not happy about the diagnosis, the parents are happy.
But don't take it as a challenge or a problem. I will end it with a real life anecdote. It is anecdote also, it is real life also. I was set to set up a department in a friendly country during my surveys. So the hospital was for the royalty. It was for the common person also, but for royalty there was a separate wing where there was gold studded things and all that. So one of the royalty member, the senior one, got hospitalized. And we were asked, sir, put a monitor on him. I said, but it does not need a cardiac monitor. He said, no, put a monitor. There are two ways. It's either like my son who says, I'll tell them, go to hell. I don't have a spare monitor, I have poor man to treat, so I'll not give it. I said, shouldn't be like that. What did we do? We said, take the monitor. Laga do. But we were wondering, it was a learning experience for us. It was not a difficult time. We were wondering, why would he want to have a monitor for a person who doesn't have a cardiac problem? He has a fever, his heart rate, ECG, BP, everything is good. Why would he want to have this? Then it turned out that they have a attendant. And the royalty has told them, keep looking at the monitor. If it goes flat, give me a ring. We have things to sort out for posterity. So thank you so much. Enjoy your evening. Yes, Dr. Anand, come.
The next event is about to start. I am Calcutta, I am bahar wait kar rahe.
So thank you so much. Have a nice evening. I hope, and do give us feedbacks. hhcn.in. The whole thing was telecast live, and on YouTube you can rerun it.
How do they know so much?
Oh yes, you can come here.
Yes, yes, group photography. Please come for a group photo.